Dear colleagues and partners, leaders, community members, TB survivors, Namaskar and welcome to the India TB Summit 2022. It is my pleasure to welcome you to join us for the second edition of the India TB Summit, hosted in partnership with the Indian Express. The world has changed in more ways than we can imagine. The pandemic has made us realize our immense vulnerability, but also our collective strength. We can only defeat the challenges that confront us today if we come together. The challenges in TB, but more broadly in health, are now staring us more clearly than ever before. Inequity, inequality, and lack of access. This summit is a response to the challenges that we have witnessed over the last 2 years in fighting TB amidst the ongoing COVID-19 pandemic. The pandemic and its impact on TB and also other diseases has made us realize that the focus on cure is insufficient. We also need to think about prevention, access, equity, and affordability, whether it be TB or COVID-19. We are at a turning point in history. We have to see and examine if our approaches and tools, not just for TB or COVID-19, but all healthcare, are they sufficient or not? Are the current approaches people-centered, and do they put the individual and the community at the center of their efforts? The truth is that comparing TB to COVID itself is like a study in inequity and injustice. A centuries-old disease which has just one vaccine, and a relatively new and recent disease where we are almost spoiled for choice. A centuries-old disease that is curable, but those affected are still asking for access to new diagnostics and new drugs. Those affected who cannot still access treatment because it is either too expensive or they feel too stigmatized by their communities, by their families, and the health system. Really, the question that this summit poses before us is, have we done enough for the TB affected? In TB, the time has come for all of us to come together and collectively rethink and redesign TB care, not just in India, but also elsewhere, to ensure justice and equality. Hence, the theme of the summit this year is redesigning TB care for equity and access. As always, the summit brings together leading national and global experts, survivors, advocates, to form and lead the discussions and the sub-themes of this event. You will hear from all of them, but most importantly, you must remember the stories of millions who are forced in silence and suffering due to TB-related stigma. The summit represents their voices, their needs, and their demands. Every aspect of this summit has been developed with inputs from survivors and communities. In a 2-day rigorous program, the summit will bring together communities, experts, clinicians, public health workers, policymakers, researchers, and advocates. Through these efforts, we hope to engage in inclusive discussions and combine diverse perspectives and create awareness through an independent public discourse around TB. Most importantly, we seek to put those affected by TB at the center of all our strategies and efforts. Every panel has been independently curated by the chairs to ensure academic rigor and independence. And every panel has a community representative because without their inputs, no solutions are possible. We are extremely grateful to our academic committee as also our chairs who have, despite their exacting schedules and timelines, curated a robust and thought-provoking program ensuring diverse participation and perspectives. We're also grateful to our supporters who continue to understand and effortlessly support the value of an inclusive national forum such as the India TB Summit. But most importantly, we are grateful to the TB-affected individuals and communities who have, over the last several decades, shared with us their lived experiences, their stories and experiences that inform all our strategies and efforts. We salute your courage, your commitment, and your hope. I want to end by saying that this is more than just a forum. This is an opportunity to bring together issues, approaches, and innovations, but also people in an inclusive way to generate transformational change and ideas and thought-provoking discussions. Every person's input is important because all of us need to work together to end TB in India. With these words, we agree to argue, to disagree, and to challenge each other, because without debate, no change is possible. I thank you again for joining us for this summit and look forward to your participation in it. Namaskar.
Good day everyone. I am Dipti Chavan, an MDR TB survivor, advocate and fellow with SATB. It gives me immense pleasure to be speaking at the plenary session for India TB Summit. Before COVID-19 arrived and devastated us, TB was India's severest health crisis. Even today, TB kills 1,200 Indians every day, and yet it is discussed in hushed tones. TB-affected persons are stigmatized and discriminated against and are often forced to suffer in silence. The COVID-19 pandemic has changed the way the world lives. It has devastated TB-affected persons and communities. Access, affordability, and availability of care were all significantly compromised. TB-affected communities still struggle every day. Yet see the contrast. A disease that primarily started by affecting the rich, that is COVID-19, saw billions in investment. TB has been with us for centuries, and very little was done in terms of investment and research in TB, even lesser so when compared to the amount of money that was spent on fighting COVID-19. Even today, we have one vaccine, that too 100 years old. Imagine if this injustice were happening to powerful communities. We would have seen it as a violation of their rights. Yet, very little is spoken about patients and their rights. Ever wondered why? We need to understand that patients are not subjects or statistics, but living, breathing people. It is their right and our ethical duty to explain their condition and not dismiss their concerns. It is not just the need of the hour, but our ethical duty to redesign the TB care patients are currently receiving. This care needs to be equitable and accessible, ensuring the highest quality to all patients. The TB care continuum needs to be transparent, taking community inputs at each stage of development and implementation. You cannot bring communities as a token gesture. They ought to have a seat at the table and be substantially involved. Otherwise, all efforts are bound to fail. This engagement has to be diverse, including in its fold TB survivors, but also communities of people living with HIV and marginalized communities such as the LGBTQIA that often do not get access to high-quality care. Survivors and patients need to be made equal stakeholders in policies and decisions in TB care by the government and by their health providers. You cannot make decisions for us. We have a point of view and we have a voice. An engaged and informed community is a community empowered to engage in beneficial care-seeking behavior. Investment and ownership in the drug development process is what would allow for better treatment outcomes and successful prevention initiatives. We need to make diagnosis, treatment more affordable and accessible for patients. We need new and more flexible forms of service delivery along with remote support. We also need better economic support programs for TB patients. The current Nikshay Poshan Yojana is not enough. The mental health cost of TB can be very high, and integrating mental health care in TB care is critical. This can be done by creating expanded mental health services and training healthcare staff and TB helpline workers in counseling, etc. To ensure that discrimination against TB patients and survivors is tackled, we need legal punitive action against discrimination. Please train healthcare staff to avoid class, caste, and gender based discrimination. As a survivor and a fellow with SCTB, I can tell you that peer and mentor support networks, as well as patient education groups, help patients adhere to treatment. The patient is the most important stakeholder in this fight. Fight the disease, not the person infected by it. Let us reimagine patient care by putting the person at the center of the care model and not the disease. Nothing about us without us. Thank you.
Hi. The last 2 years of the COVID pandemic have cast an enduring scar across humanity, one that will be impossible to delete. It wouldn't be exaggeration to say that COVID has been the defining global emergency of our eras. Here is a virus that has shut down the world, closed down our cities, derailed our economies, and in the course of 2 years, killed 6 million people and counting. We now talk of COVID going into an endemic phase, but TB is a disease that we've always considered endemic, one that has been there since the dawn of civilization. And the impact of these two ongoing syndemics, if I may put it that way, will be fascinating to understand as the decade ahead unfolds. So I never thought I would see a more deadly disease than MDR-TB in my lifetime, for example, an airborne disease that's more deadly. But the impact of this novel virus on this ancient bacterial disease has truly been devastating. Just as another virus, HIV, did to TB control 3 decades ago, the effect of SARS is almost certainly going to set back TB control several years. And what are the interactions, the synergies, and the impact when these two airborne diseases collide? As I said, one, tuberculosis, as old as human civilization, and the other, which was unknown till 2 years ago. And how do high-burden countries best equip themselves to navigate the tortuous path between controlling COVID without, at the same time, neglecting tuberculosis? And that is the additional impact of this virus on this disease, which has always been there because we've had billions exposed to TB, 2 billion who have TB infection, 10 million with TB disease per year, and TB still kills 1.5 million deaths per year. So when we talk about COVID becoming endemic, let's hope it doesn't become endemic like tuberculosis, which still kills with remarkable regularity. And tuberculosis had long been the world's leading infectious killer. But that dubious title on April 1st, 2020, went to COVID, when the daily death count from COVID outnumbered TB deaths at this stage. On April 1st, it overtook TB as the infectious disease killing the most people per day. And 2 years into the pandemic, where are we? 400 million cases and counting of COVID, which almost dwarfs the TB wheel into submission. But it is this overlap of these two diseases and the indirect effects as well of COVID on tuberculosis that we will be discussing here. So how is COVID impacting on TB? There have been delays in the diagnosis of new TB cases and much less active case finding. And that holds true for the developed and developing world. There's been a disruption to medical production, transportation, and supply. There have been great stockouts and delays in accessing both first and second line drugs. I'm talking especially of the early days of the pandemic. There's less staffing and therefore reduced care because most staff was purloined over from TB to COVID care. There's reduced support for the dreadful adverse effects and the comorbidities that can occur because of tuberculosis, delays in our patients receiving the financial and nutritional support packages, which are their rights, great shortfalls in BCG vaccine, and I've got a couple of slides discussing that a little later, and interruptions in HIV and TB HIV programs as well. So are patients with TB more prone to get COVID, and do they have worse outcomes from it? The verdict is not yet clear on these two very, very important questions. But most people feel that infection with TB is a more common comorbidity for COVID than the traditional ones like diabetes and obesity, hypertension, ischemic heart disease, and COPD. And in this study, in the early days from out of Wuhan, MTB infection was linked to the patient then getting more severe COVID, that COVID progressing more rapidly, poorer outcomes in dually infected patients. And they also wondered if latent TB infection would be an independent risk factor for susceptibility to SARS-CoV-2. And if that were true, billions of people would be more prone. And we just don't have the answers to this. Time will tell us. What about TB HIV, TB HIV and COVID? Well, TB with or without HIV was recognized as a risk factor, as I told you, for COVID-19. Patients with TB having more severe COVID in this study, higher mortalities from COVID, and the HIV infection were particularly vulnerable. So TB, HIV, COVID probably is the worst outcome, even more than TB COVID. And these diseases are so similar. As someone wise put it, COVID is like a version of tuberculosis on steroids. They share biosocial determinants, the four commonest being for TB, poverty, overcrowding, pollution, and diabetes. And check this list, they're also the most common four biodeterminants of COVID. And I put that up here in a slide from a paper we wrote a couple of years ago. And we called it the poverty trap. The social economic consequences of COVID will increase the number of people living in poverty by 500 million. Look, COVID has resulted in the rich getting richer and the poor getting poorer. It's estimated that the poorest 20% of the population of this world will take a decade to recover from the effects of COVID. They've been pushed below the poverty line. And as a result, this new poor are certainly going to be more vulnerable to TB because we know TB and malnutrition are potent risk factors for tuberculosis developing. So poverty and the impact of COVID will push an additional 104 million below the poverty line, increasing their vulnerability in turn to tuberculosis. And then there are the effects of the lockdown. Jayati Ghosh from New Delhi said this was the most destructive effects of COVID have not been the results of the disease, but the nature of our response. The most stringent lockdown in the world destroyed the economy, forced millions into poverty and hunger, but did little to control viral transmission. And I wish we had had this paper has just come out, January 2022, from the Johns Hopkins group. And I wish we had this knowledge 2 years ago precisely, when we chose one of the most rigorous lockdowns in the world, the longest lasting too, because these authors looked at the effects of lockdowns across the globe. And they showed us three important facts: that lockdowns have little or no public health effect, that they pose enormous economic and social costs where they are adopted. And they conclude by saying lockdowns are ill-founded and should be rejected as a pandemic policy instrument. As I said, I wish we had the power of hindsight. And how did our lockdown impact our TB patients? It changed their health-seeking behavior. Take your mind back to the early days of the pandemic. People were too scared to leave their houses. And even if they had dared to venture out, there was no public transport and they would have been turned back. It disrupted all health services qualitatively and quantitatively. It delayed the diagnosis, therefore, and the notification of tuberculosis. There was less testing. Where are all our gene expert machines being put to use at present? They're being put to use for COVID tests, because the gene expert machine is an ideal way to give a quick diagnosis of COVID, as ideal as it is to give us a quick diagnosis of tuberculosis. Treatment interruptions occurred for the reasons I talked about. Medical supplies, drugs, stockouts interrupted treatment. And we know that TB is one disease which does not bear any interruption. All this could certainly have amplified drug resistance, irregular treatments, delays in treatment, as you know, and increased transmission at home was probably occurring while our patients were too scared to leave and exit their houses. Perhaps the only good thing that lockdown did was that mask wearing increased, and perhaps mask wearing was destigmatized. So that is the only positive effect I can see from the lockdown. Perhaps, therefore, there was reduced community transmission of tuberculosis just because patients were at home too scared to leave the house. And when they did, they generally wore masks. But look at this precipitous drop in BCG vaccination rates. In March 2020, 260,000 fewer kids received BCG than in January 2020. And in April 2020, 1 million fewer children were vaccinated than the corresponding figure 1 year ago. That's frightening. So all this will come back probably to haunt us years and perhaps decades down the line. Notifications of TB cases dropped. These cases were always there, but they just dropped below the radar. TB notification rates in August 2020, for example, were 50% lower than 1 year earlier. Notifications dropped sharply in both the public and the private sector. And the causes of this are obvious. They are patient-related and program-related, as I've put up in this slide. And you can see with the onset of the lockdown how there was this sharp drop in the public and the private sector in terms of TB notification cases. The cases were always there, of course. They were just not being notified. They dropped below the radar. And this is from the latest WHO chart, which showed and compared TB notifications between 19 and 20. The monthly notification cases in 20 were 30% lower in India. 30% reduction in notification equals 3 million more people dying from tuberculosis. Treatment completion rates fell, and DOTS completion rates fell by 23,000 patients from Jan to April 2020, as you can see in this graph. And that is the TB report I made reference to. And they conclude that the COVID-19 pandemic is likely to leave a profound and long-lasting impact on TB diagnosis and control, leading to an additional 6.3 million cases of TB globally and an additional 1.4 million TB deaths between the next 4 or 5 years. And we were part of this study in the CDC journal. And we just showed that at the Hinduja Hospital, a very, very busy tertiary care center, our OPD TB visits just dropped by 2/3, and our inpatients fell by 2/3 when we compared them to their 2019 levels. So patients were obviously paying a price. And this aftershock will be felt over time. And these are projections by a colleague and friend called Nim at the Imperial Institute in the UK. And he guessed that each month of lockdown in India would result in an additional 40,000 TB cases annually for the next 5 years, and a total of 151,000 plus cases. That's 5.7% increase in TB deaths in India. And when I say guess, this was based on very, very careful mathematical modeling. What did we do? Well, we did our bit. We used telemedicine, again, one of the possible fringe benefits of the lockdown. We use telemedicine to the benefit of our patients. Each crisis is really an opportunity in disguise, isn't it? And this was published in Lung India, where we use telemedicine to reach out to a cohort of the most difficult, most drug-resistant XDR-TB patients we had on precious bedaquiline. We did not want to let them lapse. We did not want them to not take their drugs for any reason. And we managed this cohort, thanks mainly to one of my very competent registrars, Samriddhi Sharma, we managed this cohort of 30 patients remotely through the lockdown with regular teleconsults, and we kept questioning them about new complaints, drug reactions, adherence, bedaquiline. Directions were given, ECG monitoring was done, prescriptions were given. It is possible to do all these things online, as we've all now discovered. And after remote management like we did through the lockdown, I was chagrined to find that 68%, when we polled them later, said they preferred the convenience of telemedicine to direct contact. Driving through 3 hours of Bombay's traffic to reach Dr. Udwadia, who has a minute or two, unfortunately, only to spare, perhaps this was more convenient. And of course, 27% still preferred a direct interaction face-to-face across a table, and 5% they said they had no particular preference. And I think these are my last couple of slides. And I've put up provocatively, what if we tackle TB like we have tackled COVID over the last 2 years? With the considerable overlap between these diseases, what if we merged the detection, the contact tracing, and the infection control programs? We destigmatized masks. We had bi-directional screening and active case finding. We leveraged all the community care workers currently searching for COVID cases to consolidate and complement active TB case finding. We've often talked about active TB case finding, going out and finding your tuberculosis cases in the community. But we've never really got round to doing it. Perhaps we could. What about integrating the use of testing platforms? And I've given you an example with the Gene Expert platform. And most important, speeding up the new drugs and the vaccine trials. We've seen this abundance, this profusion of TB drugs which have come out, of COVID drugs, I beg your pardon, which have come out over the last 2 years only. And yet the TB drug pipeline has been so glacial in its progress. Look, for TB, we have a single old dinosaur of a vaccine, which is over a century old, while with COVID, we have an abundance. We have 33 approved vaccines as of today being used across the globe for COVID. 10 have got WHO approval. 197 countries have approved vaccines. And there are so many further vaccine trials, vaccine candidates, and countries where vaccine trials are taking place. And on the TB side of the balance, we have just one old vaccine whose efficacy has always been questionable. So let me end with this quote: lest we forget, COVID-19 is a wake-up call to a health system, and she's talking of TB, that was already underfunded, overburdened, poorly staffed, wasteful, and provided care of questionable quality. Without a robust and responsive health system, we can neither hope to eliminate TB nor weather the COVID-19 storm. And I couldn't hope to end on a better note than this quote from Lucia Ditiu, the director of Stop TB. Thank you.
Greetings from the World Health Organization, and thank you so much for inviting me to speak at the India TB Summit 2022 with a topic that resonates a lot. It's called Ending TB Together, the Need for Equitable Approaches. I think we're all familiar with the current statistics around the TB pandemic. Last year, we had 10 million people developing TB in 2020, but only 5.8 million were diagnosed and reported. And this is an 18% decrease from 2019. And this was particularly concentrated in 16 countries, including some of the large Asian countries like India, Indonesia, Philippines, as well as China, which are the countries which which also had major COVID outbreaks and healthcare service disruptions. TB deaths have also increased, probably because of reduced access to healthcare. And we know that in 2020, there were roughly 1.5 million TB deaths reported worldwide. And this is very notable because it's the first time that we've seen a year-on-year increase in TB deaths since 2005. We've also had other negative impacts, like a 15% reduction in the number of people treated for drug-resistant TB, a 21% reduction in people getting preventive therapy treatment, as well as an overall reduction in TB spending globally from 5.8 billion to 5.3 billion. And therefore, it's of great concern that we're going to be off track for the SDG targets, and certainly in India for the very ambitious 2025 elimination targets. If you look at specifically the data from India, apart from the reductions in case notification, we also find that looking at the treatment success rates, of course, this predates the pandemic. So we have data from 2019 cohort. We had a success rate of 84% for new and relapsed cases, but only 56% for MDR TB cases and only 48% for XDR TB cases started on treatment. And for HIV TB as well, this was around 71%. Now, we know that there are a large number of MDR and XDR TB cases that are probably missed. And even of those starting treatment, only about half are having a successful outcome. So this is again of concern because clearly it means that we are not managing MDR and XDR TB that well. The other thing which is worrying, of course, is that we know that the pandemic has pushed at least 100 million more people into poverty, and that we know the links between poverty, undernutrition, and TB are particularly marked. And in India, it's estimated that about 50% of the risk factor for TB is actually attributable to undernutrition. Globally, this is about 20%. So we also are aware of the gaps in terms of regard to prevention, diagnosis, and treatment. And these are important because they are informing us about the research needs. So, for example, for preventive therapy, clearly we need more specific sensitive tests for TB infection. We need better biomarkers that tell us about the progression, the risk of progression of disease from infection to active disease. And we need better treatment options for the contacts of people with both drug sensitive as well as drug resistant TB. So big gaps, and there's a lot of scope for research, for example, including new vaccines that could be used amongst household contacts for prevention of TB and also simpler drug regimens. And of course, we are facing big gaps in using the existing tools we have, and we need to scale those up. Systematic screening, I think the bidirectional screening that started with HIV and diabetes and then has been extended to COVID. I think that's a very good approach really to the detection and management of respiratory diseases as a whole. And so I think if we can think of an integrated approach when somebody presents with a cough, then what sort of algorithm does one use and how does one actually solve the problem of the person or the patient? Because clearly the approach the TB program uses is to find out TB cases, but actually what the person and the patient is interested in is a treatment for his or her symptoms and underlying illness. So again, bringing together NCD screening like hypertension and diabetes, along with TB, COVID, or other respiratory infections, because we know that early diagnosis and treatment is important for all of these conditions. How do we maximize the use of our health workers and our community health workers? And also keeping, again, the person at the center of it. The person has one body, would like to have all of their health issues addressed at one point of contact and not having to run around. As it is, we have so many people with undiagnosed and undetected hypertension and diabetes. So again, these are important opportunities for integration of services at the primary healthcare level and below. In terms of detection, we know that not everybody is getting access to a molecular test for TB and a molecular test for drug resistance. This is important. We have indigenous technologies like TrueNat now that are WHO approved. And so I think also more research is needed on point of care tests using saliva and other specimens as for easier testing for TB, just like we were able to do for COVID. Now we have rapid tests which can do at home and self-diagnose COVID. So of course, we're still far away from that, but we know that globally a rapid molecular test was used as an initial test in only 33% of 5.8 million people who were diagnosed with TB in 2020. And again, on the treatment side, we still need to continue to do clinical trials, innovative designs to try and shorten treatment regimens, to try to have better acceptable regimens which are safe, which don't cause side effects, and which are easier to take. Again, keeping the patient in mind. The tolerability is really important, including for pediatric age groups. We have learned a lot of lessons from COVID, and the one lesson that we've learned, I think, is firstly that science can find the solutions, that we have so much of advance today in science and technology that we will be able to find a solution. We just need to work in a mission mode, and we need to come together and have a common objective, and then be willing to share data, share knowledge, share information, of course, put funding and resources into doing the clinical trials and the operational research that's needed. And high burden countries like India can really take the lead in this space. The second lesson, which is a sad lesson that we've learned, is around the equity, that even if you are able to develop COVID vaccines and therapeutics, we have not been able to provide access still to billions of people around the world. And I think TB patients are some of the most marginalized, belong to the really vulnerable and high risk and marginalized groups in every country. They're the poor, basically, and the people who have least access to services. And so it is our responsibility to ensure that whatever advances in TB are made, that the first people who should benefit are those who are usually at the back of the queue and who have, the least amounts of not only money, but also health literacy. And therefore, we need to keep equity at the heart of everything we do for TB, involve the patients, involve the communities. We have a vibrant NGO sector that is working and that has grown from strength to strength. And again, because we're speaking around Women's Day, I would like to say that the contribution of women, particularly the frontline workers, to the whole of TB control really needs to be celebrated. And whether they are ASHA workers or Anganwadi workers or our BHNs, nurses, doctors, I would like to salute all of the frontline workers as well as the community volunteers and others who've been supporting the fight against TB. So I hope that this summit will re-energize us, will bring us together with, again, a renewed determination to win this battle against this very age-old enemy that we have. We've won trying to win the battle against a new virus, and we need to put the same energy into fighting tuberculosis. Thank you very much.
Namaste, good morning. It's a pleasure and honor for me to be a part of this wonderful get-together and summit that all of you have put together for TB and gender issues, both very close to my heart. TB is something we saw when we were children, and fortunately, whichever government is in power doesn't really matter. But there are some programs which we have no political differences on, and TB being one of them. And subsequent governments have worked together and worked very hard to eradicate TB from our country. But still there are several numbers which still do exist. I'll give an example of polio. Polio was something I do remember as a child. In school you would see 1 or 2 children with polio. Now fortunately we have won the war against polio. Now we have to win the war against TB, tuberculosis. And I do see in several situations that gender sometimes does become an issue with patients who are tuberculosis. And it's seen because I work on gender issues. There was a time when I was growing up, we were not talking about the LGBTQI community. But times have changed, we have evolved as a society. And I'm happy to see there are so many people are actually talking about these issues very openly. So I congratulate the entire team who has put this entire summit together, which talks about TB and gender. And it becomes slightly complicated here medically for the reason that there are some people from a certain community, it doesn't matter which one it is, but there are HIV cases, and TB cases. So now people who probably have HIV are far more vulnerable to TB. So it becomes a little more complicated scientifically. So we need to work harder. We have to be very, very sensitive towards TB patients, and even more to people who have emotional issues, also with gender issues. For last 2.5 years, under the leadership of Shri Uddhav Thackeray, Shri Ajit Pawar and Balasaheb Thorat, we have managed in Maharashtra, in the Mahavikas Aghadi government, to put a group together, Mr. Dhananjay Munde, who happens to be the minister of that department, for an entire community and a full community of this entire community together for the LGBTQI community. And we want to understand their issues and we want to address them. So this committee is not just about flagging issues, but it's flagging, tracking them and resolving them. And we have got people from all these communities together on this committee, and we will be discussing TB also. I'm so glad and grateful that you all have brought this to our notice. Mahavikas Aghadi government in Maharashtra is totally committed to working with your entire team to eradicating TB from our lives. Besides that, any issues you want me to raise in Parliament, I'd be happy to. I'm an elected representative from Baramati, which I'm very grateful and proud of. But beyond that, I do speak the voice of Maharashtra and India in Parliament. So if there's anything more I can do for the community or for anything or any fight against tuberculosis, I'll be more than happy to assist you all, support you all. So let's raise our voice, and we are going to win this war. We fought the COVID war, and we are on the verge of winning that war. There are no differences here. It's the virus versus us. The way it was polio versus us. This time, it's TB versus us. And I'm very, very sure with all these wonderful interventions during this summit, together we will come with a roadmap and we will fight the gender issues and we will fight this war against tuberculosis. Thank you so much from the bottom of my heart to each one of you who thought of inviting me today and making me a part of this very important program, which probably will be a turning point of a new and a beautiful beginning. Good luck and best wishes to your program. Thank you.
Good day, friends, and a warm welcome to the India TB Summit 2022, ahead of World TB Day, where we remind ourselves yet again that there is so much work to be done to get a grip on this diabolical scourge of mankind. My name is Camilla Rodrigues, and I come from the Hinduja Hospital in Mumbai, where I work as a consultant microbiologist. And together with Dr. Puneet Diwan, we are chairing the panel today on equitable and accessible TB diagnostics or TB diagnosis in India with the impact of COVID. Friends, we all know for years that the biggest impediment to TB control has been the long and winding road to diagnosis. The poor accuracy of smear microscopy and the weeks to months long time for culture have really been the Achilles heel in the efforts to eradicate TB. NATs, or nucleic acid amplification tests as they've been called, have really ushered in a new era. And they are either cartridge-based, which is the expert, or chip-based, which is TrueNAT. Accurate and rapid diagnosis, less than 90 minutes, with resistance on board, really has been a game changer for diagnosis of TB, no question about it. At the same time, but we cannot lose sight that timely initiation of anti-TB drugs and follow-up of positive patients is equally vital. And as we in India started to get a handle on this, came COVID. This is really likely to leave a profound and lasting impact on TB diagnosis and control. The reasons are that in the initial lockdown, there was a precipitous fall of 70 to 80% in TB notification rates. It also changed health-seeking behavior, disrupted health services with delayed diagnosis, and interrupted treatment for our patients. The large number of cases that currently remain undiagnosed and untreated will really fuel TB transmission, especially in household contacts where they've been sort of encaged for some time. And this is estimated to be at least 40,000 cases annually, with an increase of almost 1.5 lakh till 2025. So the aftershocks will really be felt long after the COVID epidemic wanes. COVID has additionally made it more challenging to locate TB patients. Poor compliance with TB treatment is a significant reason behind the increase in MDR TB and XDR TB in India. And the numbers are expected to be even higher during and post-COVID. So it's a wake-up call for overburdened health systems across the world, and prevention, diagnosis, tracing and management strategies of TB patients will really need to be restructured and reevaluated to meet the needs of our patients. So now, the remit of our talk is basically, of our panel, is accessible and affordable diagnostics. And before I introduce the speakers, let me thank New Diagnostic Working Group of the Stop TB Partnership for sponsoring this event. My co-chair, Dr. Puneet Diwan, is going to speak on the future of point-of-care testing on aspects of access and equity. Because if it has to be accessible, it really should be as point-of-care as possible. And Puneet is a senior program officer at the Bill and Gates Melinda Foundation in Seattle. And he was in India for some time, and he's currently involved with developing new tools and strategies to solve challenges in global TB control, to help countries and programs to figure out how to best use these diagnostics. Our second speaker is Dr. Mark Nicol, and he is going to speak to us on the role of new technologies in diagnosing TB, lessons from the South African experience. Mark is a clinical microbiologist with a particular interest in TB and in developing and testing newer diagnostics suitable for the developing world. His joint position with the University of Cape Town and the National Health Laboratory Service of South Africa allows him to sort of balance and coordinate activities of research with both clinical and laboratory teams involved directly in patient diagnosis and care. Our third speaker is Sanjay Sareen. Sanjay is going to speak to us on COVID experience in setting up PCR labs across the country. Sanjay is the head of FIND. FIND stands for Foundation of Innovative New Diagnostics, and he heads the India division and is really instrumental in laboratory strengthening and expanding access to high-quality TB diagnosis with the Central TB Division of the Indian Ministry of Health and Family Welfare. He also has been instrumental in setting up several PCR labs across the country, and he's going to give us his perspective. And our last speaker is Sandhya Krishnan. She's going to speak to us from a perspective of being a TB survivor on the challenges of TB diagnosis in India. Sandhya is a lawyer, she's a TB survivor, as I said, and she's a life coach. So friends, I invite you to listen to the words of wisdom from our four panelists, and I promise you it's going to be an exciting time. Thank you.
Hello, my name is Sandhya Krishnan. I'm a TB survivor and a wellness and mindfulness coach. I would like to bring the survivor's perspective into the discussion on equitable and accessible TB diagnosis in India, with a special focus on the impact that COVID has had on our journey as patients and survivors of TB. So it's no news to us that we are the TB capital of the world, and yet to many of us, it is unbelievable that we still face so many challenges for diagnosis in India, even today. I'll start at the beginning of the TB journey, so to speak, where thousands of us still suffer from incorrect diagnosis and treatment here. I am a case in point where I had no idea that I was displaying symptoms of TB to start with. I was guided to a general practitioner who gave me a collection of pills, one of which was antibiotics, I presume, and was just told that I'd be fine in 2 weeks, was not called back for a follow-up, or was not recommended any tests. And like most people, I was just trying to keep heart and health together, working a long day. It didn't even strike me. And there's a certain anger and outrage that I felt that my TB could have been diagnosed 2 or possibly 3 months earlier than it finally was. And I can only imagine what people with far less access to healthcare must go through on a regular basis and continue to go through from the reports that we get. The impact of this diagnosis is exactly what I just described. There is a huge suffering. The cost is exponential because we're running from pillar to post, very often having to repeat tests and not really knowing where all of this is leading us. There's nobody to guide us on this journey. There isn't enough information or transparency or someone to break it down for those of us that don't understand medical speak, and there is a lot of neglect. I do know that the healthcare system is hugely taxed, but there is a sense of nobody having time for us, and that we are somehow a burden on the system, and any kind of handout that we get in terms of attention or care is really a huge favor that's being done to us. I do believe truly that that's the narrative that has to change, and especially when it comes to drug-resistant TB patients. In diagnosis as well, there are several challenges that we face. We don't understand the different kinds of TB, how contagious it might be, what care we need to take of ourselves, of those around us, how we need to plan our lifestyle, our nutrition, our treatment even, more than just taking the pills. And I feel like having support through this journey can make a huge change if indeed we want to be that TB-free country that we have stated so vocally we will be this year, if I'm not mistaken. In terms of the kind of tests that exist versus the kind of tests that we have access to, I do believe there's a huge gap there today as well. I certainly wasn't aware of what tests look like, and this is despite my mother being a doctor and a microbiologist at that, just not one in India, right? So what else is out there in India? What the private sector offers, what the government sector offers, and I really, our hope is that there shouldn't be a divide amongst this. What new technologies are coming out? Again, from a lot of us survivors, there's a sense of anger and outrage that the world rallied around so successfully to find solutions and to beat COVID. I may be speaking too soon, but TB is taking decades, and are we just languishing, and are we just not moving fast enough to create the change for a disease that's so preventable, so treatable, and for deaths that are so unnecessary? We believe that there is a need for some fundamental changes, particularly in the areas of diagnosis, the kind of tools that are currently being used, and just the efficacy of it. So much more sophisticated technology does exist in the world today. We would like to have access to it sooner rather than later. And I think all it takes is strong will on the part of all of the stakeholders, and we can truly make this happen. Because healthcare, at the end of the day, is a human right. A lot of us believe that TB is not a personal disease. It really is a failure of the healthcare system, of society, and really to be TB free and to have access to diagnosis, treatment, support through this journey that is horrific in itself is really a fundamental right for each of us. Even in the public sector, where TB care services are offered free of cost, there are a lot of hidden costs, for example, that are not taken into account. It's not just about diagnosis, but hospital stays, how often you get access to review of X-ray results, travel to get your medication, travel to see your doctor. I know of people that dropped out of treatment in the government sector just because they couldn't take a day off work that it took for them to go and wait at a dot center for their medication. These challenges pose a serious economic barrier to accessing care and complementary treatment, and if this is a fundamental right, we would like for it to be exercised and respected. Stigma is another big problem that often goes unaddressed. Again, somehow the focus is always on just getting us to have the medication without any of the societal or the mental aspects that accompany this disease. TB is as much, if not more, societal and mental as well. And we would really like for those conversations to happen louder and with multiple stakeholders. Not only does every TB patient face stigma and very often a lack of understanding for ourselves as well, but there are several groups that are far more vulnerable, and especially those that have comorbidities or belong to groups that are already stigmatized by society, such as HIV patients, transgender patients, and other patients that might be suffering from mental health disorders as well. The pandemic has had mostly a negative impact on our journey as TB patients and survivors, accessing healthcare, being able to get diagnosed on time, being able to access medication. Everything that was already a problem pre-COVID became so much tougher during COVID. And I think if there is a strong will now to fight COVID, there has to be an even stronger will to overcome the difficulties and the setbacks that we faced in the last 2 years. I will also say that some of the behaviors and conversations around communicable diseases, use of masks, we could take some of the best practices from that and apply them to TB as well. And many of these actions have now been normalized. Those conversations should definitely be taken forward in the treatment of TB and in the managing of the disease as a whole. I'll recap by saying that the need of the hour is an urgent need to establish and implement a gender-sensitive, people-centered approach to diagnosis and treatment of TB, in terms of affordability, in terms of awareness, in terms of challenges faced by the public and the private sector, in terms of costs, access to technology, access geographically. If vaccines could reach every corner of the country, surely TB treatment and diagnosis can as well. Access to support in terms of mental and social issues, and more awareness and treating TB as in this basket of communicable diseases, of which COVID is one. So I hope our voice will be considered when we're having discussions around this. Our hope is that we will see the end of TB very, very soon. Thank you so much.
A very good morning, afternoon, and good evening to delegates, colleagues, and partners who are attending this very important TB summit. The SARS-CoV-2 outbreak has highlighted the huge gaps in the ability to test and manage widespread pandemics globally and in India. Challenges in the diagnosis of SARS-CoV-2 infections have emerged as a critical point of failure in the COVID strategic preparedness and response plan. There are gaps in both availability of tests and trained laboratory personnel. Over the last 2 years, India has taken great strides in building its COVID-19 diagnostic capacity. From having less than 20 labs in March 2020, the network currently has greater than 3,000 labs, with almost 2,000 labs in the private sector. In addition, there is a large network of antigen testing sites that has been established. The country has also established strong sequencing capabilities by the INSACOG network. India's testing rates are also tracking well as per the recommended WHO testing rates and stands on par with some of the high-income countries. There have been some important learnings from India's response to the pandemic, which in fact can be leveraged to develop a resilient pandemic preparedness system to protect the country from future threats. These include an unprecedented speed of regulatory approvals and simplified import procedures to ensure rapid availability of tests, strong focus on local R&D and innovation, which resulted in the development of tests like TrueNAT, the CRISPR, as well as the RT-LAMP-based tests, and rapid adoption of testing innovations like professional use antigen tests and self-testing antigen tests. India, in fact, was one of the first countries to come up with a policy on self-testing. There has been a strong private sector participation right from the beginning, and that has in fact contributed to the rapid scale-up of the testing network as well as the labs. To ensure quality, the government has ensured that only the ISO 15189 private sector labs are onboarded. The workforce has been rapidly expanded because of the large and huge focus on the training and capacity building, which now means that the country has a ready-made pool of skilled lab technicians, which can be leveraged to manage to mitigate threats from future pandemics. There have been strong intersectoral partnerships. For example, ICMR availed the services of the Ministry of Civil Aviation to deliver consignments of diagnostic material through mission Lifeline Unan. The near real-time data tracking has enabled analyses at district, state, and national levels to support rapid decision-making. And last but not the least, the government has very rapidly responded to the threat from emerging variants of concern by setting up INSACOG, a network of 38 labs to monitor genomic variations in SARS-CoV-2. Changing tracks a little bit, COVID-19 pandemic, while we all know has impacted livelihoods, it has also adversely impacted health systems across the world, including disease programs like HIV, TB, and malaria. The number of new cases of TB, which were rising steadily between 2016 and 2019, dramatically fell by 20% in 2020. India, in fact, contributed to the biggest drop in the detection of new cases, with 41% of the total number of cases that dropped in 2020 coming from India. It is therefore critical, in order to prevent disruption to TB detection, that TB diagnosis be opportunistically integrated with screening of respiratory illnesses, like, for example, COVID-19. In line with this, the Government of India, Ministry of Health and Family Welfare, they in fact issued a guidance which urged the state governments to rapidly conduct bidirectional screening of TB and COVID-19 presumptives because of the similarity in the symptoms of the two cases. There are two case studies which I would very rapidly walk you through. One is an experience from Kerala where both the cases, the influenza-like illnesses, as well as the severe acute respiratory infectious cases from OPDs and IPDs were subjected to this bidirectional screening. X-rays as well as oral questionnaires were used, and all the presumptives were offered NAT testing. And this resulted in a significant increase in the TB yield, almost 200 of the 100,000 screened in the ILI cohort, and nearly 988 cases detected of the 100,000 screened in the SARI cohort. There was another similar intervention which was implemented by FIND in collaboration with MCGM and IHF in Mumbai. Here, walk-ins in 4 government hospitals at the COVID-19 OPDs were screened with the TB questionnaire. The positives were isolated, and then the phone TB screening was conducted after 14 days of quarantine. The walk-in patients at the TB OPDs and the health posts were offered rapid antigen testing, and all the presumptives were offered NAT testing through either GeneXpert or TrueNAT. More than 15,000 COVID-19 OPD walk-ins were screened, and almost 219 of 100,000 cases screened were diagnosed as tuberculosis. And this has, there has also been guidance from global agencies like USAID and STOP2B partnership around the integrated diagnostic approach, and this study from Mumbai has now also been published in Lancet Global Health. This is another quick experience from Nigeria, where GeneXpert and digital X-ray CAD were used, and they in fact brought in HIV, HPS-AG, and HCV as well, and resulting in a strong TB yield of almost 570 per 100,000 cases screened. Very quickly, coming to some of the learnings from this integrated screening, absolutely critical to have an integrated touch point in order to offer the best experience for the patients so that they don't have to move around and increase the risk of infection. Try and use a single sample type and test cartridge. There are innovations happening in this space. For example, there is a new MTB plus COVID test, which will simultaneously be able to test for TB and COVID. There needs to be strong coordination between the vertical programs who are implementing, that is those who are implementing COVID-19 programs, as well as the TB and the HIV programs. Readily available and dedicated area for sample collection. And last but not the least, there has to be a constant push to be able to maximize the utilization of the machines and the human resource personnel which are deployed for these interventions. Some of the lessons from the COVID-19, basis strong investments in the diagnostics. Absolutely critical to continue focus on integrating multi-disease platforms, keeping the patient in the center and leveraging the massive testing infrastructure. Continue investments in research and development to ensure there is a reduction in dependence on imports and fill up to the local diagnostics innovation. Continue investing in skilling to augment the laboratory capacity so that we have a ready-made laboratory workforce. and incorporate a system strengthening approach which integrates and connects diagnostics with surveillance system to ensure that we are picking up early signals and are able to manage our pandemics and outbreaks better. And the strong backbone of genomic surveillance, which has been built through the INSACOG, there is a need to continue investing in that so that you can not only track the spread of TB and resistance, but also other emerging pathogens. Thank you.
Hello. I'd like to thank the organizers for the invitation to present at this summit. And what I'd like to do in the next couple of minutes is just share some of the lessons that we learned in South Africa from the implementation of new technologies for diagnosing tuberculosis. And I'd like to start by contrasting these two assays over here, Expert MTB-RIF and the ALIA-LAM lateral flow assay. Now, on the face of it, one would anticipate that the ALIA-LAM assay would be much more successfully and more rapidly implemented than the GeneXpert assay. Expert requires a complex instrument, it's costly, requires a power supply, is a laboratory-based rather than a point-of-care assay, requires collection of sputum, and in clinical studies, including meta-analysis, has shown that although it reduces time to treatment and improves the proportion of patients started on treatment, has limited impact on patient mortality. In contrast, the ALIA-LAM is a simple, relatively inexpensive test. It can be done at the true point of care at the bedside of the patient. It relies on urine collection, which should be simpler to obtain than sputum. And a number of studies have demonstrated that in patients with advanced HIV infection, rapid implementation of treatment on the basis of ALIA-LAM results can reduce mortality. However, the experience from South Africa was that while Expert was rapidly implemented and became widely available across the country, this was not the case for ALIA-LAM. So on the map on the left, you'll see that in 2019 already, 203 sites had implemented GeneXpert testing, and more than almost 15 million tests had been done across the country. In contrast, even until now, there's very limited data on ALIA-LAM implementation, but implementation is patchy, and the test is not widely used except in selected tertiary care settings. So why is this? Well, there's some obvious answers. The first is that while GeneXpert is both sensitive and specific, and can be used in a wide range of patients ranging from children to pulmonary and extrapulmonary TB, the ALIA-LAM assay is relatively specific, so a positive test can be used as the basis to start TB treatment, but is insensitive and really only has useful sensitivity in patients with advanced HIV infection. However, I believe there's some broader lessons which can be learned from this. The first is that laboratory services can be powerful vehicles for program change. Following the decision to implement GeneXpert in South Africa, the National Health Laboratory Service, which provides laboratory testing for the state sector in South Africa, was put in charge of rolling out the GeneXpert assay. The laboratory services selected the sites, purchased the equipment, made sure the consumables were available, set up the quality assurance systems, and developed the algorithms for implementation. In contrast, because the ALIA-LAM assay is a highly decentralized test done by clinicians at the point of care, we found that inertia was a very strong force. It was difficult to change entrenched practices, supply of tests was problematic, and simply getting clinicians to start using the assay has not proven easy. Part of this may relate to political will. So following the WHO recommendation on GeneXpert in 2011, the South African Minister of Health made a decision. He said GeneXpert would be used as the replacement for smear microscopy, and he allocated this responsibility to the laboratory services. In contrast, there was no similar decision or recommendation from a senior government minister around the implementation of ALIA-LAM. The final lesson in relation to this, I believe, is that complexity is the enemy of implementation. So whilst for GeneXpert this was relatively straightforward, GeneXpert was to be used as a replacement for smear microscopy for primary diagnosis of pulmonary tuberculosis. A simple implementation message. In contrast, a considerably more complex algorithm had to be developed for Lear-Lamb. This test was only to be used in HIV-infected patients, in those with low CD4 counts or advanced infection, those who were hospitalized. Decisions had to be made on whether a test could be used as the basis for treatment or whether a test could be used to rule out tuberculosis in this patient group. And this resulted in considerable debate over an extended period of time about what the optimal algorithm was. And in fact, the algorithm was only finalized a year or two ago, many, many years after the test became available. The next lesson which I'd like to mention, and this should be a really obvious one, is that tests don't work without specimens. And for here, I'd like to highlight our experience with diagnosis of pediatric TB in South Africa. So we and others were amongst the first to evaluate GeneXpert and other tests for diagnosis of pediatric TB. And we showed that the tests were relatively sensitive, detecting around 60 to 70% of culture-confirmed TB in children. But of course, you can only do a test if you have a specimen. Most of the TB in children in South Africa is children under the age of 5. Those children are unable to expectorate spontaneously, and so we need to collect gastric aspirates or induce sputa to perform testing. And we haven't been widely successful in implementing collection of those specimens outside selected tertiary care centres in South Africa. And so either we need to do a better job at making sure that specimen collection becomes more widely available, or we need to find alternative specimen types in these patient populations. The final lesson I'd like to mention here is that tests only have impact if results are actionable and actioned. And so what do I mean by actionable? Well, let's use the example of children with TB in South Africa again as an example. So in South Africa, with a high prevalence of tuberculosis, empiric TB treatment of children on the basis of clinical presentation is the norm. In this setting, there's very low appetite for implementing tests for this population that have relatively low sensitivity. So for example, a clinician with a child with suspected TB will say, well, why must I do a GeneXpert test? Irrespective of the result of the GeneXpert test, I'm going to start this child on TB treatment. Of course, there are counter-arguments, in particular, the ability to confirm TB and rule out other diseases, and additional information on drug resistance that one obtains from microbiological testing. The second point here is that even when tests are actionable, they're not always actioned due to health systems failures. And the example I give here is the proportion of patients with drug-resistant TB who were diagnosed by GeneXpert and started on treatment. And here, this figure over here shows a study that we did in Khayelitsha outside Cape Town, looking at time to treatment of patients with drug-resistant TB on the x-axis, and on the y-axis, the proportion of patients diagnosed with drug-resistant TB who were started on treatment. And you can see that even after implementation of GeneXpert in 2013, only 60 to 70% of patients were started on treatment after diagnosis of drug resistance. And this is because of health systems failures in recalling the patients and getting them onto treatment. However, the final lesson is that when we get this right, it's certainly worth the effort. And this is an example from Khayelitsha, again in Cape Town, where we explored time to treatment initiation with implementation of a range of different diagnostics across the years. And you can see that in the early 2000s, the median time to treatment of patients with drug-resistant TB was around 70 days, with implementation of line probe assays, followed by decentralization of care for patients with drug-resistant TB, and implementation of GeneXpert. By 2013, the median time to treatment for a patient with drug-resistant TB was 7 days. So an enormous achievement and a substantial improvement in patient outcomes. I'd like to thank my colleagues, particularly Helen Cox, the children and adults who've participated in our studies, and our funders. Thank you.
Greetings. I'd like to share with you a few points and thoughts about the diagnostic access gap and the need for point-of-care testing. The context of this presentation comes into the principle that we are missing millions of patients with TB. The map on the left shows the estimated TB incidence for 2020, and you can see, of course, India dominates by the number of TB cases. And the figure on the right shows who's missing. That is the gap between those that are notified and those that are estimated to occur across both men and women. And the numbers are large. We're missing millions, and many of those are from India itself. Now, where are these patients being lost? The diagnostic gap is the biggest drop in the cascade of care we have. Across all countries, when you aggregate the information between that estimated incidence and the patients who are diagnosed is where we're missing, a third of patients in the case of drug susceptible TB and half to two-thirds of patients in the case of drug resistant TB. It's interesting to put this in context of every other diagnostic out there, because this problem is actually particularly notable for TB itself. If you look at all other essential diagnostics as judged by the WHO across all levels, whether it's the basic primary care level or the advanced primary care level or the hospital level, what we find is that you can, even if access to other essential diagnostics like malaria, HIV testing, and urine pregnancy tests and others are there, TB access is not. And that's true very much at the basic primary level, where just about 12% have microscopy, shown on the left in the Lancet Commission on Diagnostics. At the advanced primary care level, you find out half with microscopy, and very marginally or rarely would find more specific TB diagnostics in the form of molecular testing. You do find it sometimes in hospitals at about a half to two-thirds, but that's not where patients are. While there has been some modest improvement in the availability of so-called WHO-approved rapid diagnostics, or WRDs, shown at the table on the right, that the number of people who get that test at the point of diagnosis is far below the global targets. In this case, global target for 2020 was 80% of patients who are diagnosed should have a WHO-approved rapid diagnosis at the time of diagnosis. That number was only about a third. And in fact, in India, it was close to 20%. That's kind of an amazing number. And one of the core problems is, as I showed you a little bit earlier, that across all aspects of the care cascade, when you look at where people seek care, whether it's in public or private sector, which is circled in red there, what you find is those are the places where it's uncommon to have TB diagnostic access available. It's a refer out or send out in almost every place. That's about 30% overall across all countries, and about the same in India. Why does this matter? It has been shown relatively convincingly that on-site molecular testing increases patients diagnosed and treated. First example here comes from India itself with a demonstration of GeneXpert when it was first released a decade ago. So it's not new information. When Expert was replacing smear microscopy just in the public sector facilities, they found about a 15% increase in the total amount of patients who were diagnosed and put on drug across all cases, clinical cases, microbiological cases. And there was a 5-fold increase in detection of rifampicin-resistant TB. More recently in Uganda, a cluster randomized trial across 20 clinics, again, had a striking increase in not only the transition from standard of care, which was basically microscopy with expert referral when needed, having on-site expert availability in that setting increased your proportion of patients who got diagnosed at 14 days by a lot, okay, by over 30%. And more importantly, increased the quality metrics across every step along the diagnostic evaluation, including the time to treatment, getting a DST, and everything got better. So it's clear that having diagnosis where people seek care makes a difference. But why hasn't this happened everywhere, since really we've had a decade to figure this out, certainly in India? One core issue is cost. As one senior program officer mentioned to me several years ago, that if we transitioned to expert at that point in time, it would more than double the amount of money the government had allocated at that time for TB. The supply of the diagnostics is non-trivial. Many of these previously were imported, although that's been recently partially addressed by the presence of new indigenous products like MolBio's TrueNat, which could address some of the reliance on external supply. In fact, that external supply was even more unreliable during the pandemic. A lot of this is just priority. How much are we going to be bothered by, investing in needing TB diagnosis versus just letting people get diagnosed the way they were and having this available just as a DST. People previously thought molecular testing was just unscalable. You couldn't put these things in austere settings. Probably the most important thing is just straight up the willingness to pay for seeing that this service becomes available to patients as they need them. And I think that is probably the core thing that has to change. People who thought that molecular testing wasn't scalable have been proven dramatically wrong by the events of the pandemic. And India's COVID-19 PCR testing success story is probably the best answer to that concern. India does more than 1 million tests a day. And take that against 10 million tests a year for TB across microscopy and gene expert, roughly speaking. Now, the 73 crore total, almost 750 million COVID-19 molecular tests that have been reported over the past 20 months in India dwarf the 20 crore TB tests that have been conducted over the last 20 years. And most of that's just microscopy. Only a small fraction would be an advanced molecular test like what's happened here. So I think we've proven that molecular testing is scalable. And the question is how to report that capacity and willingness, more importantly, to seeing that TB testing becomes available where patients need it, not just COVID testing is available to anyone in India who wants one kind of anytime. There are a number of pipeline products that are coming down the pipeline which can help bridge this diagnostic access gap. We're enthusiastic about oral swab-based molecular testing, which can be plugged into this massive existing PCR capacity that India exists. This could also be plugged into existing diagnostics like Expert and MolBio's TrueNat. And there are pipeline platforms by companies like LumiraDx amongst many, and consumable NATs, disposable devices, where we might be able to take this non-sputum specimen and deploy it into. And that's great because that increases the access base of people. They don't have to rely on sputum processing. And at the same time, everybody knows how to do a swab. We're sick of them. But they work apparently almost as good as sputum and TB. And we'd like to see those protocols promptly reviewed by ICMR and approved. And there are some urine assays which might be able to augment that molecular capacity in austere settings. So it's possible to address this gap. And I think we'll hear more about this in the upcoming presentations. Thank you very much for your time. I want to thank all of our speakers for their interesting presentations. For my closing remarks, I just wanted to highlight a few points from the presentations as well as make some suggestions for the subsequent discussion. First, I think we heard that there's a substantial diagnostic gap in TB, and in particular, a gap in the delivery of WHO rapid diagnostics to patients at the time of diagnosis, with only 20% of patients in India having that test at the time of diagnosis. Second, we heard that there are some interesting and promising tools in the pipeline, some of Indian origin like TrueNat and MolBio, which are increasingly available, but not quite there yet in terms of being routinely available for most patients. And some additional pipeline technologies which offer the opportunity for more decentralized diagnosis moving forward, which is great. Third, that we heard that COVID-19 has had an enormous impact and a negative impact on TB health service utilization in general and TB case finding in particular. And that's really challenging for patients and challenging for the program to recover from this setback. Then we heard that some of the remarkable experiences from India's effort to rapid response to deliver COVID-19 testing to its population, and some of the incredible mobilized efforts and the results were sort of stunning in terms of number of tests that could be delivered to people when the political will was able to be summoned. And lastly, that some interesting and innovative approaches for things like bidirectional testing through the pandemic and efforts to try and recover ourselves out of this hole of case finding that COVID left us in. So a lot of really interesting experiences and lessons, but the fundamental problem remains. Most patients aren't getting the right diagnostic test when they need to at the time that they're suspected of having TB. They're still subject to clinical and ancient microbiological diagnoses, not actually getting the tests that are even available. And my basic questions, perhaps for points for reflection, are first that clearly India can do this. If you can test a million patients a day with molecular tests for COVID-19, I think it should be possible to get to, a million patients a month for TB with molecular tests, which is all it's going to take. So I think there's an incredible capacity and capability that's been demonstrated under the duress of the past few years, which now needs to be harnessed for the disease that's caused nearly as much damage on an annual basis for the past many years. So I think that there's no excuse anymore. Second, that it'll be crucial to find a pathway to leverage the diagnostic capacity that's been made, not just in terms of the technologies and tests, but also in the human systems for collecting specimens, for getting those to a laboratory, for returning a result to patients and providers almost within hours, and reporting those to public health authorities for subsequent action. Like those systems that were built for COVID now need to be harnessed for TB. So I'm looking forward to the opportunity that the pandemic dividend might allow for not only catching up out of the hole that COVID has left us in, but actually moving forward towards the national goals of TB elimination with a redoubled effort because of the diagnostic advances that have been made under duress because of the pandemic. With that, I'll invite the live question and answer session that for the presenters and the audience that might be assembled. And thank you very much for your attention.
Hi, everyone. Puneet, it's late at night. Mark, it's afternoon. Sanjay, you're in Europe. So everyone, good day. It's been a fabulous meeting, and each of our speakers has been outstanding. There's some questions that have come in from the audience, and one is addressed to Sanjay. Why is it that the diagnosis of TB remains a challenge in India? Is it deliberate overdiagnosing? Is there lack of awareness? Or do we just simply ignore the symptoms? And, there's a lack of accessible, reliable diagnostics.
Thanks, Dr. Camilla. I think the presentations in this panel, they kind of address this question. I think Puneet's presentation, it really spoke about the fact that even though I think there is a massive infrastructure that is now available within the country, there are over 80 culture and DST labs, and there are close to 3,000 NAT labs, and that is, not discounting, that is discounting the huge infrastructure that has now been put in place because on account of COVID. I think of late, there have been some particular challenges with the program. I think there have been disruptions as far as supplies for TB testing are concerned. There has been, I think the government has been trying to decentralize testing to the extent possible. And when they're talking about decentralization, they're also wanting that the states should start procuring these tests on their own. And this sudden shift in strategy has caused some challenges, because the states are still trying to get their act together. This decision was obviously taken, a little before the pandemic struck, and hopefully the situation gets resolved. But even despite that, despite these challenges, and even before the pandemic struck, there were still issues as far as access to diagnosis is concerned. And we, through a Gates Foundation grant, we had actually implemented an exercise around diagnostic network optimization, where we sort of analyzed the available capacity across the various platforms, which included LPA as well as the Gene Experts both in the public and the private sector in 3 states. This exercise is now being scaled up to 15 states. And we found that, despite such a large infrastructure, majority of these machines still remain underutilized. And I think a bulk of this is also alluding to the point which Puneet made, is that the access at the point of care is still lacking. I think the first point of call for a patient is either a subcenter or either a physician's office in the private sector, or maybe a private or maybe a primary healthcare center. And there, other than maybe a microscopy test, you don't have an advanced TB test which is available there. So either the sample has to be transported or the patient has to travel quite a few miles in order to get access to testing. And then once the sample reaches there are challenges as far as sample turnaround time is concerned. So and then this gets multiplied further when you're talking about culture and DST. Even though majority of the testing is happening on molecular platforms, but there is still a reliance on the culture and DST, on the culture platforms, at least for treatment monitoring. And even the culture and DST capacity has been expanded massively over the years, but I guess still in terms of accessibility, it's a challenge. I think government has gone ahead and now established some of these labs in the districts. There is, under the new Global Fund grant, there is a plan that another 10 midget labs are expected to be set up at the district level just to support the monitoring efforts. So I guess the challenge, long story short, the challenge is that, there is still a lack of appropriate, point of care tests, that is true point of care tests. And, even though the GeneXpert and the TrueNat are closest to that, we still can't call them real point of care tests. I think Mark alluded towards the Alair LAM. While that has challenges, there are certain new generation LAM tests which are expected to become available and using simpler test types. So another challenge has been perhaps that sputum is not really an adequate, appropriate sample or the best sample for TB diagnosis, and specifically for those who are afflicted with HIV and the children. So introduction of new test types where alternate samples can be used should dramatically improve access. So the future looks good. I think we at Find did an analysis, and there are close to 151 true POC NAT technologies which are likely to become available over the next 3 to 4 years. Now, all of them, may not necessarily make the cut, but still, even if 10% of these technologies are able to make it to the market, that should substantially expand the availability of tests. And the best part is that most of these technologies could be potentially point of care or true point of care, that is, and hence being able to improve access to the last mile.
Okay, thank you. The next question is Puneet. Puneet, given that a majority of Indian TB patients seek care in the private sector, how do we resolve the issue of misdiagnosis? Basically in the informal private sector. We're not looking at the good private sector, we're looking at the private sector that is kind of a bit informal. Can you hear me, Puneet? Okay, Puneet can't hear me, so I'll go to the next question. I'll come back to Puneet when he can, and that's to Mark. Mark, how feasible is door-to-door testing for TB in a high burden, low middle income country like India? Are there any other alternatives to making diagnostics remotely available?
Yeah, so Camilla, that's an interesting question. So there have been a number of initiatives in South Africa to try and bring molecular testing, in particular expert, if not at the door, at least locally available to communities. And while those have shown success sort of during the life of the project, they've proven to be non-sustainable. And so I think with our current technologies, there isn't really a sustainable option to do that. I was interested to hear what Sanjay's comments about care, and just reflecting on, I guess, the differing experiences of India and South Africa. I wonder to what extent this may be a legacy of the type of diagnostic programs that were in place prior to implementation of molecular testing like Expert. So in South Africa, testing for TB has always been fairly centralized. It's the most decentralized point at which it was offered was at the district hospital level. We never really had the same experience that India had with microscopy centers, which I think are more decentralized sites. And so instead we had the the systems put in place to move samples rather than patients. And so I think when Expert came online, there was the opportunity to simply replace smear microscopy with Expert, because we were already fairly good at moving samples rapidly. And so I guess I've always wondered why that hasn't been possible in India. Why, given that I don't think have the technologies for true point of care testing at the moment, and maybe they will come, but my guess is they're going to take a little while. Why can't we do better in moving samples rapidly and efficiently and getting results back to patients? I've always wondered that in relation to the Indian experience. So I'd be interested to hear what the other panelists have to say on that.
And just one point from your talk, you said complexity is the enemy of implementation, which is an absolutely terrific point. So how do you see, this is kind of everyone is talking about NGS as the new kid on the block. How do you see NGS being applicable to the Indian sector? I mean, we're not even got to grips with experts. So how do you look at next gen sequencing in terms of, because I already have clinicians saying, give me a whole genome sequencing report, tell me. So that's for us, but how do you look at this in a public sector?
So I think it obviously, there are a couple of things. I guess the one thing is just to make sure that the referral networks work well, and that you have good, culture labs, which India does have. So at the moment, the technologies for doing direct NGS on samples are not optimal, and there's massive technical challenges there. But if you've got a good culture lab network as India does, and you have a good you have a good referral network system for making sure that the samples that need the NGS get referred up to the reference laboratories, then there's no reason why NGS can't replace or at least be an ancillary test to phenotypic testing for patients with more challenging forms of MDR-TB. I think we're probably still somewhere away from doing it for everyone with TB, right? But if you target this for people who at least have rifampicin-resistant TB as identified by molecular test, or maybe maybe the starting point is those with XDR-TB, then I don't see why this is not possible. And I say that, but South Africa hasn't successfully done this, right? Despite, again, a couple of projects really doing this, demonstrating that it should be feasible. The technical challenges are still there, right? You've got to get reasonable quality DNA out of you've got to get the culture of the organism, you've got to get reasonable quality DNA out. And from then on, it's actually quite straightforward, right? Because the pipelines for sequencing and for interpreting genotype-phenotype relationships are much more sophisticated and user-friendly now. And so the hard parts, I think, have been done. It's in a sense the easy parts that we're not getting right, which are the referral networks and getting just getting our labs up to scratch and getting good quality DNA out. Part of it, I think, is also just that we tend to be staid and stuck in old ways of doing things, and it's sometimes difficult to shake the boat a little bit. And I guess the point that I made in the talk around the Ministry of Health, right, and our minister, who basically just said to the lab services at that point, you will implement this test. It will be done as a replacement for smear microscopy, and everybody was terrified of the Minister of Health, and so it happened, right? And so I think political will is a big driver as well.
True. Thank you. Next question. There are a lot of questions. How long do we have? Will the organizers tell me? About 5 minutes more or 7 minutes? Anyway, I'm going to ask Puneet, my co-chair. Given that majority of India's TB-affected persons seek care in the private sector, how do we resolve the issue of misdiagnosis more in the informal private sector?
Well, I think India's already shown. Thanks, Camilla, and greetings, everyone. I think India's already showed the way. In many settings, they have levels of diagnosis and use of microbiological testing among private providers, which is similar and indistinguishable from that in the public sector. And I think the answer is the same for both. If you make the tests available, then and provide some engagement with providers and some basis to use them and giving them the results back, they've shown pretty high willingness to use them. in both urban and rural settings. So I think it comes back to the, well, I think Mark pointed out a great point. It's not only the political will to make that evolution and testing happen. It's also give them the budget, right? Which I think what was provided there, and I would say that we've proven pretty spectacularly in India that you can collect the specimens and move them to the central laboratory and get the result back, as long as it's been a nasal swab for COVID, by the million. And so I think provided both the political will and the budget, India could probably snap its fingers and get this done. And by the battery of tests that are available, there's plenty of expert capacity. There's growing mobile capacity. It's a layered network of services that can offer this. If you're in an urban area with easy specimen transport, boom, that's going to get into your laboratory. You're going to get a result super fast in the central laboratory. If you're out somewhere in a more austere setting, then there should be a local, a mobile or expert available at the CHC or district hospital. It's already there. So I think it's they just need to augment their channels and throughput to meet the demand. So I think the same answer is the same for the private as the public sector. When you make the specimens available and the infrastructure to just make the testing services available, make the infrastructure available to pick up the specimen and get it back to the laboratory and get the result back to the patient and provider, there's no reason why it can't succeed as much for private as public.
Thank you. There's a question for Sanjay. Learning from the impact COVID had on TB diagnostics, what steps do you think we would need to take to ensure that the next, God help us, the next pandemic, if it ever happens, will not derail TB services? That's been such a depressing scene. So what do you think we should do to avoid this huge derailment of TB services across the block, whether it's notification, whether it's diagnostics, whether it's treatment? What do you think we should do? What steps should we take as a country, as a world?
Yeah, no, I think that's a pretty loaded question, Camilla. And I was hearing to an earlier talk by Dr. Zarir Udwadia, and he was kind of pointing out that how these frequent lockdowns, for example, in India has had a tremendous impact on the ability of the patients to be able to access these services. I think that was one clear, and there are, I guess, enough publications of all kinds to sort of show that lockdowns have not had the desired impact in terms of reducing the incidence of the pandemic, so to say, in so many words. And I think the other challenge which we had was that a majority of the TB infrastructure and including the personnel were pushed into COVID. I think it was an emergency response, and that coupled with the inability of the patients to access the services further compounded the issue in terms of patients' ability to be able to get tested. I think going forward, one of the good things, or I guess one of the silver linings of the COVID pandemic, has been the unprecedented focus on diagnostics. I think that it has clearly shown that diagnostics still remains the first line of defense as far as pandemic is concerned, even though now vaccines are widely available. And I think similarly, as far as the TB piece is concerned, this is something which obviously needs to be widely propagated. We need to address all the challenges associated with, taking the diagnosis as close to the patient as possible, whether it is through technologies or whether it is through efficient sample transport mechanisms, whether it is in the public sector or in the private sector. Then there is this massive infrastructure, diagnostic infrastructure, which has now been established in the country and even globally, and there are multiple donors who are supporting that Global Fund through C19RM and a whole bunch of other donors who are, pumping millions of dollars in terms of enabling the countries to build their infrastructure. I think going forward, the countries have to perfect the art of integrated diagnostics. I think moving towards a world of integrated health systems. Majority of the platforms, even if you talk about the GeneXpress and the TrueNAS, they are actually multiplex platforms, and they enable testing of multiple pathogens. And that is something which has unfortunately not been practiced globally. We still continue to be very siloed in terms of our programs. HIV doesn't talk to TB, and TB doesn't talk to malaria, and so on and so forth. And while these technologies amongst themselves have the potential of being able to test all of the diseases in one go, so this is obviously something that needs to be tried, and it has been tested in multiple pilots and it works well. I think the programs need to talk to each other well. They did so because of the COVID pandemic. And if it is, as Puneet, I think, very articulately said, that if it is possible for India to do 1 million tests a day on account of the COVID pandemic, and despite all of these restrictions, why should not it be possible for them to, conduct, at least even half the number of tests for tuberculosis with such a massive diagnostic infrastructure available?
Thank you. There's a question for Mark, and it's what helped the political will? But also, apparently, you need administrative will in South Africa as well for investing in new diagnostic technology. So, what should India learn with both convincing our politicians as well as the administrative service, because they're pretty powerful? So, you have these two chaps who are, pushing the agenda. So, what are the lessons India can learn from South Africa that seem to have done pretty well in getting Gene Expert rolled out when we were still struggling to get it rolled out, at least 6 years later?
I'm not sure that I have a good answer to that question.
You all did it.
Well, we did, but I mean, if I'm honest with ourselves, right, the reason it worked is because our then Minister of Health, this was his pet project, right? He was embarrassed by the fact that South Africa had the highest incidence of tuberculosis in the world, and he was obviously sold on the technology, and I don't actually know sort of how he became convinced about the technology, but I think it was obviously the data were good, and many of the early data had come from South Africa, and so I think that probably helped. So fortunately in our situation we didn't actually have to persuade the minister, right? And in terms of the relationship with the administration, I think the advantage that South Africa had in that regard, and I'm not sure what the structure of the laboratory services in there is, but I suspect that they're more fragmented or state driven, is we had this sort of national health laboratory service which essentially was a state entity, and the Minister of Health could direct the laboratory services to make this change. So it was a simple direction, and there was no arguing with it. Obviously, it helps to have local data to convince politicians. I'm a simple microbiologist. I'm not a politician, and so I'm afraid I don't have a really good answer for that question. I think patient advocacy obviously makes a big difference, right? And I think advocates are often strong advocates around things like getting drugs available and treatments available. And perhaps they also need to be encouraged to increase advocacy around diagnostics, because of course if you're not diagnosed, then it doesn't matter if you have the best treatments in the world. So I guess that kind of advocacy helps, and I think also just clear messaging, right? I mean, there certainly were situations in South Africa where the Ministry of Health was given incorrect messaging particularly by other diagnostic manufacturers, and we had to sort of counteract that, and so I think really clear messaging and having the trust of the ministry helped in that regard.
Thank you so much. That was really a good answer. Okay, Sandhya, the last question is to you. We have to stop. We just have 2 minutes. How can diagnostic services be improved from the point of view of TB-affected individuals?
I think communication, information first, Camilla. So much of what we struggle with, for example, for all of us here on SATV, Survivors Against TB, we get so many queries on our personal contacts, right? Like, what do I do? Who do I approach? Which is the doctor? And sometimes we're completely lost ourselves because we don't know where the patient started and where they're getting. So I think information is key. And simplified information, and I'm not quite sure. We advocate for different kinds of groups to give that information at different stages, because we can't also bombard a patient, I think, as they enter the healthcare system. but having somebody like handhold us through the entire process will be key to us feeling like our health is being taken care of, and that it's not our responsibility to go find and just find a doctor because we
Yourself, yeah, exactly. Thank you so much. We're coming to the end, and Puneet, would you want to just any questions you feel would be pertinent to this particular discussion that I thought has gone off pretty superbly?
No, I think this has been a really useful set of presentations, and I want to thank everyone who for all the presenters who put something forth. I mean, it is kind of mind-boggling that this is it's 2022 and we're still relying on microscopy for the majority of patients, and I think that's got to change super fast. And I really look forward to seeing how India can really harness what it's done and make this sort of diagnostic promise real for most patients. I don't really have additional questions right now. I think now that it's really a question for patients and program officers throughout the country and affected individuals to demand what's right here.
Thank you so much. Thank you, panelists. Thank you, speakers. It's been wonderful, and I'll take you back to the audience.
I want to thank Chapel and the organizing committee for allowing me to chair the Burning Issues and Innovation track in this year's India TB Summit. I'd also like to thank those who have agreed to present in that track. I also want to commend the organizing committee for the topic of this year's meeting, Redesigning TB Care for Equity and Adherence, which is so timely given the global situation. In preparing these comments, I realized that tuberculosis had been the focus of my professional life for over 3 decades, and that in the past 5 years, I've grown distant from the day-to-day details of tuberculosis as I've focused more broadly on innovation and global health. But with distance comes a perspective that I'd like to use to frame the Burning Issues and Innovations presentation. A lot has changed in the last 35 years. 35 years ago were dark days for TB, and since then, we've seen decades of steady progress. And what was once a vicious cycle is becoming virtuous. The vicious cycle of inattention, underfunding, and stagnation was becoming a virtuous one. Increased political commitment elevated tuberculosis from the domain of technocrats and bureaucrats to the conversation of heads of states, and it even took the center stage at the UN, and this resulted in increase in funding from public and private sources. This funding attracted some of the brightest young minds who provided new insight into control strategies, more sensitive diagnostic tests, more effective drugs for both drug-sensitive and drug-resistant TB, and even the hope for a more effective vaccine, all of which was being delivered through public and private health systems that were becoming more integrated and effective. Political and technical leadership proved that tuberculosis was a solvable public health challenge, with death rates dropping and even the incidence decreasing year on year. And the social and economic determinants that underlie tuberculosis were finally being discussed and addressed. Was it perfect? Certainly not, but the progress was energizing. Then came the crisis that many had discussed, but none had prepared for, a global pandemic. COVID has been catastrophic in so many ways, but particularly so for those with tuberculosis. Disease trends have reversed, and for the first time in a decade, rates of disease and death are increasing. Even more disturbing is what is not happening. Case reporting down 16% in 2020. Therapy of MDR-TB decreased 15%. Preventive therapy decreased 21%. But most troubling to me is the ultimate consequence of increased poverty and inequity. The UN estimates that more than 100 million people have been pushed back into poverty, and the world economy has lost $12 trillion. The sad fact that history has taught us is that TB patients will suffer disproportionately from this poverty. There is, however, a silver lining to the COVID crisis, one that can serve the TB community well if it chooses to pursue it. COVID has mainstreamed airborne infection control. It has raised awareness of the importance of cough, not just as a manifestation of disease, but also as a mechanism of disease transmission. It is again bringing a new talent into the field with applications to public health programs at an all-time high. And it is increasing funding for health infrastructure that can benefit not just COVID or TB, but universal health. In short, COVID reaffirms a basic public health truism that I first learned during the early days of the HIV pandemic. In public health, no crisis should go unexploited. As we kick off this conference, there's just one thought I'd like to leave you with. Now, more than ever before, there's a need to focus on burning issues of health disparity and opportunities provided by innovation. We need to readdress neglected burning issues, full spectrum of patient support, the potential to redefine quality TB care in the context of mental health, gender, stigma, equity, and access. And at the same time, we need to double down on innovation, drugs, vaccines, and digital tools, perhaps even using sound for diagnosis. I'm very thankful to those who agreed to talk about these issues in this symposium. And I urge all of you to see COVID not just as a crisis, but as an opportunity for exponential progress. Thank you.
What do you think of people fighting TB? Or people who have survived TB? Do you think they are different from you? How different? Contagious? To be avoided? But why? Do you know that every type of TB is not contagious? And a few days after medication, TB patients can't infect anyone. Then why discriminate? Anyone can get TB. Even you. Come on, India. Let's fight TB, not the people it affects.
Hi, everyone. I want to thank the organizers for giving me the opportunity to speak today. I'm quite excited to talk to you about digital cough monitoring and its role in TB care. Cough is a hallmark symptom of TB. It is used to screen for and track clinical improvement of TB disease. Globally, cough is the one symptom that predominantly triggers the entry of patients in the cascade of care. But as we speak, despite the central role in TB control, neither patients or practitioners have the means to objectively quantify and qualify cough. But coughs do not all sound the same. They do not all have the same frequency or last as long or vary the same way between day and night. Cough is such a data-rich symptom that clearly is not used to its full potential. It feels intuitive to me that if we could just refine and improve the way we analyze cough, this could accelerate patients' entry in the pathway to cure and be such a game changer for finding the missing millions of TB patients out there. Recent developments in acoustics and artificial intelligence now allow us to make significant progress on this. Using smartphones and mobile applications, cough can be accurately monitored and recorded, what we call digital cough monitoring. The tuberculosis working group in Peru showed that the frequency of cough diminishes with therapy and that its circadian variability regresses as time goes by. A proof of concept that objectively measuring cough correlates with the stage of disease, as shown on the left-hand side. The questions we need to ask ourselves are, does cough correlate with treatment failure or infection relapse? Is there a specific pattern of cough which even predicts those unfavorable events? On the right-hand side, colleagues at the Wadhwani Institutes for Artificial Intelligence in India showed that artificial intelligence model can be trained to differentiate the cough of COVID-positive patients from that of COVID-negative patients. Can such model be trained to screen for or diagnose TB? How good would be this model if it was trained on an enormous amount of TB coughs collected throughout the world? To answer those questions, we need to start digitally monitoring cough in TB suspects and TB patients right now. This is the Hive Cough Tracker app, which is currently used within TB clinical trials. This app records human cough without recording background noise or conversations. It can easily track significant increase in the user's cough over time. This application allows users to share their cough data with loved ones or healthcare providers or clinical researchers as part of a study. I think it's extremely refreshing and empowering to have such an innovation that can now be deployed outside the laboratories, outside the clinics, in patients' hands and pockets on their smartphone. I'm part of a global research consortium currently deploying digital cough monitoring technologies within TB diagnostics and treatment cohorts. Our aim is to build a global open access TB cough database, which will allow the development and validation of artificial intelligence models so we can make cough count in TB care. If you're a patient, a TB practitioner, or a researcher, I invite you to join us in this effort. I also invite everyone attending this conference today to download such app and start monitoring their cough and learn more about their respiratory health right now. So once again, I want to thank the organizers for giving me the opportunity to talk about this. I think it's an exciting technology that we're going to hear much more in the coming years, and I'm looking forward to the rest of the conference. Thanks, everyone.
Welcome to the session on TB and COVID-19, the two pandemics at the India TB Summit 2022. I'm Lancelot Pinto. I'm a consultant respirologist at the PD Hinduja in Mumbai, and I have the honor and privilege of co-chairing today's session. So what do we intend to discuss over the next hour or so? When you talk about diseases, you talk about the epidemiological triad, the agent, the host, and the environment. And it's amazing how similar or the similarities that both COVID-19 and tuberculosis share, which therefore lends itself to common solutions, common pathways, and common ways of looking at the problem. So when you look at the agent, both the agents, whether it's the tuberculosis mycobacterium or it's the virus that causes COVID-19, both of them are airborne and therefore spread from person to person through the air, and therefore measures such as masking, measures such as distancing might play a role in prevention. When you look at the host, unfortunately, like most diseases, they tend to affect the vulnerable the most, individuals who are elderly, individuals who have comorbidities, individuals who are impoverished, have poor nutrition, potentially have worse outcomes than individuals who don't have any of the above. And when you look at the environment, overcrowding, living in poverty, living in conditions which are subject to minimum distancing among individuals, all contribute to both the pandemics of tuberculosis as well as COVID-19. What we hope to achieve over the next hour or so is look at the challenges that different stakeholders play in the management of tuberculosis and COVID-19, how COVID-19 has affected the control of TB, the ambitious plans that we may have had for TB, and what are the opportunities, therefore, that we can look forward to? How has our understanding of the spread of an infectious virus helped our understanding of tuberculosis and how to manage it best in the future? How can we be better prepared for future pandemics or future viral clusters which may happen and take us and catch us off guard suddenly? So we begin with today's session with someone who represents the most important stakeholder and voice in either tuberculosis or the COVID-19 pandemic. And we speak about the patient, the individual going through the entire disease process, the entire infection, and therefore suffering as a result of the same. We have Ms. Bulbul Sharma, who will be speaking to us today. She is a content creator, a patient advocate, and a TB survivor. She will talk to us about challenges faced by patients during the pandemic and go through her own personal story of how she survived tuberculosis, the trials and tribulations that she had to go through to get cured of the illness, and how her work as a TB survivor, her work in helping individuals through the COVID-19 pandemic taught her some valuable lessons in terms of how we need to address this problem to best serve the most important stakeholder, who is the patient. We then have the second session by Professor Madhukar Pai. He is the Canada Chair, Research Chair in Transitional Epidemiology and Global Health, and the Associate Director of the McGill International TB Center. Dr. Pai has been at the forefront about speaking about the inequities associated with the care of tuberculosis, the problems that we face when it comes to quality standards, especially in the private healthcare, which is often unregulated, which is often expensive and inaccessible to the majority. He will be speaking to us on his topic today, which is from mismanagement of TB to mismanagement of COVID-19. How can we work towards improving private sector healthcare, in which he will speak about the challenges faced by patients in India when it comes to diagnostics, when it comes to treatment, when it comes to accessing the healthcare, and how these traditional problems faced because of when patients access care for tuberculosis were also faced during the COVID-19 pandemic, and how we need to look at consolidated pathways towards helping patients access care for both diseases. We will then have Dr. Jennifer Furin, who is an infectious disease clinician and anthropologist based at the Harvard Medical School in the Department of Global Health and Social Medicine in Boston. She has worked in the field of TB for more than 26 years, focusing on improving access to the best treatment for all forms of TB for vulnerable populations. When the COVID-19 pandemic hit in 2020, she founded and ran her hospital's COVID-19 service, receiving the hospital's Presidential Medal in recognition of her work on behalf of people affected by COVID-19. The thrust of her talk is that it's not just innovation that helps progress when it comes to disease, when it comes to public health. We know that vaccines and drugs have been innovated at a record-breaking pace when it comes to COVID-19, but these mean little if they are inaccessible to a majority of the world. She will also address stigma, psychological comorbidities, implementing community-based models, and integrating chronic care when it comes to the care of patients who suffer from long COVID and could potentially suffer from similar long-term sequelae of diseases such as tuberculosis. The final talk for today would be a talk by Dr. Rao. Dr. Rao is the DDAG TB of the Central TB Division of the Ministry of Health and Family Welfare in India. And he will speak to us about opportunities and how we need to be optimistic about the future, how the government acknowledges the challenges faced by patients with tuberculosis and COVID-19, and how it is working very hard to improve the care of such patients. He acknowledges the reduction in case notification rates for tuberculosis during the past 2 years and possible losses to follow up. And he will be speaking to us on opportunities to leverage the similarities of the two diseases, the two pandemics. He will speak to us about bidirectional screening, increased funding for tuberculosis, among other innovative ways in which we can address both these pandemics. His topic will be TB in the midst of COVID-19, a golden opportunity to strengthen public health care. I will then hand it over for the Q&A sessions to address all the questions from the audience. I will hand it over to Dr. Bornali Datta, who is my co-chair. She's the Director of Respiratory Medicine at Medanta, the Medicity Hospital. She has extensive experience in treating drug-resistant TB cases, as well as complex COVID-19 cases. She is herself a COVID-19 survivor. So I look forward to the next hour of very interesting debate and discussion related to the two pandemics and how we can move forward, helping patients suffer from either of the two diseases in the future. And I hand it over to the first speaker for today, Ms. Bulbul Sharma.
Hello everyone, I am Bulbul Sharma and I'm a fellow with Survivors Against Tuberculosis. So today, I'm here to talk about the effects of COVID-19 on patients with tuberculosis. But before that, I'll take you through my long and arduous battle with TB. I was 23 when I was diagnosed with a non-pulmonary form of tuberculosis. I had TB in my head. While initially the biggest battle was with getting the right diagnosis, I had no idea about what was waiting for me. Side effects and the related stigma were possibly the biggest challenges for me to deal with. However, I still consider myself fortunate. Why? Because I was diagnosed and treated with TB in the pre-COVID times. So when I say I was fortunate and I was lucky, this is what I mean. Let us look at this WHO's 2020 report on the effects of pandemic on TB and patients and how the services were disrupted. So according to the report, TB deaths increased for the first time in a decade as far as 2020 was concerned. There was a 50% reduction in TB case detection in the same year. The report also estimates that 1.85 million deaths occurred due to TB globally in the year 2020. Now that we decently understand the magnitude, the effect, the great effect that the pandemic had over TB patients and TB services, let us understand the challenges that TB patients continued that the TB patients continue to face. Diagnosis and treatment. The challenge with regard to diagnosis involved and still involves doubts with respect to where to get the tests done, which tests to even go for, the interpretation of those reports, and the next steps. For the treatment, the biggest hurdles faced are treatment adherence, accessing treatment facilities, side effect management, and various others. Nutrition. Nutrition, which plays a major role in the causal chain of many diseases, is extremely important in the recovery of a TB patient. However, food insecurities were created due to the economic slowdown induced by COVID-19. This economic slowdown also affected direct benefit transfers to TB patients, which further crippled them. Mental health. Complete ignorance to mental health forced TB patients into the furthest corners. No proper counseling and follow-ups made the situation even worse. Inability to access services due to disruption in transport and due to the redirection of all healthcare support to managing COVID-19 were bigger problems too. Now, I would like to tell you that these challenges were inferred based on the data that was recorded by SATB's multilingual virtual help desk in the form of queries asked. The virtual help desk is running and continuously providing peer support and expert-led assistance to TB patients and their families. That we have understood the challenges well, let us look at the ways to combat them. Survivors recommends the following. Prioritize case detection, address treatment challenges, address mental health and stigma through peer support. Deploy strategic communications, both in the form of interpersonal communications and a media mix. Create and initiate accessible remote treatment support. There's an urgent need to kind of strengthen those remote treatment systems, or in fact, build them from the scratch, maybe. Create and emphasize community-based care. Engage private health services. It is very important that the private healthcare system now shoulders an equal responsibility with the government, with the government healthcare system, since the government healthcare system rarely crumbles under that kind of a pressure, especially in a high burden country such as India. Strengthen implementation of direct benefit transfers, such as Nikshay Poshan Yojana. Gender responsive care and solutions are equally important. We also need to tackle those infrastructural challenges. And I believe the use of local machinery is very important to do so. Improving interventions and strategies. We need more people-focused strategies and strategies that are derived out of data. Towards the end, I like to say that even though the pandemic has reversed the forward leaps that we had taken as a country to eliminate tuberculosis, it has also helped us understand the vulnerabilities and fragilities of our healthcare system. On the brighter side, however, it has taught us ways to strengthen it as well. I think and I believe that we are now more prepared than ever to tackle TB, which continues to remain an endemic in various parts of the country. Thank you.
Hi, in this session on TB and COVID-19, I will be specifically speaking about the issue of mismanagement or poor quality care in the private health sector. I think we all know that COVID mismanagement has been widespread in India during this pandemic. Polypharmacy, which is use of multiple different therapies at the same time, use of unproven therapies, convalescent plasma is a good example, irrational, unnecessary use of antimicrobials, including hydroxychloroquine, ivermectin, doxycycline, azithromycin, favipiravir, and so on and so forth, untested alternative treatments, unnecessary investigations such as CT scans, approval of drugs without adequate phase 3 trial evidence, abuse of steroids with all the complications around mucormycosis are all critically important examples that we have seen during this pandemic. In fact, during the Delta variant, we documented many state governments and central government guidelines, including all of these medicines, many of which were completely disproven to be of any value in COVID-19 management. And things were so bad that we, India COVID SOS, an international volunteer group, had to come up with these sorts of simple home care infographics on what to do, and also to discourage use of all of these useless therapies and potentially harmful therapies. And this infographic was translated and disseminated in more than 20 Indian languages. But irrational treatments, as we have seen for COVID, is not new at all in India, especially in the private health sector. It has been a long-standing concern with tuberculosis, dating back to some seminal work done by Dr. Mukund Uplekar and others, who documented hundreds of different TB prescriptions, and continued by Dr. Udvadia, Dr. Pinto, and others, who shows that these trends continue to be a problem in India as far as irrational treatments go for TB. And more recent work from our team, a large consortium, now conducted in 5 different countries, where we've used standardized patients or simulated patients or mystery clients. So when you have a patient actor presenting as a classic case of suspected TB, walking into the clinic with a history of 2 to 3 weeks of productive cough, fever, weight loss, loss of appetite, what happens to them when they visit various health sectors. And what we find here are the highlights of these studies in 5 countries. Across all countries, only about a third of these suspected TB mystery clients are correctly managed. Correctly managed means either a referral to the public program or any test for TB, including an X-ray, sputum smears, or gene expert. We find that only about a third are correctly managed. We find that public sector does ask more for sputum tests than the private health sector does. And we find that referrals are very uncommon. Most private providers prefer to manage patients. They do not like to refer. And polypharmacy that we saw so prominently during COVID-19 is dominant in tuberculosis. So when somebody presents with classic TB symptoms, the approach is to use broad spectrum therapies, multiple therapies for once, twice, thrice before TB test is even done. And antibiotics are very, very widespread, including fluoroquinolones, sometimes steroids, and sometimes lots of unnamed pills are dispensed to people with suspected TB in India. And so the key issues as far as quality of TB care in India and in the private sector is low rates of TB testing by private providers, even when people present with very classic TB symptoms, low rates of referral to the National TB Program, empiric management with antibiotics and broad spectrum therapies, multiple rounds before TB is detected, and that results in long patient pathways and diagnostic delays. Chest X-ray is the preferred test, not sputum tests. Use of drug-resistant testing in the private sector is very low, and private health sector doesn't have much capacity to follow up, to look at adherence and treatment completion. And then the high cost of care in the private health sector is another important consideration. So some thoughts on how we can tackle mismanagement, either whether it's COVID or whether it's TB. I think these are critical considerations. One is India needs to come up with very strong national guidelines consistent with WHO and global guidelines. This happens for TB, but it hasn't happened for COVID-19. It's because the national guidelines have been inconsistent and have incorporated untested therapies that many states have also followed this. So a clear evidence-based national guideline is critical, and that must be updated when new evidence emerges. National guidelines must be followed consistently across all states in India. Each state cannot be prescribing its own cocktail of medicines. New drugs must not be approved without strong phase 3 trial data. That should be in the public domain. Better regulation of antibiotics is absolutely fundamental. Enforcement of the Schedule H1, for example. Right now, India's antibiotic consumption is just completely off the charts, and this can prove to be extremely challenging for antimicrobial resistance. Price controls and price caps are necessary to prevent the private health sector from price gouging and overcharging. There must be clear communication about rational practices via social media, newspapers, radio, and television. PPM projects, public-private mixed projects, can be extremely helpful to educate, incentivize private providers to improve quality of care. There must be clear institutional mechanisms to purchase services from the private health sector, and education right from medical students and residents on rational, evidence-based care, careful use of antibiotics. All of that is absolutely necessary. And then, of course, for practicing doctors, ongoing CME programs and retraining is also quite critical. And I think for TB, we have plenty of pilot projects in India showing that we can work with the private sector. We can allow them to manage TB, but we can support them to notify, we can support them to do microbiological testing, we can support them to do adherence and treatment completion. With effort, it is possible to reduce mismanagement and improve quality of TB care. But my last point on which I will close is that if there is one lesson that India should take from COVID-19 and to build a healthier nation, and that is excessive reliance on the private health sector is simply not a good strategy. India must invest more in the public health sector and build a comprehensible, equitable health system that will serve all Indians, not just those who are rich enough to afford the private health sector. And all of you can download a copy of our book, Quality of TB Care. It's available free as a PDF, and we hope that you will find it useful as you think more about quality of TB care and strategies to improve quality of TB care. Thank you.
Hi, everyone. Good afternoon. My name is Dr. Jennifer Fern, and it's my pleasure to join you today via this Zoom recording at your India TB Summit in this session on COVID-19 and TB. Today, I'm going to be talking about how India can use the lessons learned from the COVID-19 pandemic to strengthen and build an equitable healthcare system for infectious diseases. And I'm primarily a tuberculosis doctor, so I'm mostly going to be talking about how to build an equitable healthcare system for tuberculosis, but I think the lessons definitely apply to other infectious diseases. Before I get started, I do just want to say that I hope everyone who's attending this conference is doing okay and that you and your loved ones have been all right during this incredibly difficult couple of years. I don't think any of us imagined that we would still be dealing with COVID-19 today. And so I'm certainly mindful that this has been a really tough 2 years for everybody. But I think it has been 2 years that give us some pause and some opportunities to think about where we can do things better. And certainly in the field of infectious diseases, and particularly when it comes to tuberculosis, we haven't done well for people living with the disease. And in fact, TB, more than any other disease I've ever worked with, seems to be very proud of being a tradition-based approach to disease. And while I think it's important in medicine to acknowledge tradition, we stand on the shoulders of the people who came before us. We have to acknowledge that that allows us to see further and change and innovate. And so we have to be able to innovate. And I think we're learning this the hard way in the TB space. And we know that the TB situation around the world has been markedly impacted by COVID-19 in a negative way. So I'm hoping today to share some thoughts on how we can use lessons learned during COVID-19 to improve the way that we take care of people who are impacted by TB. And then those lessons can apply to other infectious diseases as well. I think the first and one of the most important lessons is that rapid innovation is both necessary and possible to address infectious respiratory diseases. We saw that in COVID-19 where everything happened so quickly, but equitable access plans need to be developed and enforced from the beginning. With COVID, we really quickly got vaccines, rapid diagnostics, new therapeutics, But what we found is those were largely hoarded by wealthy countries or wealthy people, and there were no plans on equity or access. And if anything, COVID widened the health gap that often exists between resource-rich people and nations and those that are resource poor. But TB definitely needs to do more when it comes to innovating. We're starting to show some promise in innovation, but access is too slow or limited. And this includes things like cartridge-based nucleic acid amplification tests or GeneXpert or MolBio. Almost everybody should be diagnosed with TB in this way, and we should have rapid access to information on rifampin resistance, quinolone resistance, but sadly in many places in India, they're still relying on smear and culture, and this is not acceptable. We need to make sure there's better research around all oral shorter treatment regimens for drug susceptible and drug resistant TB, and that they're rolled out equitably. In India, it's really a shame that children are still getting injected, particularly younger children who have drug resistant TB, and this just isn't acceptable. And we also need shorter and better regimens that are accessible for prevention of TB for people who've been exposed. COVID-19 also taught us that facility-based models of care are really risky. And the risk comes both from transmission of infection within facilities, but also from the collapse or closure or even just repurposing of health facilities and facility staff. Community-based models of COVID-19 care were rapidly developed and deployed, but TB in many places still relies on routine interactions with the healthcare system, whether it's for DOT, to give those nasty, horrible injections. And this was devastating for people living with TB disease who are given little to no support and essentially abandoned. We need to make sure that people don't have to go to facilities to take their treatment, that they can be educated and empowered to take their treatment at home or with support as they need, and that there's not a one-size-fits-all model. But we do know from COVID-19 that stigma around contagion is prominent and ongoing for both diseases, and it must be addressed. We know from COVID-19 that infectious respiratory diseases often affect the entire household, and they really require family-centered models of care. And the same is true for TB, the same is true for many infectious diseases, but by and large, we've failed both in COVID and in TB in coming forward with family-centered models of care. And in doing so, we really place household members at great risk. COVID-19 did a better job in terms of contact assessments and tracing systems. They were much more robust than TB, but we still need to address things like disclosure, stigma, different family members' roles, and psychosocial and socioeconomic support must be provided as part of these family-centered models of care. We know that when it comes to infectious diseases, multiplex diagnostic research and treatment platforms are both needed and possible in order to identify comorbidities and provide integrated care. And COVID-19 really revitalized this idea of platform trials to test multiple interventions with methods that can address changing standards of care. They introduced testing with a single specimen for multiple diseases, and then they risk stratified people based on comorbid disease and managed those comorbid diseases. TB really needs to learn from this and come around to using multiplex testing. And we have done some work on TB and HIV integration, but much more needs to be done around testing for multiple diseases with a single specimen, fostering innovation in study design, and providing holistic care for people living with the disease. And finally, we know that the long-term effects of even a short respiratory disease must be addressed. With COVID-19, we hear a lot about long COVID, right? So we know that even if the infectious pathogen is cleared and gone, that there can be lingering effects. And people talk a lot about long COVID syndrome, but TB programs seem to stop caring for and about people once they're given a final outcome. Once that TB is gone, it's not the problem of the TB program anymore. And there's little that's known or done to address long-term issues. And we absolutely have to change this. An infection may clear, but the person may still be living with the consequences of that infection for a very long time. And our systems need to take this into account. So TB has much to learn from the experience of COVID-19, and TB innovation is needed to make up lost ground. It's devastating to hear about the drop-offs in TB diagnoses that are being made. I work in South Africa. I'm seeing tons of families that are just being decimated by TB right now. So we have to do this, and it's not only possible, we did it with COVID-19, but it is our absolute imperative. So I just want to thank you for giving me time with my esteemed colleagues on this panel. My email address is here. If you want to talk more or have any additional questions, please don't hesitate to reach out. And thank you again to you all for all you're doing, and have a great rest of the day. Thank you.
Greetings from the Central TB Division and the Ministry of Health and Family Welfare, Government of India. And it's a pleasure to be part of the India TB Summit. And I'm Dr. Raghuram Rao. I'm a Joint Director in the Ministry of Health in the Central TB Division. Today, I would love to be speaking about how the government has, and the TB program has used and there's a window of opportunity for the TB program, and how have we strengthened the public health care in the country. TB and COVID, being respiratory infections, have primarily attacking the lungs, and the pandemic has brought quite a few challenges to us with additional stigma and discriminatory behavior against people perceived to have been affected with these symptoms, and also for fear of being quarantined or diagnosed of TB or COVID. So the health-seeking behavior has been severely impacted. You could see that with almost 25% reduction in TB case notification in 2019 in 2020 as compared to 2019, where we almost notified 24 lakh cases, and that reduced to almost 18 lakh cases. But you can see in the graph below that in 2021 we were a learned program. The public health infrastructure was a lot more capacitated to handle the response, and like you see during the peak that was there in 2020, where in the month of late March, early April, the nationwide lockdown was implemented, and a lot of restrictions due to control the COVID that had to be mandated. You'll see that the average notification per month, which was in 2019 around 200,000 or 2 lakh cases, reduced to almost 80,000 cases in the month of April in 2020, and then it took almost the year end to reach back to 2019 levels. And you'll see that in 2021, in spite of having a harsher epidemic with severe cases, almost 3 times the first wave, you'll see that the program was able to get back to pre-COVID levels in terms of monthly notifications as early as June, July, with the peak which happened in May. So you can clearly see that because of this impact, we reduced the gap, and we could notify as high as 21 lakh cases in 2021. The evidence that we have seen and the impact that we have seen on COVID and TB, what we could see is that COVID, active TB as well as latent TB is a risk factor for COVID, and it has an impact on the severity and rate of progression of COVID, and it has adverse impacts on the prognosis of TB as well as it leads to higher mortality. And COVID and TB both, since they have common risk factors, have common vulnerabilities for both of these diseases, and co-infected patients almost have a 3 times higher risk of mortality and adverse outcomes. In terms of impact and the mitigation strategies that we could adopt, which is going to help the TB program and the public health response in the long run, is the introduction of the policy of bidirectional screening, means looking for TB among COVID and ILI-SARI cases, vice versa, looking for COVID and among the TB cases. And this has led to early detection of both TB and COVID in those co-infected cases and having a better impact on the treatment outcomes. Also, because of COVID, the program had to come up with a rapid response plan which can mitigate the impact, including making sure that there is uninterrupted diagnostic services and treatment is not interrupted because of want of access to drugs. And in fact, in the recent recommendations, based on all these evidences, active TB disease has been considered as a high risk factor for severe disease or mortality among COVID patients, and the guidance prescribes that if cough persists for more than 2 weeks after COVID, the patient should be investigated for tuberculosis. And accordingly, in the program also, post-COVID follow-up for TB cases, looking to these patients who have had COVID in the last 2 years, go back to them and screen them for tuberculosis every 6 months. And also in post-TB treatment follow-up for, COVID or post-treatment sequelae at 6 monthly intervals. So these are the, technical recommendations that we have incorporated into the national program. In terms of infra and public health strengthening, COVID era has taught us a lot. A lot of investments have happened in getting these molecular diagnostics. There was a time when COVID first came in 2020, and there was a sudden shortage of molecular diagnostics for doing COVID testing. RT-PCR machines were restricted to certain ICMR laboratories and NCDC laboratories. And the only program under the National Health Mission which had molecular diagnostics was the TB program, where we had GeneXpert or CBNAT and TrueNat machines in the system, which was used for COVID testing at that point of time. And then slowly the country then invested into putting in systems for lab testing, and we now probably have RT-PCR labs in every district of the country, and there is so much of capacity in-house that in fact now initially we were a country which was importing technologies, and now we are exporting technologies. So there's a lot of investments and lab strengthening that has happened because of COVID that has a very direct impact on TB, and we have molecular diagnostics almost at the block levels, below district levels, and that will improve case finding, and it has expanded the molecular diagnostic network to over 5,000 laboratories in the country now, which is available for tuberculosis, and it's something which is going to help TB in the long run. Second important aspect of COVID that we have seen is that a lot of investments with additional, over and above the existing money, the impetus, financial impetus that health got, we invested that in improving the infrastructure and getting additional human resources and building capacity of the human resource to respond to critical care diseases and infections of communicable nature. And so now you will under the upcoming things in PM ABEAM and in the emergency COVID response packages that have been given, a lot of investments have happened to develop integrated public health labs at the district level, at the block level, critical care units at the district level. A lot of ICU capacity, oxygen beds capacity has been increased, and all these things are going to help tuberculosis and such diseases of respiratory health and communicable disease, where infectious disease wards are established. Diagnostic capacity to test it at decentralized levels is available now, and in public health surveillance, TB is very keenly looked at now. Everybody knows what is contact screening, what is quarantine, what is isolation, what is self-isolation in the home, and the platform technologies and all those things that have happened is translating into looking for TB in every home visits or household level or outreach activities that happens. So that's going to help us in finding TB in the long run. One very important aspect of public health that we have seen is airborne infection control, which was a dream for tuberculosis program, which was always required, but the larger health system had to take it up. And with COVID now, you'll see that there are cough corners in the hospitals, there are isolation rooms, there is triaging of patients with cough, and ruling out infections, communicable diseases before being taken for surgeries. So a lot of airborne infection controls has been incorporated and established in the public health settings. Apart from that, in the community level, the COVID appropriate behavior and the community, behavior of using mask, of social distancing, of physical distancing, ban in spitting in public places, all those things are, all something which we always aspired for tuberculosis, and that is something which is now available for us, and it's something which we have to invest in and sustain that going forward in the next few years, and that will definitely have an impact on TB transmission. Newer technologies, AI-based tools, X-rays, point-of-care tests, and telemedicine, teleradiology, so many newer technologies have come in, which are now being, going to help TB in the long run, and is now made available across the public health system and at decentralized levels, even going down to the health and wellness center, at the sub-health center, at the primary care level. So all these opportunities which, are because of COVID have been made available is something which is going to help tuberculosis in the long run. So this is in a nutshell what I wanted to share about TB and COVID, and the way it has helped us strengthening the National TB Elimination Program to achieve our targets of ending TB by 2025. Thank you.
What an all-encompassing and enlightening discussion with so much of food for thought. The way forward needs to acknowledge the difficulties faced by patients. We need to always remember that the patient is the center of the healthcare model, and listening to the trials and tribulations that our patients face, listening to their concerns and addressing them by focusing on a community-based treatment model becomes extremely important to address concerns, to address the challenges faced by patients. It's also important to think of bi-directional screening such that we create a framework which could then be applicable to any respiratory illness in the future, any transmissible respiratory illness, not just COVID-19, where we have a model in which patients with tuberculosis can get screened for other viruses when the need arises, and vice versa. When individuals come with any acute respiratory illness, they are asked questions thinking about whether they could potentially have tuberculosis, and then screening them for TB as well. I think it's important, this is an important time for us to talk about preventive measures. I think very little attention has been paid on ventilation in India, and we now acknowledge the fact that ventilation has an extremely important role to prevent the spread of COVID-19. And it has been known for some time that ventilation and close contact play an important role in the spread of TB as well. I think this is an important time to open the conversation around what we can do best to ventilate indoor structures better, and thereby prevent the spread of diseases in places such as schools, in workplaces, in closed, crowded places where spread becomes so easy. I think it's important to normalize masking as well, especially when individuals are ill, when individuals have a cough, when individuals have a respiratory tract infection, to encourage individuals to wear masks and normalize it in a way, in fact, even encourage it and applaud individuals who wear masks when they are unwell themselves. And I think these would be great public health measures for the future. We also need to think about the private health sector, which has always been problematic when it comes to adhering to treatment guidelines, when it comes to quality of healthcare, when it comes to, especially when it comes to tuberculosis. And we've seen the same spill over to COVID-19 as well. I think it's important to address the quality of care with standardized guidelines across the country, and then help implementation of these guidelines at the ground level by dissemination of education. I think last but not least, it's extremely important to focus on psychological care and the stigma associated with transmissible infections. We've seen this in the past with tuberculosis. We saw it during COVID-19 as well. There was a lot of stigma that individuals had to overcome. And I think the best antidote to stigma is very often education. And I think we need to do our best to disseminate education to prevent such stigma. I thank you for a patient listening, and I hand it over to Dr. Bernali Datta, my co-chair, to take over the Q&A and discussions. Thank you. We need to do our best.
Right.
Hi, Chapal. Hi, Bulbul. That was a really good session, and I think we had a representation from a broad segment of people involved in TB in different aspects, and I think Dr. Pinto summarized it very well. And essentially, I think all of us from the respiratory space have dealt with COVID and have been dealing with TB for years, for decades. And then we had this blip with COVID, which of course upset the balance, but as well made us very aware of how we can make things better, and gave us a lot of insight into how our infrastructure can be strengthened. So we'll go over a few kind of burning questions, which are always bound to be there after such a intense discussion on a challenging topic of a dual pandemic. COVID, which is hopefully on its last legs, although it may become endemic and then hang around, and then TB, of course, which has been there with us for centuries even. So if I may address a question to Chapal. So Chapal, what do you think about a recovery plan from COVID-19? How do we ensure that diagnostics and therapeutics for TB and COVID are universally accessible in high burden, resource limited settings like ours, like in our country? What would you say, Chapal?
Thank you, Dr. Datta, for this question. I'll take a couple of minutes because I think a lot of people have alluded, and one of the themes of this conference has been how COVID has impacted TB. But the truth is, COVID has impacted the entire health system, and we need a recovery plan, not just for TB, but for almost all diseases. Because immunization is down, women's health has suffered, cancer treatments have suffered, all kinds of diagnoses. In TB particularly, this has been very, very harsh because we have noticed that the notifications fell drastically during the first few lockdowns. And as you know, the nature of TB is such that, and something that Dr. Rao also alluded to, and so did Dr. Pinto, and you know this as well, that TB as a disease can very easily be mixed up with COVID, and there can be delayed diagnosis. So I think what one needs is a TB recovery plan, which is not just for the 6 months or 8 months, but really for a few years. Because we we who work in TB do know that despite the challenges, there was progress being made. And COVID has really not put us back 2 years, it has really put us back 8 or 9 years in a way. So India and all other high burden TB countries who also had a high burden, and there are very few now that didn't, of COVID, need a TB recovery plan. What would be the elements of that in a low resource country, and also a country where the health system is already overburdened, whether it's the public or the private? There are some elements. One, of course, is it's very easy to say political will and better resources, and they go hand in hand because, of course, you need political will and resources. But also some of the things that a lot of the speakers have already alluded to, which is the access to diagnosis, which has to be really expanded and strengthened. Dr. Rao referred to bidirectional screening, and so did, I think, Madhu and Dr. Pinto. All three of them spoke, and that is really critical, that we bring convergence between the systems. The other thing that I would say is that access to and actually an emergency preparedness plan, because we were totally caught off target and we were thinking on our feet, and sometimes we didn't know what lay in front of us. So I think that should not be the case. The other three elements that I wanted to refer to is one that was talked to by Dr. Udvadia, but also by Dr. Pinto, and Dr. Rao also alluded to it, which was remote patient care and support. This is possible in TB also, and I think we're not going to double our TB budget tomorrow. So we have to think of technology and innovation as the way. We're also always going to have a finite number of doctors and health workers. So we have to equip them with the challenge with innovations that can address these challenges. There's also the point of convergence that I wanted to mention, since you asked me about both public and private in low resource settings like India. So when we were running the SCTB help desk, one of the things we found was that mental health support was really lacking, patient education was really lacking. So it was not that the patients were helpless, they were willing to help themselves. But I think what was needed was that did they have the actual information? Did they have the protocols? And again, one of the speakers alluded to it, that how quarantining or mask wearing have become norms. So as part of the TB recovery plan, we really need to look at these issues as part of being a way to addressing TB. We also need more community-based systems, because one of the things that we realized is that there was no community support left. Once the ASHAs and the health workers got redirected and the private sector was just overwhelmed, with lines outside hospitals, which you have been witness to, it was just impossible to, we couldn't double them overnight. So I think community-based systems of care was also very important. So these are some of the issues that I think one could certainly take in a TB recovery plan if we were to imagine one for India. Thank you.
Yeah, no, that's I think you've almost you've pretty much touched on every relevant aspect of this recovery. And I think you're right that in some places it has been a huge learning it has been a setback, without a doubt. I think WHO has said it has set us back by a good 10 years. And that's what you said. And from the TB, achieving the end elimination of TB goals from the SDGs that we had planned, and that is how it is. But then equally, the key thing is that the learnings that we've had from this entire pandemic, and I think we can use so much of that towards improving TB care in all the various aspects that you just mentioned.
I actually wanted to also ask a follow-up question to you, Dr. Datta. Now, one of the things that has emerged post-COVID is that how critical the private sector is in TB, because a large majority, whether it's me or it's Bulbul, a lot of us basically go to the private sector to seek care. For various reasons, part of it being that the public sector is very overburdened and there is long waiting time, and so how do we this what I was talking about is really more from a public sector perspective, but in the private sector, you're a leading private sector physician. How do you think people can how can we ensure proper care and high quality care for TB in the private sector? Also, because as you know, there are challenges both with TB and COVID, but also more prominently around issues of private sector care. How do we improve those, and how do we bring about a change which is for the positive for TB affected communities?
Yeah, no, absolutely right. So, I mean, so private sector, so from, where I sit, I mean, even till date, 40% of our OPD follow-ups will be of tuberculosis, different aspects. It may be pulmonary or extrapulmonary. And of course, that is something that, all of us deal with, and we try to ensure that we align ourselves with the government model as far as possible, following the latest algorithms, diagnostic and otherwise. Now, people who seek treatment in tertiary healthcare centers, I think they do fine, they do well. I don't think there's much of a problem with that. The only place that we had struggled a bit was DR-TB treatment, because the newer medications, the shorter regimens were just not available to the young DR-TB patients who would come to private sector, who would want to continue care with us, that we weren't able to offer them things like bedaquiline. But that has changed now, because Medanta now has a DR-TB center, which we have developed closely with the state. And we are going to identify our patients, and the ones who want to carry on treatment with us, the state will provide these medications which are not available. So I think it's important for even in tertiary care centers to understand the lacuna, to understand the gaps that are existing, and to try and address it. Because after COVID, I think the working of private public sector has been the best that we've seen. It was like a teamwork. It was a phenomenal team effort. And I think we must, hang on to that, because healthcare ultimately, you just want healthcare to be available to every individual who needs it. So that's what health equity is about. And I think private sector, apart from the COVID thing, must continue to be engaged with the public health burden that the country faces. I suppose the other aspect of private care are the smaller private practitioners, especially if you go far out in the districts and in the more rural areas, who are sort of away from regulatory kind of systems, and they are practitioners. They've been looking after their local community very well, and I think what they need more than anything is support from the government and others, so that in some way their practice becomes more robust and the patients therefore benefit. So maybe they can start the treatment for TB, but the patient may get it for free from the government center, and then at least we are ensuring that the patient gets the correct treatment, the adequate length of treatment, and things like that. So I think there is a lot of potential in these engagements, and during COVID, of course, apart from healthcare, private healthcare organizations, I mean, there are so many corporates, and with the mandatory CSR, there is now a huge drive for all companies to utilize their funds in a very meaningful way. And we've had a recent series of engagement with so many corporate partners, and we have been really assured of quite good support vis-a-vis mobile vans, the equipment like CBNAT and things like that, which are, and as you rightly said, technology is a key thing. We can't achieve anything in this current day and age, and we have access to so much technology, then we should really utilize it. So I think that it's multi-pronged. I think in many ways we can kind of address this private-public gap, and COVID has helped us, and we should just continue to engage very closely and kind of fight the battle together.
I was wondering if we should also get Bulbul in and ask her, Bulbul, one of the things that Dr. Datta and I were discussing before this panel was that from a survivor perspective, what is the kind of support, particularly patient support or mental health support, that TB patients or TB affected individuals needed, especially during the pandemic, and what kind of interventions you think might help?
Oh, hello. So, Chapul, thanks so much for the question. But before I go on to answer this, I was just simply wondering, when we talk about how COVID can help us treat TB better, or, kind of strengthen TB services better, I was just wondering that why could it not happen the other way around? I mean, with both TB and COVID being similar in terms of clinical manifestation, why could we not learn from, TB services and deal with COVID better? So that's just one thought that I had. And I think we certainly have lost that part of the battle. That's already gone. And now coming to talk about the services that possibly I would have appreciated, or I'm pretty sure those who are, still struggling amid the pandemic, the TB patients, especially, I think that would be to begin with, to deal with mental health. When I talk about mental health, I talk from a very privileged perspective. Why? Because I had everything taken care of, and all that I was dealing with personally was not getting to know where I was going in terms of treatment, because I suffered from extra pulmonary form of TB, and it was unfortunately in my head. So the diagnosis was a big problem to begin with, but more so the biggest challenge for me, and I'm pretty sure for others as well who possibly come from similar socioeconomic background as me, is certainly mental health. Till date, I get anxious thinking of what if I get reinfected, right? So I certainly do not have those answers yet. What will happen to the in case I get reinfected? Second would certainly be, as Dr. Datta talked about,
strengthening or kind of providing support to these private practitioners. So I am I live in NCR. However, the services in my city are not as are not really high standard in that sense. So I just went back to the time when I was diagnosed, and I was told by one of the practitioners to possibly approach somebody in AIMS and Apollo, and I thought, this is the end of my life. I'm never going to be able to live a normal life again. So to just think of this, and how, though I had all the support needed in the world, I'm just thinking of all the people who could not really fathom and could not really understand what to make out of that discussion, right? So I believe this is a very important measure that we need to take as community who's trying to fight TB and trying to help the survivors. Another problem that I faced, considering that I undertook ATT drugs for like 4.5, 5 years. Yeah, I mean, all I had to do, because I come from a privileged background, was just take my medicines, start my day. However, I might feel nausea and I would vomit. I might vomit the entire day. But again, I had people taking care of me. And all I had to do was promise that I'm going to take my drugs right. However, I know it for a fact that not many people have that kind of patience. Right? If it was not for the persistence of my parents, I wanted to leave it, because I was undergoing a lot of hair fall. I had breakouts. I was just not I was just not able to cope with all, and also for a very long time I was not able to walk right. So I mean, TB treatment adherence is certainly a challenge. And at this point of time, or, what we saw 2 years back, and maybe in some areas we still might see that the facilities are still, or major chunk of healthcare facilities and system is redirected still to kind of COVID treatment and COVID control. So in that respect, I feel this is another problem in terms of kind of TB patients, and the measures we kind of need to ensure that the treatment is better and adherence is better. Yeah.
I mean, I think these are very, very, very relevant points, and thank you for bringing them up, because I think the fact that you recognize that you were privileged and that you still had challenges is a very important thing. Dr. Datta, I want to turn to you, because in a sense, with the COVID-19 thing, our privilege has manifested itself, but it's also made all of us sort of helpless, because especially those affected by TB, because everybody was trying to get access to services and support was limited. How do we address that in the health workforce, as a health workforce issue or as a systems issue?
Yeah, no, it's I think it's challenging, and I think I appreciate everything that Bulbul just said, because we have patients. I have young women who are, and you can see, you live with the entire treatment period with them, and you can see the anguish they go through. You have the medications are tough, the side effects are tough, and you're at an age where you really are not expecting to have a 2-year, 4-year kind of treatment. You just want to get out there and get on with your life, and this just holds you back. So I totally understand that, and I think it is so important to have support, basically, and I think that is a huge lacuna in our entire treatment, the kind of 360-degree care that we talk about. We've become very good at diagnostics. We've become good at treatment. We have all regimens, everything available now. But the point is that what is still lacking is the patient, access to all of this, and secondly, as you pointed out, Bulbul, adherence. I think adherence is a huge thing. Until we ensure that the patient adheres and completes, we have not completed the loop. Just diagnosing, starting treatment is simply not enough in a disease like TB. And again, as Bulbul pointed out, this. So why the difference? Why did we not learn from TB, which has been with us for centuries? I think that's why, because TB is the bug has just learned, has learned to coexist with humans. So it's an indolent disease. It won't annihilate the human race. It'll just go on living along with causing a lot of morbidity, mortality in human beings. but over a period of centuries. Whereas COVID, these kind of pandemics, viral pandemics, when they come, they could potentially just wipe out the human race, which is, of course, they won't do that because the virus also wants to just live forever. So the best bet for the virus is also a low-grade infection that keeps going. But that's the reason, I guess, why, although TB has been probably the longest known infectious disease to man, it's still, causing so much havoc, and we've still not been able to control it, because it's not just a medical disease. It's socio-economic, cultural. There's so many stigma. There's so much attached to it. So therefore, it's a genuine challenge, I think, far more than any other disease that we come across. Coming back to Chapal's thing of support system, I think that is the healthcare worker support, I think, is difficult. I think we have inadequate doctors, we have inadequate workers in the periphery, ashas, Anganwadi workers. If you start right from the grassroots, we don't have the ratio needed for our population. Having said that, I think in the rural zones, we've worked a lot there, and ASHA workers and all, I think they are our, they are the strongest pillar we have, because they're from the community, closely connected with the community, but they deal with every aspect of healthcare. So, that it's unfair to expect the same person to deal with maternity, childcare, and TB, and whatever, everything, and diabetes and HIV. So however, they're doing it because their role is entirely incentivized, so they have to do it to make any money at all. But and then there's Anganwadi workers, multi-purpose healthcare workers. Then it comes to when you come to the actual TB program, it gets a bit more streamlined. You have the treatment supervisors and lab technicians, and then you have the medical officers. And so that is, of course, I'm talking about the rural setup. And in the private, again, you'll see the doctor will write a prescription, then you disappear, and and there's possibly no further connect. So I think, unfortunately, I don't think it is a problem that has been resolved, but I think which is really asking to be resolved. And we have now got educators, but I think possibly we need psychologists as well. First is the doctor, who needs to be empathetic and really, really engaged with the TB patients undergoing treatment. And I think we do try to do that, especially, the younger people who suffer much more because of the reasons we just went through. And I think it's for the physician to give time, no matter how busy, and then to have maybe a psychologist, maybe a educator, who will just be a point of contact for the patient, who can just have a one-point contact for doubts, queries, negative thoughts, whatever comes into your mind. Somebody who can just at least, maybe not address all of it, but at least connect you with who can, or at least be a sounding board. So I think, we'll need resources for that. Ultimately, it all boils down to that. We need resources to appoint support system for healthcare as well. And it's for us to just keep trying in the best way. But I think getting the patient's perspective gives us so much of a reality check as to what is needed. It's not just the pills, like Bulbul pointed out. The pills she popped in her mouth because her parents just put it in front of her, and that was fine. But you still lose the will to do anything, because you don't, at this age, you don't kind of expect something like that. I think I've totally diverted from whatever Chapal asked me, but anyway.
No. But I think it's very interesting also, because
And
I
very
think
relevant.
Yeah, and very relevant also, because I think when one thinks of the changes post-COVID, right, because we are really talking about changes post-COVID in TB and also in the healthcare system per se, because TB doesn't stand on its own. These are very relevant, right? Because what you said, what Bulbul said, because if we are just going to talk about only diagnosis and treatment all the time, we are going to fall into the same trap all over again, which is to say, okay, I've made diagnosis available everywhere and I've made treatment available everywhere, but the actual end user is not really having a say in what they need. So I realize we have just 4 to 5 minutes left, but I wanted to ask you very briefly, all of you, two things that you want to change in the public or private healthcare system, very briefly, that post-COVID, because I think COVID is, a lot of people have been saying COVID is a crisis, but it is also an opportunity. So if we were to see it as an opportunity, and the National TB Program speaker, Dr. Rao, was also saying this, it's an opportunity. We are seeing it as an opportunity. So how do we take that discussion forward? Two things that you think can change in the public and private sectors that would help us recover from COVID, but also use COVID as an opportunity to start a discussion, about how TB can be improved. So, I mean, I don't know, Purnali, do you want to go first?
Shall we let Bulbul, because I've done a long speech.
I mean, I don't know if
you take over and then I'll follow.
Can you hear me?
Yeah, sure. So first off, since I have been an extrapulmonary patient, I really feel the understanding of people and of everybody I've met, and I have, because though I get really anxious while I talk about my story, I do not know until date. I feel very anxious as I talk about what I have gone through. I really feel that there is this gap in terms of understanding that there is this extrapulmonary form of TB as well. I'm not going to infect you, but I need your support, right? So that first, that, and second, I just realized, though I'm so sorry, Chappal, I might digress, but I just realized that we do have, it was really we had these COVID leaves into system, right? I'll talk about my experience as a student, and now as a working professional as well. We quickly had these COVID leaves in system, but we still do not have these TB leaves in system. I mean, I have done my post graduation in journalism from a government college, and at that point of time as well, because of course I could not attend college my classes for the longest time, I could not sit for the first sem exams. However, anyways, at that point I was feeling it is so unfair, and I still feel it has been so unfair to me, right? When I, being an extremely a diligent student, I'll take the liberty to say that I could not sit for those exams, and I had to sit for those exams again, and I could not sit for the placement services as well, because I had my first some exams missing, for that matter. So I do not know, while we talk about TB and while we talk about awareness on that level, and when we have such meets and when we have such seminars on a regular basis, I do not know why are there no policy changes happening. I have no idea. And imagine TB leaves for active TB patients is such a relief. Just imagine that. Especially for pulmonary forms, right? So I believe first, awareness around extrapulmonary forms of TB, and second, I believe it is very important that we not just kind of integrate and converge private healthcare with government healthcare, but we also need like corporates for that matter, MNCs for that matter, to not just kind of hold such seminars or hold big seminars around TB or awareness, but kind of take those measures. Yeah, those ground measures that kind of can help people like me or others. So, just simply these two suggestions. Thank you.
No, these are very, very helpful. Purnali, do you want to?
Yeah, no, absolutely. So I think that you're right. A lot of the time it's all lip service, without actually doing something. So I think I agree that when we say something that we just must. So coming to your question, Chappal, so I think one of the key things Dr. Rao mentioned, everybody's mentioned, is the behavioral change that COVID has instilled in us. We are much more conscious now about spitting and coughing and wearing masks and, staying away, keeping a distance and not sort of, of course, all boundaries dissolve when there's festivals, and you'll find there is, whether it's COVID, TB, there'll be no effect. And human behavior ultimately is what these diseases ride on. And that's something, that's, possibly never going to change to the extent we want, but at least a degree of awareness, at least a degree that, okay, and if we continue to mask and we continue to, be at least aware of this. It will not be for TB still. It'll still be because of the fear of COVID returning. And I suppose TB will never, realistically, TB will never gain the kind of traction that COVID has, because COVID, it was like every human being, was a susceptible kind of individual. TB, obviously the healthcare services and people who've undergone it are aware of it, but the larger public is still, a lot of people will say, oh, we still have TB in the country. So there is a huge amount of ignorance also for that. So if the behavioral aspects, continue, then pulmonary transmission of pulmonary TB, there will be hopefully some benefit to that. The second aspect, I guess, is stigma. So stigma, I think, is, apart from all the medical aspects, the social aspects become so important in diseases, because, so Bulbul, you won't encounter that living in a city, being a young professional and, very articulate, very kind of positive attitude. But, I did a qualitative research with women with TB in the villages. and sometimes they are in such a bad situation, like a young daughter-in-law of the house, for example. If you are in a family that is not supportive, imagine what you go through. I mean, the disease and your state of mind. So that stigma, because during COVID, obviously we started off with huge stigma around COVID, and all the houses had that sticker slapped on, and whatever, everything. But equally, every individual knew, as we went on to the next year, the second wave, the third wave, everybody knew that, look, anybody can get it, and that's the same with TB. TB has a bit more immune system, etc., but literally in a place like India, where we have such high incidence and prevalence, anyone can get TB, just like anyone could have got COVID or can get COVID. So the stigma has to be put away. I mean, there are different diseases. COVID is a 2-week disease. TB is a 1 year long, and sometimes, as Bulbul said, it can go on for years. It's that kind. But the stigma has to be dealt with, especially for the vulnerable, the weaker sections, women. You have a disease which is not your fault, and it's why should you be put through so much mental suffering because of that? I mean, as I said, medically, diagnostic, drugs, we have everything. So we have to give that access. We have to support the patient through the treatment. And again, easier said than done. It all sounds, I mean, we all know this is what's needed, but to actually implement it is, just not easy. But if we could put the stigma aside and treat the TB patient as a patient who needs support to just complete treatment, it's a curable disease. It's a perfectly curable disease. Then why not? So I think these are some of the, at least, messages from COVID that one could take home.
Thanks. I think those were very, very useful, both of them. But I think I would echo what you and Bulbul said, awareness, stigma, mental health support, but also investing in our health workforce. I just want to remind people that our health system is really tired after COVID. Our doctors have worked very, very hard. Our health workers have worked non-stop for 2 years. So actually, you really do need to give them a break. If you want a recovery plan, these people are going to implement it along with the communities. So you really need to invest in them. You need to pay them better. I know that's a tricky issue, but it's not an insurmountable one, because during COVID, we all know how many doctors lost lives, how many health workers lost lives. Every single health worker or doctor's family, or even the essential workers' families, were affected. So I think that's also something you must remember when you think about a TB recovery plan, that the people who are the foot soldiers on the ground, or the doctors who are treating TB, they need a break and they need investment too, because our expectations from the health workforce are often unrealistic, because we forget that they are human beings too. This is a job. This is not their life's purpose. I mean, they treat it like their life's purpose, but it is not the only thing that they do. So I think one has to be empathetic and considerate towards them as well. So I mean, I would end by saying, because we've run completely out of time, that investing in the health system, but also the health workforce, is critical if you want a TB recovery plan from COVID. Thank you.
Thank you, Chapal. Thanks, Bulbul.
Thank you.
That was a great discussion.
Hello, I'm Sandhya Krishnan and I'm a TB survivor. Today I want to talk about how TB affects people of all genders. As a woman with TB, I struggled with how to fulfill my role as a mother of two. I constantly feared passing my disease on to my children. For the first few weeks of my treatment, I couldn't even hug my kids. But for their safety, I knew I had to stay away from them, no matter how painful it was. TB affects men, women, and transgender persons differently. But all of us require the help of our family, our community, and our caregivers, doctors, nurses, and others, in order for us to fight the illness and its impact on us. TB affects people physically, emotionally, mentally, and financially, and they need our support. As a society, let's come together to support individuals of all genders in the battle against TB. For more information on TB, download the Talking TB app. You can also write to us on Facebook, Instagram, Twitter, or ShareChat.
Hi, my name is Diptendu Bhattacharya. I am a scientist. I am a teacher. And I am an MD TB survivor. I had started my PhD at IIT when I was diagnosed with MD TB. We don't realize or talk about it, but the stigma of TB takes a deeper toll on the patients than the disease itself. Why do people discriminate against the patients with TB? It's not our fault. Anyone can get TB, even you. Few people called me in the first 6 to 7 months. My guide at IIT didn't want me to continue under him anymore. When I was detected with MDR, I realized I had to confront that stigma. We all are fighting something. I got TB, I fought it and defeated it. So can you. Let's talk about TB and let's end its stigma.
नमस्ते, मेरा नाम सिया है। मैं 12 साल की हूँ और मैं स्कूल में पढ़ती हूँ। मेरे को पढ़ना पसंद है और अपने फ्रेंड्स के साथ खेलना और बातें करना पसंद है। मैं कहानियाँ पढ़ती हूँ, घर पर गेम्स खेलती हूँ। सबसे ज्यादा तो मुझे भूतों की कहानी सुनना पसंद है। बहुत दिन पहले छुट्टी में मैं अपने गांव गई थी। गांव में मैं अपने दादा और अपनी दादी के साथ रोज घूमने जाती थी और फिर वहां जाकर मैं बहुत बीमार हो गई। मेरे गले पर एक बड़ा गोला जैसा बन गया था। अप्पा और अम्मा काफी डर गए थे। फिर वो मुझे गांव में नमस्ते, मेरा नाम सिया है। मैं 12 साल की हूँ और मैं स्कूल में पढ़ती हूँ। मेरे को पढ़ना पसंद है और अपने फ्रेंड्स के साथ खेलना और बातें करना पसंद है। मैं कहानियाँ पढ़ती हूँ, घर पर गेम्स खेलती हूँ। सबसे ज्यादा तो मुझे भूतों की कहानी सुनना पसंद है। बहुत दिन पहले छुट्टी में मैं अपने गांव गई थी। गांव में मैं अपने दादा और अपनी दादी के साथ रोज घूमने जाती थी और फिर वहां जाकर मैं बहुत बीमार हो गई। मेरे गले पर एक बड़ा गोला जैसा बन गया था। अप्पा और अम्मा काफी डर गए थे। फिर वो मुझे गांव में डॉक्टर अंकल के पास ले गए। पता है, डॉक्टर ने टेस्ट करने के बाद कहा कि मेरे को तो ट्यूबरकुलोसिस या टीबी हो गई है। अब पूछो कि टीबी क्या होती है? ये बीमारी बैक्टीरिया से होती है। बैक्टीरिया पता है ना? ये बहुत छोटे छोटे कीटाणु जैसे होते हैं। ये नजर भी नहीं आते। वैसे तो ये हमारे फेफड़ों पर हमला करती है, लेकिन इसके कारण हमारे शरीर के दूसरे हिस्से में भी इन्फेक्शन हो सकता है। पता है, मुझे तो टीबी एक भूत जैसी लगती थी, बहुत डराती थी। फिर ना मुझे डॉक्टर अंकल ने समझाया कि टीबी तो किसी को भी हो सकती है, लेकिन सबसे अच्छी बात तो ये है कि इसका पूरा इलाज हो सकता है। तब मैंने फैसला किया कि मुझे इस बीमारी से लड़ना ही होगा। इसके बाद 2 साल तक मेरा इलाज चला, क्योंकि ये वाली टीबी ना कुछ अलग तरह की थी। इतने दिन तक इलाज चलने के बाद भी मैंने तो सोच रखा था कि टीबी से लड़ती रहूंगी। इसकी दवा मुझे इतनी कड़वी लगती थी, फिर भी मुझे जूस के साथ ये दवा लेनी पड़ती थी। कभी कभी तो मुझे उल्टी भी होती थी, लेकिन फिर भी डॉक्टर अंकल कहते थे कि अगर मुझे ठीक होना है तो दवा लेनी ही पड़ेगी। मैं रोज अपनी टैबलेट खाती थी और बहुत सारा अच्छा खाना भी खाती थी। मैं रोती भी थी, लेकिन हमेशा नहीं, सिर्फ कभी कभी, क्योंकि मैं बहादुर और स्ट्रांग हूँ ना। इसके बाद फिर कुछ ही दिनों में मैंने टीबी को हरा दिया। मैंने देखा कि ये भूत तो खुद ही डर कर भाग गया। मुझे बड़ा मजा आया। याद रखें, टीबी किसी को भी हो सकती है, लेकिन अगर हम अपना ख्याल रखें तो इसके बैक्टीरिया को फैलने से रोक सकते हैं। आप सब लोग टीबी के लक्षण ध्यान से सुने और याद भी रखें। आपको बहुत सारी खांसी होगी जो 2 हफ्तों के बाद भी ठीक नहीं होती। सीने में दर्द होगा, खांसी या बलगम में खून निकलेगा। इसके अलावा अगर खूब ठंड लगे, रात को पसीना आए, भूख ना लगे या बुखार आए और कमजोरी जैसे लगने लगे, तो समझ जाना कि कुछ तो गड़बड़ है और तुरंत डॉक्टर अंकल के पास जाना। याद रखें कि आप भी टीबी को रोक सकते हैं। हमेशा मुंह ढककर खांसें, और यदि आपको टीबी के लक्षण दिखाई दें तो तुरंत ही टीबी की जांच करवाएं। टीबी की जांच एवं इलाज सरकारी अस्पतालों और कुछ निजी अस्पतालों में मुफ्त में करी जाती है। टीबी का इलाज पूरा करना जरूरी है। और हाँ, एक बात और, किसी भी टीबी मरीज के साथ भेदभाव कभी नहीं करना, क्योंकि उन्हें भी तो प्यार और देखभाल की जरूरत होती है। टीबी का इलाज हो सकता है। आप इस बीमारी को हरा सकते हैं, जैसे मैंने हरा दिया। अच्छा, चलती हूँ, होमवर्क का टाइम हो गया। बाय।
Greetings. My name is Nina Russell, and I work at the Bill and Melinda Gates Foundation, where I serve as the Director of TB and HIV prevention. Many, many thanks to Survivors Against TB for asking me to participate in this important meeting. I'm going to talk briefly about some of the ongoing and potentially exciting TB vaccine advanced clinical development programs that are underway. And let me start by saying that India, specifically the Serum Institute of India and ICMR, has undertaken the most extensive late-stage development program of any current TB vaccine candidate. There is a constellation of trials going on with a recombinant BCG vaccine called VPM1002. Specifically, Serum Institute and ICMR are currently sponsoring 3 ongoing TB vaccine efficacy trials: a phase 3 proof of infection study in infants in Africa, a prevention of recurrence trial in recently treated TB patients in India and Bangladesh, and a prevention of disease trial in India in household context, which also includes an arm evaluating a second Indian vaccine called Imivac. So there's lots of interesting data that we anticipate seeing from all of these studies. The Gates Foundation and our partners at the Gates Medical Research Institute are also advancing a few other approaches that we think are potentially promising. Our most advanced candidate is the M72 vaccine. This was a vaccine that was initially developed by GlaxoSmithKline, and then in 2020, the Gates Medical Research Institute obtained a commercial license from GlaxoSmithKline to continue the development of the vaccine and advance it for use in lower and middle income countries. So now the Institute is preparing the many steps that will be required to take it into phase 3 clinical testing. The M72 vaccine is a fusion protein, which means it consists of 2 tuberculosis antigens delivered in combination with GSK's proprietary immune-enhancing adjuvant called AS01E. There was a previous phase 2b efficacy trial with M72 that reported initial results in 2018 and 2019. And this is important because the results of this earlier trial demonstrated that the vaccine was safe and that the overall efficacy of the vaccine for protection against TB disease was around 50%. And while this level of efficacy certainly doesn't compare to what we're now accustomed to seeing with COVID vaccines, this was a landmark result for TB and the first vaccine since BCG vaccine that has shown significant efficacy in humans. And we believe that a vaccine with 50% efficacy for prevention of TB disease that might also ultimately prove to provide some protection against TB infection as well could make a very significant impact on reduction in TB incidence. So now a considerable amount of work is underway to verify this result and to develop the M72 as a potential product. Another vaccine under evaluation is revaccination with BCG. In other words, boosting young adults who were previously vaccinated with BCG at birth. It's well established that BCG at birth it confers good protection for approximately a decade, but there isn't much protection beyond that. And this BCG revaccination approach comes from a phase 2b study that ERAS published in 2018 on the efficacy of BCG revaccination in adolescents for prevention of infection. And this study showed significant protection, around 45% against TB infection. This was, of course, a very interesting result since it's an existing vaccine. So in follow-up to this study, the Gates Medical Research Institute is currently conducting an ongoing confirmatory phase 2b trial, a slightly larger trial in 1,800 adolescents aged 10 to 18 years of age. This completed enrollment last summer, and we're hoping for results in 2024. Lastly, briefly, there's some exciting work going on using the mRNA platform that we've all learned so much about during the COVID pandemic. We have a partnership with BioNTech to develop an mRNA vaccine for TB, and we're hoping to initiate a first-in-human clinical trial before the end of this year, end of 2022. So this is still in an early stage, but lots of progress being made. So these are very exciting times for TB vaccine development. It's going to take a few years to generate the data that we'll need to understand which of these approaches is likely to be most impactful. But we hope to leverage all the momentum that has been generated by COVID vaccines and really move as quickly as possible. Thanks so much. Bye-bye.
Yeah, hi.
Hopes to evolve an approach that guides efforts in everything from awareness, diagnosis, treatment, support, and nutrition that remain challenges in TB care for these vulnerable groups. Let's meet our speakers today. We're joined by Dr. Bornali Datta, who was in our last session as well. She is a clinician and associate director at the Department of Respiratory and Sleep Medicine, Medanta Hospital. We have Dr. Abhishek Royal. He's a doctor and public health professional working with the Humsafar Trust. Hi, Dr. Bornali. Thank you for joining us again. And we have Ashna Ashish, who is a public health professional, lawyer, and MDR TB survivor. Welcome. Thank you to all of you for joining us in this session, and thank you to our audience for being here. We are happy to take your questions as well today. And with that, let's dive in. So we're keeping this as an open forum and a discussion. I'm going to throw the question open. I'm happy for anybody to pick it up if they'd like to go first, or if you prefer that I will identify one of you, I'll do that as well. I do see we have a lot of people popping in and out, so let's go with connectivity issues as well on this one. So the first question might seem very obvious, but I think sometimes it does beg statement. So I'll ask for each of you to share your views on this. What is the relationship between gender and TB? Are some genders more vulnerable than others when it comes to TB and accessing TB care? And if so, how? I think each of you could bring a rich perspective from the work that you do. So who would like to go first? Dr. Abhishek, Dr. Bornali, Ashna?
Yeah, I mean, I can go first, but I think, Sandhya, best you point out which one, otherwise we'll be anyway. Yeah, no. So definitely. So I think you're right that all of us will have perspectives, and I know for sure Ashna will have hers, and I'm sure Dr. Abhishek and will too. And now, so I see TB patients in two aspects. One is as a clinician sitting in the hospital OPD and inpatients, outpatients, in whatever capacity they come to us. And then we also do a lot of rural work with mobile vans in the districts of Haryana. So these are two sort of very starkly different, aspects of TB that we see in the patients. And certainly I have to say that, gender forms a huge thing. And as we know, the difficulty with TB is that it's not just a medical disease. It's a disease that is so governed and influenced by social, cultural, economic, religious, etc. There's so many factors that influence the development of TB, the economic deprivations that make you more susceptible to TB, than your access to healthcare. And certainly gender plays a key part of this, especially in our dealings with rural women. We have seen that women, and this is nothing new, we know this very well, that women are stigmatized far more. They have poorer access to healthcare. They have lesser support from family and the community per se, and they are often felt to kind of, they often go on to feel that they are to blame in some way for getting the disease, for being infectious, etc., etc. So I think gender in this regard plays a huge role. What we have seen in the rural communities, I have done some qualitative research amongst young women there, and I think it is not easy. In the hospital setup, maybe it's a little different, because these are again young women who have a voice, who understand, who have good family backing, and many are well supported. That doesn't reduce the difficulty of the disease in any way, and of the treatment and the protracted treatment that sometimes and that no amount of support and medical care can ease that for you. That is still something that you need a different kind of support with. So I would say that women definitely fare a bit worse, and that is I know that is what is expected. We hear it, and then of course I know you will come on later with maybe other issues across gender, but yes, as a basic, men and women will always fare worse, and I think that is across the board in any country, and especially in a developing country like ours more so.
Thank you. I mean, I can tell you that having access to hospital and the best of care, I've been shamed by healthcare workers being told that, you society ladies diet, and that's why you get TB and stuff like that, when I was working like 14-hour days and stuff. So I hear you completely. I mean, if it's that way in an urban setting, the situation in other places can only be worse. Dr. Abhishek, gender and TB.
Yeah. Thank you, Sandhya. Very well put forward by Dr. Banali. It's like I'm going to talk about the other genders, gender minorities, transgenders, gender ambiguous people, I would say. See, what happens is the dynamic is slightly different when it comes to gender minorities. The thing is that there are different reasons for vulnerabilities in this population towards getting infected towards TB because of the lifestyle, the struggle that they have faced in their entire lifetime. They have always been malnourished. The nutrition level is actually very low because most of the times they are not. Uh, Especially the transgender hijra population, they are not living with their families and they are struggling to earn for their lives, so they are nutritionally deprived and they're malnourished most of the times. So that nutritional perspective seeps in very well with these kind of population. Most of these populations are not very well earning because livelihood is something that is very compromised in these populations. From that perspective, they are into odd jobs, begging, or I would say toli badhai, dancing, bar dancing, or into sex work. These kind of profession actually makes them nutritionally deprived, increases a lot of stress level in their lives, so which makes them ultimately compromising their immunity and making them vulnerable to get the tuberculosis also easily. And apart from that, the way they are nutritionally deprived because of lack of earning is very well playing here. The living conditions are also very poor with this group. So those who are coming from abandoned by their families, they live in very compromised settings, and a lot many other things. The excess that you were asking is like different in these population because see, these populations are like having problems with accessing to these services, even the general services also. Okay, so they have their preconceived notion. Okay, they don't want it to go to the hospital settings because if they go to the government settings, they will be like brutally traumatized, or they will not be given that kind of care, or they will choose to go to the private sector, which they will not be able to afford. And the kind of chronicity that I would say the TB is actually having, there's a lot of delay in the diagnosis of tuberculosis among these populations. Moreover, because they will bear the weight loss, they will bear the loss of appetite, they will mask all these symptoms, chronic cough and sputum, everything. So as long as they're like collapse, they're like grossly compromised with their health perspective, they will not go for diagnosis so easily. So even from if they go to hospital to get diagnosis, going there at a weekly basis to get those drugs is like very difficult for them because their dynamics for livelihood plays in night, and they are not they're not able to get that drugs during the daytime, most of them. And the other part is like they will not be able to access those drugs because going to a hospital for these population for the first time is actually very difficult. Then they will be sent for examinations, investigations, and that kind of trauma at every counter of the hospital is very problematic to them. That's why adherence to the medicines, follow-ups, loss to follow-ups are very high in this population and ultimately compromising the outcomes for the treatment. Okay, so that's why and plus the entire cascade of HIV co-infection is very prevalent among these population. So most of the times when these populations come to diagnosis for treatment, they are like compromised from various perspective. I would say also their basic immunity, their basic well-being is very compromised. Apart from that, maintenance of the therapies, maintenance of the treatment is very problematic. Ultimately, nutritional perspective during the treatment time is also compromised. So the outcomes grossly, more or less, is not good in their favor because of the gender minority group that they come from. So apart from that, substance abuse is high among these groups. So substance abuse make them vulnerable to acquire those diseases, and the entire, and we also don't have much of data about the severity, the treatment completion among transgender groups or other gender minorities. Actually, the data which we are having is like a very superficial data. So since we don't have that much of data, we don't know what kind of outcomes that we are facing right now at a national level among these communities, because most of these communities are either not are tagged as their gender identity, or they are put forth into the male category also. So we do not actually know the burden of disease and their severity of the outcomes as per se from the research perspectives or the reports perspective also. So these are in a nutshell, I would say, yeah, are the issues with the population. Yeah.
Yeah, no, thank you, Abhishek. Ashna, I think this is a good segue because I think you and I have talked about this quite a lot, and you've been particularly vocal about this. Would you like to share your thoughts?
Sure, thank you so much. So I want to talk about two aspects of this when we're looking at gender and TB, which is the prevention side of things, and also when you come to cure and accessing treatment. In terms of the preventive aspect, as far as gender minorities are concerned, as Dr. Abhishek rightly pointed out, they tend to be undernourished or malnourished. And I want to talk a little bit more about things like housing, for instance, because at SATB, we've done some work with gender and sexual minorities and what barriers they face in the access to healthcare. And one of the things that came up constantly, particularly with the trans population also, is that they wouldn't get good housing even if they could afford it. They were forced to live in these ghettos, which were not well ventilated, where access to clean water wasn't as easy. And of course, nutrition remains an issue because if there's not a steady source of income, then these kind of lifestyle factors tend to be affected. So that's one end of it. And usually when we talk about them being at risk, even the public health messaging tends to be that, they engage in substance abuse and they tend to live this way. But I don't think we look at the systemic issue. In a way, we've created an environment where they're forced to live in those spaces. And that is an institutional issue, whether it's to do with urban planning and who gets access to clean water and safe spaces, and nutrition and steady income. And that aspect of it, we don't really tend to focus on. We focus on it more in terms of an individual behavior kind of thing, which is problematic. In terms of accessing care, again, as I've been incredibly privileged, so my experience was not one where gender played an issue. In fact, Dr. Datta here was the one who diagnosed me with MDR-TB and initiated me on treatment, and she was incredibly supportive. I remember breaking down in her office and taking up quite a lot of her time, but she was incredibly, incredibly supportive. So my experience was, touch wood, really great, but that doesn't change the fact that just, working up the courage to sort of approach a hospital and all of this is, it's so scary and there's so much to deal with. And then for women particularly, it might not be the case that they, even if they have the advantage of literacy and an education, health literacy may not be as high. And they may not have access to, let's say, phones or the internet as easily as men do comparatively, right? So those things become an issue then even in identifying what is wrong, even if I want to approach a system. The other thing is that women tend to be socialized, and this is a generalization, I'm not saying all women, but we are socialized to take care of others. So our own health sort of goes on the back burner a little bit. And I've been guilty of this myself. I'm a caregiver for my grandfather and my mother. And even while I was on MDR-TB treatment, I was still prioritizing all of this. So those things I think definitely do play an aspect. That said, I would like to say that it's not cakewalk for the men either, the cis men particularly, because the pressure of having to be the breadwinner, where patriarchy sees a man as the breadwinner, that kind of pressure does create a lot of shame and feelings of inadequacy for somebody who's already struggling with the limits of their ASTD. And so it definitely does affect men as well, although in a different way. So those are my 2 cents.
Yeah, no, thank you. I think you and I can relate to this in terms of just accessing care. For us, like when you're nauseated because of medication, stuff like that, even access to a bathroom is so difficult. And again, for us in urban settings, right, with other genders and for people who have to travel longer, for women, I think something as small as that could just be an inhibiting factor. Dr. Barnali, because I heard you mention this earlier about a daughter-in-law, I'm going to direct this one definitely at you first. What are the challenges that women face when attempting to access healthcare, in particularly the stigma and fear of accessing care long-term?
Yeah, no, absolutely. So that I think is it's a very pervasive kind of thing in our country, isn't it? Women do take a back seat, and I mean, first, can I just point out that whatever Dr. Abhishek and Ashna said, I mean, it's quite insightful for me because as the end kind of care provider, in a tertiary care, we don't deal with anything around, which is on the fringe at all, and it's something we all know is there, and we don't have. And it's so important to address it because, the trauma that they must be going through, apart from being physically unwell, it's just it's quite shameful that, health services don't reach these kind of, and that is exactly what health inequity is about. Anyway, coming to your question, Sandhya. So women, yes, I mean, so this daughter-in-law in a rural, village household, diagnosed with TB. So you can imagine her predicament. So first of all, everybody's very upset that, why do you have this disease that is going to, potentially you may give us. So that straight away, that ostracization, the whole household gets ostracized in some way. And that is, again, the young woman's fault, perceived to be the young woman's fault. And then she herself may infect others. And then first is just, wrap it up. Don't let this news not go out. And, and then treatment and everything comes much later. I mean, this is a curable disease. This is a disease that we have such good treatment for, but yet, things like this. Then these medicines are difficult, they're incredibly difficult. And even the first line treatment, can give so much of, nausea and, potentially joint problems, jaundice, fatigue, lethargy. So the illness, the side effects of the medicines. But this young woman has to continue to run the entire household. She has to look after the household. And as Ashna said, women are always in this role of caregiving, no matter what your situation may be. So she has to look after the father-in-law, the mother-in-law, all the other, the entire family, who are also, resentful that she's got the disease in the first place. And therefore, it is inconvenient for them. So nobody looks at the young woman and what she is going through at that point of time. And we've not yet reached medication. So she's unwell. Her diagnosis has been possibly made. And the mother-in-law and of course, the tendency is, okay, go back to your parents' house. Just go back, get rid of your illness, and then come back. So forget support. It's the opposite of that. And then I think, fortunately for her, I think the father-in-law finally, rallied around and said, no, look, we will support, we will allow her to have treatment. And of course, then at least she's getting the treatment. She still has to do every single job that she was doing, no matter how much the nausea, no matter how tired or how, whatever else she feels. And then you add on to it, other conundrums like, perhaps being pregnant, perhaps, having young children in the house as well, other families. So I think it's a very difficult situation, which need not be. But that is the whole thing. This is why TB becomes an illness of, socio-cultural, economic illness, rather than a medical illness. And again, sorry, I'll just stretch this a bit longer to what Ashna said about men. And we tend to think, men, they have it all good. But yeah, she's so right, because we did this huge, like TB camps for like 2 months in Yamuna Pushta, where there is, homeless. And these are men who come from the villages because of the pressure of earning. And then the city is a hostile place, and, they may or may not succeed. But they're trapped because they cannot earn, and yet they cannot go back to the village because of the shame. And this is, again, a vulnerable population where we had a phenomenally high incidence of TB. Like I think it was 6%. Now, I don't think there's any cohort anywhere in the world that has such a high incidence and prevalence of tuberculosis. So I think it is important to acknowledge that aspect as well, that there are different challenges for men, and again the pressure of all that. So no access to healthcare, and finally I think there are some shelters there which then keep them as inpatients and give them the treatment, make sure they recover, and only then do they. But of course, again, that is subject to how willing they are to accept that kind of thing. So I think, yes, in every aspect, I think we may find that there are challenges.
Thank you. Ashna, would you like to jump in? You're going to have to unmute.
Am I audible? Yeah.
Yes.
All right. So Dr. Datta covered it quite comprehensively, so I'm just going to add a couple of things in the interest of time. So for women particularly, it's also, so in our work with TB affected individuals, and as we know, with working alongside other survivors, one of the things that becomes an issue for women in this country, again, is who will marry you, how will you have kids in the event that you're not married. People who are actually less concerned, we've heard stories that people are less concerned about when the woman is going to recover, and it's more like, ab shadi kaun karega? Not ye theek kaise hogi, kab hogi, not even education that much, almost as if, having TB makes somebody damaged goods, which is not the case. TB is an illness, and illnesses can happen to anybody, and it's not a character certificate of any kind. But for women, that tends to be that added burden. And for gender minorities or sexual minorities even, there's the added burden of this lifestyle, right? So when we say high risk, sometimes, even though that's not what it means, it becomes code for you did this to yourself. And there's a lot of shame that comes in with that. Then there are these studies where people have blamed themselves, saying, "I smoke and I drink, that's why I got TB." Now, while there's a correlation between smoking and drinking because it affects your immunity and that may cause issues, there is no direct causal link that you smoke so you get TB, right? But that tends to be the case. So there's a lot of blame and self-stigmatization that goes on, which is problematic and difficult to deal with.
Yeah, yeah. You use the word lifestyle. I'll say also like social norms. In my case, there was a house help that I was trying to counsel about not. She had to take care of her mother-in-law that was diagnosed with TB first, and I begged her to wear a mask, and she was like, "No, no, no! I'll be insulting my mother-in-law if I wear a mask." And sure enough, 3 weeks later, she was coughing and she had TB. And the other aspect I have seen is the pressure to have sex, to like, I am the woman, I can't say no. I'm curious if anybody's had that sort of experience, and otherwise, Abhishek, I'll ask you to jump in with your thoughts as well. The mute is, yeah.
It's so good to hear other speakers on a very different terms. I just wanted to pitch in here a very different perspective of a very different group. So when we talk about the vulnerability of vulnerabilities of females, we tend to we should understand that the entire group of females who are into sex work has a very different dynamics when it comes to TB vulnerabilities or access to care. See, okay, so there are two kind of women who are into sex work. So one is brothel based. The other kind of group is the females who are doing it from their home unanimously. Okay, so those who are living in brothels, they are like highly vulnerable. They are hardly allowed to leave their brothels. So these brothels are kind of cages. Okay, so you can imagine in a way a setting where there's no ventilation, where there's a lot of sex work happening, there's a lot of compromises happening with the entire nutrition or the lifestyle or the mental health issues, and then they get TB, and they are not allowed to leave those brothels so easily, so they cannot go there to get tested for that also. Okay, from that perspective. And the other perspective is that even if they have access to get tested for TB, then how they are gonna go for accessing the treatment, because their PIM will never allow them to go to get diagnosis or treatment. And now a double-edged sword, I would say, ki women have that kind of vulnerability. Okay, the women is having tuberculosis, and above that, she's a sex worker. So it's like it will jeopardize their entire livelihood also. So they will not tell their they are not ready to tell their parents about it because it will affect their livelihood. On the contrary, they are like in the same cascade of like getting into sex work, daily encounters, and everything. So how they are maintaining their nutrition, how they are maintaining their adherence to medicine is like quite challenging in that group. Those females who are into sex work from their home based sex works or network based sex works, they are the females who are like, okay, very compromised from the financial perspective. Again, bridging all the things, bridging the vulnerabilities from the societal perspective that women actually face, which my co-speakers have actually spoken about, along with the entire notion of sex work, because they cannot give away sex work because this is the part of their earning and livelihood and survival also. So it makes them at very high risk because again, you don't know what kind of client is coming to you and what kind of things that the client is giving it to you. So these are the perspectives. And when we talk about male vulnerability also, we should also pitch in here who people who are belonging to the LGBT spectrum also, those who are belonging to male sex worker group also, males who are migrants also. Okay, so these kind of groups have their again dynamics of similar vulnerabilities, a lot of vulnerabilities of violence, a lot of vulnerability of into sex work, frequent exposures, stress, very high stress levels, substance abuse, very compromised nutritional level. The fact that I wanted to point out when I talk about transgenders as gender barriers of transgenders or female sex workers or male who are having sex with men or male sex workers, the thing is that for this population there is a high need for community involved decentralization of services. For example, if a female into brothel is diagnosed, how you're going to give that person diagnosis, because agar wo ek bar aa jaye, if she comes to you first time, she will never come back for getting her test reports until now she's highly compromised on her health. So, and if she ever happened to receive the test reports, then how she's gonna come to collect the medicines? Who's gonna be the DOTS provider for that person? Is she gonna be the person in the same brothel or the next brothel? This is also a very challenging task for them. The same happens with transgender and hijra population who lives in deras. They cannot tell their you cannot tell their own sister in the same dera, okay, I'm having tuberculosis, because they will be abandoned from their group, and where they're going to go live then? So these kind of perspectives has never been thought about. So this is I wanted to pitch in here.
No, thank you for that very valuable perspective, Dr. Abhishek. Another vulnerable group, I think, because a lot of women tend to work in other homes, it becomes that much more hard to sort of hide or manage the disease. They're caregivers for other people's children, or they work as house help. That's another, I would imagine, a vulnerable population as well, as far as gender nuanced treatment and actually sticking with the protocol, right? How are you going to hide something like this for 2 years if that's how long your treatment is? Another aspect is mental health and the impact of gender on mental health, especially for more vulnerable genders. And because we have such a diverse audience today, I would like, and Ashna, I'd like you to start with this, if you don't mind. If you could also shed some light on gender and sexuality and therefore the nuances around that.
Right. When we talk about gender minorities, what we often tend to forget is that while gender and sexuality are distinct concepts, they're interrelated. And this is something that even the National Gender Responsive Framework on TB Care that we have misses out on, which is it does cater to trans individuals to a limited extent, but completely misses out on LGBTQIA++, right? And that is problematic because whether it's a gender minority or a sexual minority, they tend to face issues of the same nature. Now, when we talk about mental health and how gender plays a role there, there's a lot of, let's talk about first the gender minorities and the sexual minorities. There is, there's like layers of stigma. To begin with, first, it's to do with their identity, either whether it's a trans person or whether it's somebody who's a lesbian or gay or bisexual, intersex, asexual. Just identifying as any of these carries with it a certain level of stigma and discrimination that they have to face. Add to that mental health, which is really stigmatized in this country. I mean, we don't want to talk about it, and we use it as a pejorative to say that somebody's crazy, or and it's almost like considered shameful to need mental health care. Nobody would be ashamed to say I went to my dentist to clean up, but if you went to a therapist, it's immediately like, oh, what happened? Like something needs to happen. Like you shouldn't just routinely check in for your mental health anyway. So that interacts together, and that is a very heavy burden to then carry because when you're a gender minority or a sexual minority, you are forced a lot of times to hide yourself and who you really are, and an entire aspect of your life, and then you have a mental health issue, and then there's more hiding. Add to that something like TB or living with HIV, and that's even, it's just luring. It's like a Jenga tower just waiting to fall to pull one brick out. And so that's the way it affects gender minorities and sexual minorities. For women, again, it's especially for women who are homemakers or caregivers, it leads to this sense of inadequacy where you feel like you're not doing what you're supposed to be doing. And if other people are taking care of you, there's the guilt that, I should be taking care of you. Why are you taking care of me? With men, it's the inability to provide because we've tied up self-worth to domestic chores for women and breadwinning for men. So that's a recipe for disaster because both of those things are affected when you're ill. You're not superhuman. And so this is how it tends to, for different genders. What's common is that they all face some kind of mental health impact, but what that is and how that's experienced and who has more permissibility to seek help for that changes. So I have the privilege of as somebody from the community and as somebody who has mental health issues to be able to say this on a live stream. But and this isn't because I'm brave. This is clearly because I have the privilege to be able to say this. Even if somebody stigmatizes or discriminates against me, it won't affect me. I'm financially independent. But a lot of people who would want to seek this care or help do not get to do that just because of their gender or their sexual identity. And that is an issue that we need to address.
Thank you. Dr. Abhishek, in terms of just awareness with healthcare providers about, somebody might be anatomically male but identifies as female, and therefore just respecting that, and then of course the other mental health challenges. Any thoughts you want to share on that?
So I have been working with the sexual minorities from last 8 years, and I specifically work in HIV domain and TB co-infections. So I have been witnessing one thing. There are two different things: accessing healthcare services from general healthcare staff, and then talking about the mental healthcare services. So when we talk about these kind of services, usually these gender minorities are treated in a manner that okay, you cannot sit here. You have to wait till end to get these kind of services. Plus, when they are staying in a line in a queue, they will be like looked upon by everyone around them. It's like okay, everybody is staring at them, and at that point of time it's very uncomfortable for them to go through the entire process of initiating their medications, getting diagnosed, and then following up very well. Okay, so this is a very different perspective. Right from the person who is like testing them, counselors, doctors, they all will be like staring at them, questioning their sexual identity or gender identity, and also they are questioning their livelihoods also. So these kind of perspectives actually make them so much of uncomfortable that they usually do not like to go to that place to get treated. So as soon as they are asymptomatic after the intensive course, they will most of the time lost to follow up. So here comes the thing of non compliance, reasons for the non compliance, because you have not created an enabling environment for them in the healthcare settings. So because doctors do not know how to handle that population, they do not know how to address them. It's like I have seen a lot many doctors mentioning males to a transgender hijab person on their prescription card. वो लड़का क्या क्यों नहीं बुलाते हैं? So it's like it's very problematic to these kind of gender minorities. So these kind of things actually affect their adherence, coming back for treatment, following up, and everything. Apart from that, when we talk about the mental health services, it's like most of the mental health care personals in India, they are not gender affirmative. Okay, so when we talk about gender affirmative mental health services, it's like it's very tough. Okay, so most of these people from coming from gender and sexual minorities, they have a lot, they have experience with psychiatrists or counselors who have actually asked them, okay, this is a mental health disease, your sexuality or your gender identity, you need to get treated. Or they have bullied them, or they have asked them that okay, it can be corrected. So most of the times they are actually afraid of going to mental health care providers. Now, apart from that, those who are gender affirmative, most of them are very matlab, beyond their capacity to pay also. So the mental health services for the gender and sexual minorities is like a myth, to be very frank, for those who are coming from the core grassroots levels. And this is a very hard statement I'm making here, but it is the harsh truth. Apart from that, when we talk about TB testing or treatment services, a lot many other things. People are on hormone replacement therapies from gender minorities. It may have a very different notion for the kind of mood swings that might be having, and again ATT and antiviral therapy is actually adding up to that kind of mood swing. So either they should leave the hormone therapy or they should leave the ATT. It's a kind of thing that they're juggling between. Okay, and nobody's there to tell them okay, everything is gonna be fine. Above that, the nutritional cascade is like doctor has the work to write the medicines. The kind of trauma they are going through, they will ultimately leave the medicines. I'm sure the outcomes for the, especially the drug resistant tuberculosis, is very poor among these population because they don't have any enabling environment. uh, Only giving medicines does not make effort, does not make wonders for this population actually, until unless you do not address the other issues related to the entire cascade of testing and treatment for them.
Um, Dr. Bernali, for you, with AIDS care, we know that even, I mean, people from all sectors have access to counseling, and I remember working with some house help that was seeking help for depression. I know how strapped you doctors are, but what's the sensitization to spotting mental health issues that your patients might have, and how nuanced is it based on genders over and above just the drivers, right? Like, be strong, be a man, don't show emotion, and then for women saying, don't complain, don't make a noise, let the man speak on your behalf. What are you seeing, and what are the challenges you face there?
So, I mean, this is, I'll be honest, this is very insightful and educational for me, listening to Dr. Abhishek, listening to Ashna, who are actually, working amongst these, and yourself perhaps. Because, I mean, while we are, I mean, so apart from mental health, even the existence of gender, issues as they do, I mean, we are so insulated from it. So it's almost sort of, it's just very sad that, we are we may be aware of its existence without really knowing anything about what that community actually, suffer from the health and other issues. So that is sad, and I think awareness amongst healthcare workers, because I suspect that many will be quite, will not be empathetic to the suffering of people like this, just because our biases are so deep seated, and while our thankfully things are changing, and I mean, not at a pace that we would want it to, but yes, at least there are people engaged in their care, looking out for them, aware of it, but healthcare has a long way to go to be able to address these issues, unfortunately. So from the gender perspective, I think as healthcare workers, I think we are very, very poorly equipped to understand, and perhaps where I to do my medical practice, we just don't encounter them, but whatever. So I don't see how to kind of align it with, and as a result, I guess, because most healthcare facilities therefore are not available to the people who are in minorities in this. But I think we must just work harder to make ourselves much more aware, sensitized, and just empathetic to what situation they're in. With regards to mental health, separate to this community, I mean, just mental health per se, and in TB cohorts, of course, it's widely prevalent, and and especially the young people, especially the ones with DRTB, and it is not surprising, because you have to, at an age when you really want to be just getting on with your life, you're straddled with a disease which is difficult, which has the disease symptoms are bad, the treatment is protracted, full of side effects, the treatment. And of course, fortunately, even that is changing now. We do have access to shorter regimens and things like that. So from all of these aspects, you get mental health disease, and the side effect of medications as well also causes depression. So depression, suicidal tendencies even. So I think it's, again, so this aspect of care, yes, we are very well versed with. And when we do start a patient on treatment, we discuss that entire possibility of the mental health, and again, it's helping them accept it as well, because a lot of the time, like Ashna said, like, you're hiding from so many different things, and and partly because of society, partly because of your own mindset, and mental health is something that nobody really wants to acknowledge that you may have it, and all of us are so susceptible. And during COVID, I mean, we particularly saw how it kind of just skyrocketed the kind of prevalence of mental health issues in just everyone. Really, everyone went through just the 2 years, and if you add on to that a physical being unwell with TB or whatever other illness, then certainly. So I think even amongst healthcare workers, a lot of sensitization, awareness is needed. In how we do that, I don't know, but so I would be one person who's aware of this, who would be very empathetic if someone came to me, but that doesn't resolve anything, because I'm going to see maybe no such patient, or I may see one. So that we must, I think, have some ways of sensitizing doctors, nurses, healthcare workers to be sensitive, and to the minority communities that exist. And mental health, I think we are fairly sort of proactive about that.
Well, the start is to have more such conversations. And I think also the learnings from COVID, as you said, right? The physical and social isolation aspects of it have come so much. I mean, my entire work is around that area. And if we can take some of these learnings and some of the openness around around what everybody experienced over the last 2 years, we can perhaps become more empathetic and more sensitive to those that must suffer so much more, that also have TB as a disease to grapple with and to deal with. Our next question is more from a community perspective. How can we make TB care and healthcare in general responsive? I think the big question that Dr. Barnali was asking, how can we make TB care and healthcare responsive to the needs of gender identities and sexual identities? Perhaps one or two key takeaways, any ideas that you'd have? I'll start with you, Dr. Abhishek, if you could jump in.
See, when we talk about inclusive healthcare services, we need to understand that decentralization plays a very vital role in inclusivity of these vulnerable population. Okay, the entire TB program is actually built upon the entire decentralization of services, but we need to understand how to reach out to the actual decentralization to include these gender and sexual minorities from the real perspectives actually. Okay, so I would say community strengthening and community leadership from these vulnerable groups is very important. Making avenues for these population to get tested nearby in their settings where they will not be judged and they'll not be having that kind of odd cases in the healthcare setting, is that it is something that is very important. We can talk about integrating these testing services and also dot services into transgender TIs of HIV program. Also, we can talk about having dots providers from the same community in the same dera or same bastis where these kind of population actually lives. So these are certain things we need, a real decentralization and community leadership from these communities, and also people providing these services from the same community. So apart from that, one point that I missed during my conversation in this session is like there's a lot of high prevalence about extra pulmonary tuberculosis in these communities, and they will never receive those services of ultrasound or a lymph node examination and everything. I've seen so many people who are having very enlarged lymph nodes, until unless it starts matlab, oozing out the pus or something like that material, they will not give any kind of concern about that. So when we talk about these kind of aspects, we need to have other diagnostic perspectives that we need to take care of. Also we need to see the nutritional, because I have multiple times said that we need to think something about their nutritional status, because nutrition has, we all know that nutrition is very substantial when it comes to TB prevention. So this is the key point that I would love to give. Yeah. Thank you.
Thank you. Extremely pertinent. Ashna, your thoughts?
I'd like to add to that by saying that when we think about conceptualizing frameworks in gender responsive care, or when we're making these policies, so what Abhishek covered very well was the part where we actually start accessing treatment on ground and going for diagnostics. But even before we get to that, when we're imagining this, what a gender responsive system would look like, one of the problems that we have currently in the current framework is that there was one trans person who was part of the committee that formulated it. The rest, as far as we know, were all cis het men and women. And the arrogance of that, the arrogance of a community framing something without any idea of end user needs, that needs to stop. The communities, LGBTQI plus communities, need to be involved at the level of decision making, at the level of design, at the level of understanding what are the health needs of different genders and how do we cater to these without stigmatizing them, without sort of, because a lot of times our clinical settings and the public health messaging we use also end up stigmatizing them. That needs to go away. And this is very critical. This isn't an academic point that I'm making. In the interviews that we did with some members from the community, we had one person tell us about this incident where their friend, who was also from the community, passed away because there were two providers standing arguing over who is supposed to take care of them because it's a trans person. Would it be a male doctor or a female doctor? They asked me at the end of that interview, How many of us need to die before you understand that we're also just people, and we're citizens of this country? Why don't we get the same rights? And so involving them in a substantive way, allowing them to seek accountability from care providers is one aspect of it. The second aspect would be sensitizing health providers, and you can't just do this at the level of, once somebody has become a doctor and spent all those years in education, right? Because even for health providers, it is a mindset shift to some extent, for some, if not all. So maybe working this into the medical curriculum, where when you're in med school, you study this and you understand that there are different genders and different sexual identities, and all of them could be your patients. Maybe starting from there and then slowly organically building up to then periodic sensitizing or training or skilling, the way we anyway do in the medical profession. We have to periodically go through a certain amount of skilling to stay current. So maybe making gender responsive training a part of that. That is one way also to go.
Yeah, and I think starting with identifying the numbers, right? We have statistics finally on men and women, but as Dr. Abhishek has told us, and we're aware that the other genders don't even feature in some of these statistics. Dr. Bonali, do you want to add anything to this? Do you have any thoughts about?
Yeah, no, as I said, I feel very inadequate contributing towards this, the real, and I mean, it's just such a shame that healthcare workers are, so unaware, their awareness levels, and therefore their, sensitization, etc., is at a, so, but I think a lot more needs to be done. And after this, I'd be very keen to connect with Ashna and Dr. Abhishek. And, we do a lot of outreach work, taking up mobile vans, and I think we can really do something. We're working with government, we're doing so there's a potential here to, maybe do something, and not just provide lip service to these kind of things, and actually reach out and maybe help, because I can see that a lot of people are already working on it, and really hats off to you for what you're doing. But I think, amongst doctors and healthcare workers, the sensitization needs to increase significantly. And as you said, these are citizens of the country with equal rights, and they're being denied everything. Why? And really, really much more. I think conversations like this, as you said, Sandhya, need to happen for at least medically. As a doctor, I can only help medically, but even that would be something to have non-stigmatized and a fair kind of healthcare provision. Regardless of what other things, which are if you look at it in the larger picture, they're irrelevant. You have TB, you deserve to have the full treatment. All the other aspects have to be just taken into the mix, and not, you shouldn't be deprived of something just because of that, which is not your fault. And so I feel it's quite educational for me to hear all of these perspectives, and I really hope that we can do something about it from the medical point of view.
Thank you. I think that's a wonderful thought and commitment from you representing yourself and doctors such as yourself. I think that's where the real change can actually happen. So thank you all. I think we're all agreed that we need to have way more conversations about gender, sensitization, access to data, and then provide more nuanced care for people of all genders and sexual identities. Thank you so much to all of our speakers, Dr. Bonali Datta, Dr. Abhishek Royal, and of course my fellow survivor Ashna, Ashna Ashish, today for this wonderful discussion and valuable perspectives. Do stay tuned to our next panel discussion on TB treatment. Thank you all for being here today.
Good evening, everybody. I'm Dr. K.S. Sachdeva. I'm the Regional Director of International Union Against Tuberculosis and Lung Diseases. The theme of the meeting is Redesigning TB Care in India for Equity and Access. And what I'm going to speak about is prevention of TB, a key to end TB. I've chosen this theme within the overall theme of TB care in access because prevention remains one of the very important intervention to end as we move towards ending TB, or what we are calling as a key to end TB. And this is one of the newer paradigms within the TB care and control, which has been introduced just a few years ago. The country agreed to introducing the preventive TB preventive therapy in 2018 in a UN level, high level General Assembly meeting in 2018. So just giving an overview, when we talk of prevention of TB, it's a wider basket of choices which we have. So prevention covers what we know as a behavior change, or urging patients to seek early access to diagnosis and treatment as soon as they recognize their first symptom. So within this, we have strategic communication or a call for action for patient to assess services. We also have within the prevention what is known as a cough etiquette. As soon as you experience cough, you are likely to transmit diseases which can be transmitted through an airborne route. So you have to take adequate precaution in the form of, you have to either cover your mouth and nose with an handkerchief or with your elbow. With the recent COVID pandemic, which engulfed the entire globe in last 2 years, we now feel that there is some role of use of mask in TB prevention, specifically in the early stages of treatment, wherein you are still capable of transmitting your infection to others. So our recommendation is to use mask for about a month when you start treatment. And then, as we know scientifically, when you are on treatment for about 2 to 4 weeks, you are no more infectious. The second major intervention in the prevention is what we call as how do we prevent spread of infection. Within that, I did refer to, some of the interventions are cutting across boundaries. I did refer to cough etiquette earlier and also use of mask. But within that is also very important is an open ventilation or a natural ventilation. So if there are enough air exchanges in the environment or your room or the place where you are staying, the chances of a person spreading that infection to others becomes less. We have seen that measure within the COVID also recently, when we advise them to maintain a 6 feet distance. The basic idea is that you don't transmit infection to others. So if there are adequate air exchanges within a surrounding, there are very little chances of you spreading infection to others. Then there are other measures which are more mechanical or based on equipments, which is not the right forum to talk about it as of today, because I will be stressing more on TB preventive therapy, which is the number 3rd intervention. Another intervention for prevention of TB is vaccines for TB. We all know that BCG has been in the universal immunization program for many decades. But as we all know, BCG only prevents development of severe forms of TB in children, and it's not totally protective against TB. The scientific community as a whole is working a lot to develop new vaccines for TB, and we expect new vaccines for TB to be available within next 5 years for use under the National TB Elimination Program. A word about TB preventive therapy, a new intervention which has been rolled out by most of the programs. India committed to this intervention in 2018 and also agreed to certain targets on the number of patients to be put on treatment. And as the entire scientific community knows that in India, about 40 to 50% of the population is estimated to have been infected with the TB bacilli, but that bacilli remains dormant. In a certain percentage of patients or in certain categories of patients, which we call as high risk, they break down into TB. So there is about a 5 to 10% of chance in those who are infected with the TB bacilli to break down into TB. So the entire programmatic management of TB, or the new paradigm in TB intervention, is based on the premise that if you are able to address, reduce this breakdown of latent TB into TB, more so in the patients or in the population which are at high risk of breaking down into TB, you can effectively reduce the incidence of TB. So of the 60 crore odd population, which is supposed to be, which is estimated to be infected with TB bacilli, about 1% of them, or 1 in 100 of them, have high risk of breaking into TB. And such group of patients are those who are household contacts of TB. And other high-risk groups are certain clinical groups, such as people living with HIV, patients suffering from silicosis, or patients who are on anti-cancer treatment and receiving dialysis, or are undergoing organ transplantation. People staying in institutional or very crowded settings, as I alluded to earlier, that airborne infection control remains one of the important interventions for prevention, are also more vulnerable to break down into TB because the transmissions are very high in those settings. On a programmatic basis, if we were to address such a large population as 60 crore, it would not have been possible. But if we separate out groups which are most likely to break down, we are just left with about 1 in 100 which needs to be addressed. And therefore, a new intervention called programmatic management of TB preventive therapy has been launched by the national program. And to generate evidence for the country and how to go about it, the partners to the national program have taken on themselves to generate evidence and show to the program that it's possible, feasible within the programmatic settings to implement those interventions. Within Union also, we are implementing the programmatic management of TB preventive therapy in such patients who are supposed to be high risk, or who are household contacts of TB patients, as they are classified as high risk. We are implementing this intervention in 7 states and a large number of districts within those states. Till date, the program has screened about 1.2 lakh household contacts and initiated patients who need to be put on TB preventive therapy in the last 6 months. We are hoping that we have huge learnings in the initial period of implementation on TB preventive therapy, and each day, each month, the programmatic management of TB preventive therapy is being refined, and we are able to produce evidence that it is doable, feasible, and the national program has now, based upon the evidence generated by partners, including Union, they are now scaling it up to the entire country, to the all districts of the country, and the provisions for same have been made within the project implementation plans of all states and districts. So this intervention is also one of our high priority interventions. And if you look at this graph, which says that if we were to achieve TB elimination by 2025, what are the interventions which are going to be most effective? And TB preventive therapy comes out to be as one of the most promising intervention, which will accelerate the speedy decline in TB incidence. And we are fully committed to support national program and all the communities and states to scale those programs, develop evidence, and also handhold states to and support the country in meeting its objective of TB elimination and meeting sustainable development goals by 2025. I'll stop here and wait for questions and answers and any clarifications that the participants may have for me, and thank the organizers for giving us an opportunity to share our views.
Hi, my name is Amita Gupta, and I am the Chief of Infectious Diseases and the Faculty Co-Chair of the Johns Hopkins India Institute. And it gives me great pleasure to greet you with my co-moderator, Debashri Lokhande. And together, as part of the TB Summit, we will be discussing some new diagnostics and treatments, and to put in context some of the sobering statistics that we have identified during the COVID pandemic. So I will just start by saying a few words that I think we all are very familiar with, unfortunately, with the fact that the global TB targets are mostly off track, and that COVID has reversed years of TB progress. It's now estimated that 10 million individuals in 2020 were diagnosed with tuberculosis, and many of them went unreported. In fact, only 5.8 million of these individuals were reported to the healthcare system. So there was a large drop in notifications, and in particular in places such as India, Indonesia, and Philippines, this was particularly marked. For the first time in more than a decade, tuberculosis mortality has increased, and where we saw more deaths at 1.5 million people dying of TB. We also noted reductions in the number of people getting treatment access for drug-resistant TB. We also saw fewer people getting preventive treatment, with 21% receiving less treatment. And we noted that there was an increase in poverty and malnutrition, the very factors that are associated with increasing TB incidence. All in all, this compounded by less spending on important things like TB diagnosis, prevention, and treatment. In fact, less than half of what is necessary to combat TB was what we saw. And these here just show you very quickly, for the first time, these increases in TB being detected and more people dying from TB. And when we look at these graphs, you just see again for India, where there was both an uptick in the mortality and decreased case notification without any increase in spending to combat TB. So we are going to need many steps urgently to address these sobering facts. We need to end the pandemic critical to the recovery of TB services. We need to invest in better data systems. We've learned from COVID that we have a fractured public health system globally, and India is not alone. We saw this everywhere, where we need to invest in real-time data systems, getting COVID numbers, getting TB numbers to be as accurate as possible so we can identify and target our resources. We need to improve case detection. And we need a lot of collaboration. We know by collaborating together, we can make things happen. And so you're going to hear from several of our speakers today who are going to talk to you about new tools and for diagnosis, new tools for treatment, which are really very exciting. But we have to remember, with this excitement, we need to ensure access and equity and delivery at the cheapest cost for the most people with the greatest equity. So I'm hoping you'll enjoy talks from Dr. Kelly Dooley, Manank Shah, and our very own TB survivors who will tell you their stories. And you will learn about some of the exciting studies that include, as I said, new diagnostics and new tools, as well as new treatment trials that are shortening the length of how long we have to take treatment. They're now safer. They're available all in pills and have, and we know we need them for a shorter amount of time. But again, we cannot transfer our research into practice until we have this made available for everyone. And it's really critical that we work on that side of things as well. So thank you for giving me the opportunity to speak to you today and to be your moderator.
Hello, I'm Ashna Ashish. I'm a public health professional, a lawyer, and an MDR TB survivor. I'm honored to be speaking here on this panel on TB treatment access and strategies. My presentation specifically looks at giving an overview of access to TB treatment in India. Just some context setting before we dive in. TB, though curable, remains one of India's severest health crises, killing over 1,200 Indians daily. The disease takes its most dangerous forms with delay in diagnosis, delay in and inaccessibility of treatment, increased suffering due to side effects, and mental health issues for the affected persons. The COVID-19 pandemic has only exacerbated these challenges. A quick look at treatment in the public sector versus TB treatment in the private sector. So in the public sector, TB treatment is free, but there are hidden costs associated. This could be the cost of travel from one's hometown to a treatment center. It could be associated with nutritional costs, the cost of supplements. The treatment is reliable, but not always so. It lacks patient support. The healthcare system focuses on numbers rather than quality of care. And there's minimal economic support in the form of the Nikshay Poshan Yojana with a meager 500 rupees per month. In the private sector, care is expensive and unreliable. It's not affordable for most and thus pushes them into debt. It offers little to no patient support. It lacks focus on management of side effects. And there's a suboptimal quality of care and a high dropout rate. Now, this is alarming because patient perceptions that the private sector provides better quality of care with more focus on the patient's well-being, but it is unaffordable for most. And given this perception, a significant majority of India's TB patients seek care in the private sector, despite the challenges of misdiagnosis, delayed diagnosis, and incorrect treatment. Now, the private-public amalgamation is a model with various benefits that the government has been exploring in a limited manner with its private sector partners. Now, the benefits are that the patients choose their healthcare provider. Patients have access to adherence and follow-ups in the private sector. Patients get access to new drugs and regimens. There's a better quality of care ensured, and it's more affordable than care outside this model. However, there are still drawbacks. This model is still limited within its reach. Costs, though lesser than before, are still unaffordable for some. On account of factors like delayed incentives and being overburdened, doctors may often be reluctant to engage with the system, and patient support still remains missing. But what we do know from our learnings from this model is that the interaction of the private and public sector in an organized way can help India in achieving its goal of TB elimination. Now, what has the impact of COVID been? So an overview, we do know that the COVID-19 pandemic ended up having a huge impact on TB care, and this includes TB treatment as well. In fact, if the National Health Mission data estimates that there was a 45% decline in the number of patients who signed up for treatment in June 2020, which means that, and even stories we've heard where people have reached out to survivors against TB with queries confirmed that there was an inability to access treatment in many forms. There was an inability to afford treatment, and there was a difficulty coping with side effects, given that most patients could not access their doctor or health workers. Let's have a more granular look at COVID's impact on TB care and treatment in particular. So in terms of diagnosis, we know the diagnostic centers were shut down in some places. There were delays in diagnosis with the CBNAT machines being diverted to COVID testing. And in treatment, we saw non-availability and decreased availability of drugs for both drug-sensitive and drug-resistant TB patients in both the public and private sector. In terms of support, with COVID-19, it was an all-hands-on-deck situation, and all health personnel, including health workers, were diverted. So there was a lack of provision of supportive supervision, monitoring, and support in the treatment process for TB patients as a result of everybody being focused on COVID. Again, the lack of transportation has restricted the ability to access health centers, particularly during lockdowns, where people without private means of conveyance had no way to reach their diagnostic centers or health centers. The lack of access to health services has also brought up the issue of management of adverse drug reactions and comorbidities, with many affected individuals struggling during the pandemic to do so. As a result of COVID-19, these challenges are bound to increase and impact a patient's ability to continue treatment. So what can we do about this? To begin with, we need to adapt existing delivery approaches to pandemic needs. This would include TB diagnosis through door-to-door testing and contact tracing. But more particularly in treatment, it would mean that if a patient can't reach treatment, then treatment needs to be made accessible by taking it to their doorstep. This needs to include side effect management and patient support, including mental health support, to deal with the issue of the stockouts. Every patient should be given a buffer stock of medication. So let's say about 2 to 3 months of medicine supplies in one go. What's also critical at this time is patient education. So leveraging remote support and communication for increasing patient awareness about TB, its treatment, its physical health and mental health side effects, and also establishing through digital means local networks that can address patient queries and provide them with some semblance of credible public health information that would help them to quite an extent not just self-manage wherever possible, but also be aware of when they need to seek care and how. Given how the pandemic has affected the economy, now it becomes more critical than ever to ensure robust socioeconomic support mechanisms, because a significant amount of people in the informal sector have lost their jobs. And if these people are affected by TB, they would need increased socioeconomic support. And the way to do this would be to increase the amount in the Nikshay Poshan Yojana and factoring in hidden costs of treatment and providing for those. Another thing that is critical is ensuring access to gender-responsive, high-quality TB care. Now, care is not limited to diagnosis or just treatment. It has to cater to the varying needs of different genders. It has to be provided with dignity, and it has to be provided stigma-free. That is crucial to ensuring good patient experiences and outcomes. Another key aspect is survivor involvement. So survivors need to be involved in this process of revamping access to TB care and treatment. They need to be involved in the design of a revised access policy and its implementation. And why this is critical is because they understand end user needs and challenges, and their inputs then become critical to framing policies in TB treatment that speak to these end user needs and meet these end user needs. Let us work together to make TB treatment and care equitable and accessible. Thank you.
Hello, I'm so pleased to be here with you today. I'm going to talk to you today about an overview of new tuberculosis treatments. My name is Kelly Dooley. I am a professor of medicine at Johns Hopkins University with appointments in infectious diseases and clinical pharmacology. Our objectives today, we'll talk briefly about the epidemiology of TB, including drug-resistant TB and the urgency of need for new treatments. We'll talk about some new treatment regimens proven to be effective, as well as new drugs for TB treatment. We will look together at the drug pipeline and the trials landscape for TB and highlight some important reasons for hope. So state of the state, I think many people at this conference are familiar with TB and its treatment, but I will just highlight that as of 2014, TB surpassed HIV as the #1 infectious killer worldwide, although we know that COVID has since surpassed TB. It remains a top 10 global cause of death, and our treatment for drug-sensitive TB still takes 6 months to complete. Multi-drug resistant TB, TB resistant to isoniazid and rifampin, is common. There were 465,000 incident cases in 2019, and MDR TB treatment is successful in only 59% of cases. Surely we can do better. For HIV at least, there are many different regimens on the shelf. Multiple fully active regimens, 1 pill once a day. Many are well tolerated, and now there are even long-acting injectables that patients can receive on a monthly basis for full control of their HIV. Can we do better with tuberculosis in the same way we have done well for patients living with HIV? So, well, there is some reason for hope. We now have a 4-month regimen for drug-sensitive TB as a result of this trial, which was Tuberculosis Trials Consortium 31, AIDS Clinical Trials Group A5349. In this trial, a rifapentine and moxifloxacin-based regimen was non-inferior to a standard of care regimen with isoniazid, rifampin, pyrazinamide, and ethambutol. In this trial, I should highlight that there were 34 clinical research sites in 13 countries and 4 continents, including 2 sites in India, so the results are highly generalizable globally. The trial design was, as you see here, people were randomized to 2 months to a standard 6-month regimen, to a 4-month regimen in which they received rifapentine, isoniazid, pyrazinamide, and ethambutol for 2 months, and then 2 months of rifapentine and isoniazid. And the third regimen, the one that turned out to be successful, had 2 months of rifapentine, isoniazid, pyrazinamide, and moxifloxacin, followed by 2 months of rifapentine, isoniazid, and moxifloxacin, as you see here. And so I will just show you the primary efficacy results that the rifapentine, moxifloxacin-based 4-month regimen met non-inferiority criteria for efficacy in all analyses. Even in subgroup analyses, patients who received this regimen had non-inferior efficacy compared to standard of care, including people with HIV. For drug-resistant tuberculosis, there is also reason for hope. Here, in this trial, among patients with extensively drug-resistant TB or hard-to-treat multi-drug-resistant TB, a regimen of 6 months of bedaquiline, pratomanid, and linezolid cured 90% of patients. This was a small trial with no control arm, and there was significant toxicity, specifically peripheral neuropathy and myelosuppression. Most of it was manageable and reversible. And so this led to registration of pratomanid as part of bedaquiline, pratomanid, linezolid in several countries. In terms of latent tuberculosis infection, if there are 2 or 3 billion people with latent TB in the world, could we possibly do better with very short treatment regimens so that we can cure patients of their latent TB and prevent TB in the first place? So you can see here, these treatment guidelines, this is for people with HIV in the United States, just came out last week. So these are hot off the presses. You will see that isoniazid preventive therapy now is listed as an alternative regimen, and that 1 HP, 1 month of daily isoniazid and rifapentine has now become a possibility for patients. Preferred regimens include 3 HP, so once weekly isoniazid and rifapentine, or 3 months of daily isoniazid and rifampin. I find this 1 HP regimen to be highly exciting as it is ultra short, and in people with HIV seem to be quite effective. So just showing you here the 3 drugs that I call second wave drugs. So we had a first wave of drug development in the 1950s to 1970s, and then a hiatus from TB drug development. And then in the earlier part of this century, these 3 drugs were developed. I will say that something new is that bedaquiline is now being recommended for children of all ages. And some important things to know are that bedaquiline is a substrate of CYP3A. That means there are significant drug interactions, so just be cautious about what you use it with. It causes moderate QT effects, so EKG monitoring is necessary. For delaminid, watch out for some central nervous system side effects. These are rare, but merit attention. And then for pertomanid, there still remains limited safety information, but it makes sense to monitor liver function enzymes over the course of treatment. So this is the global new TB drug pipeline. You can see that there are multiple drugs in development. Many of these are from the same class. So you'll see these drugs in purple are cousin drugs to bedaquiline, and that the drugs you see in this sort of off-green color are DPRE1 inhibitors. Those drugs are of a completely new drug class. There are also some cousins of linezolid. You can see them here, delpazolid, sutazolid, OTB658. These are being developed to have the same type of efficacy that linezolid has, but with reduced side effects as we saw in the NICS-TB trial. So less peripheral neuropathy and less myelopathy or myelosuppression. So in summary, 3 new drugs have come to market in the last decade. We now have a 1-month treatment for latent TB, a 4-month treatment for drug-sensitive TB, and a 6-month treatment for XDR TB. We are really getting to a good place. Gradually, but we are getting there. There are many new drugs in the pipeline, including repurposed drugs, drugs of classes we know well, like linezolid, but redesigned to improve safety, and drugs of whole new classes. There is attention being paid to children and people with HIV, and I feel there is reason for hope. Who knows, one day we may even have long-acting injectables. I'm really grateful for the opportunity to be here and to interact with you and to be part of this conference. Thank you for the invitation, and my best to you all. Thank you.
Hello, my name is Yashwant Parathe. I'm DITB survivor, patient advocate, and peer counselor. I am engaged with SATB since last 2 years. Today, I have been invited on the panel Reimagining TB treatment in India, and I will be speaking on importance of treatment adherence tool and patient adherence tool and patient support tools. Now, हम देखते हैं कि क्यों पेशेंट सपोर्ट टूल जरूरी होती है। आज इंडिया में टीबी को एक गंभीर बीमारी के रूप में जाना जाता है, जिसमें बहुत सारे चैलेंजेस आते हैं, स्टिग्मा, मेंटल हेल्थ, काफी सारे एडीआर आते हैं, जिसमें पेशेंट को ट्रीटमेंट लेने बहुत ज्यादा मुश्किल होती है। पर ये चीज और भी ज्यादा चैलेंजिंग हो जाती है जब पेशेंट डीआर-टीबी का ट्रीटमेंट ले रहा हो, जिसमें एक मोटिवेट इंसान भी अपना ट्रीटमेंट सही से पूरा नहीं कर पाता। हेल्थ सिस्टम को एक क्लिनिकल अप्रोच से ज्यादा पर्सन सेंट्रिक अप्रोच लेना चाहिए, जिससे पेशेंट को और भी ज्यादा अच्छे से ट्रीटमेंट लेने में मदद हो सके। लेट्स लुक सम ऑफ द की एलिमेंट्स ऑफ द पेशेंट सपोर्ट टूल्स। पेशेंट सपोर्ट टूल्स इंफॉर्मेटिव होने चाहिए, इंगेजिंग होनी चाहिए, सिर्फ इंस्ट्रक्टिव नहीं होनी चाहिए। पेशेंट सपोर्ट टूल अगर इंस्पायरिंग हो तो और भी ज्यादा बेटर होते, या rather than blaming। पेशेंट सपोर्ट टूल्स एक पेशेंट के लिए बहुत ज्यादा रेलेवेंट होने चाहिए, और उसमें मेंटल हेल्थ सपोर्ट और स्टिग्मा मिटिगेशन के ऊपर भी डिफाइन किया जाना चाहिए। डजंट मैटर हमारे पास कितने भी अच्छे टेक्नोलॉजीज अवेलेबल हो, बट वो एक ह्यूमन कॉन्सेप्ट, ह्यूमन कनेक्ट रिप्लेस नहीं कर सकते। आज भी हमारे देश में एक गरीब इंसान के पास ये चैलेंज है कि वो अपना ट्रीटमेंट पब्लिक सेक्टर से ले या फिर प्राइवेट सेक्टर से ले। Now let's review of what's available for patient support tools. पेशेंट सपोर्ट ग्रुप्स बहुत ही ज्यादा पेशेंट को हेल्पफुल होते हैं। मैं एज अ टीबी सर्वाइवर बहुत सारे पेशेंट सपोर्ट ग्रुप्स में एंगेज हूँ, जिसमें पेशेंट को हमसे बात करके बहुत ज्यादा अच्छा लगता है। पेशेंट को उनके प्रॉब्लम्स का राइट सॉल्यूशन दे पाते हैं, पर ये ज्यादा मोस्ट ऑफ द रीजन्स में अवेलेबल नहीं है, सिर्फ लिमिटेड रीजन्स में अवेलेबल है, जिसमें सर्वाइवर लेड पेशेंट एजुकेशन वीडियोस बनाए है तो पेशेंट को ज्यादा और भी मदद हो सकती है। 24/7 टोल फ्री नंबर काउंसलिंग के लिए अवेलेबल है, पर वो सिर्फ मेडिकल पॉइंट ऑफ व्यू से ही आपकी काउंसलिंग करते हैं। पेशेंट ग्रीवेंस रिड्रेसल हेल्पलाइन भी अवेलेबल है, पर इसमें कई मेजॉरिटी ऑफ द टाइम पेशेंट की कंप्लेंट को ठीक से एड्रेस नहीं किया जाता है। Now let's look at some key aspects which are still missing. आज सिस्टम में निक्षय पोषण योजना के दौरान हर माह पेशेंट को 500 रुपए तो मिलते हैं, पर वो इनफ नहीं होते। इसके अलावा और भी न्यूट्रिशनल और इकोनॉमिक सपोर्ट की बहुत ज्यादा जरूरत है। एक वर्कर को वर्क फ्रॉम होम फैसिलिटी के साथ साथ पेड लीव्स की बहुत ज्यादा जरूरत है, जिससे वो स्ट्रेस फ्री होकर अपना इलाज सही से पूरा कर सकते हैं। सेम चीज आप स्टूडेंट्स को भी स्टूडेंट लीव्स और फी रीपेमेंट फैसिलिटी की बहुत ज्यादा जरूरत है, जिससे फीस रीपेमेंट की वजह से जो रीपेमेंट मिली फीस एक स्टूडेंट को मिलते, उससे वो पैसे अपने इलाज लेने में खर्च कर सकता है। ना हम एक बार नजर दौड़ाएंगे कुछ ट्रीटमेंट अडरेंस टूल्स पे जो कि अवेलेबल है और कुछ चीजें जो अवेलेबल नहीं है। ट्रीटमेंट अडरेंस में पेशेंट को खुद ही अपना ट्रीटमेंट अडरेंस मार्क करना होता है, जैसे कि डायरी हो गया, एड्रेस मार्किंग चार्ट हो गया, और जिसमें आप पेशेंट खुद ही अपना एड्रेस मार्क कर सकते हैं। पर ये सिर्फ लिटरेट पेशेंट्स के लिए है। जो पेशेंट जिसको पढ़ना लिखना नहीं आता, उसके लिए स्टिल अपना एड्रेस मार्क करना एक चैलेंज है। हम मेडिसिन को मल्टीपल डोसेज में पेशेंट को स्प्लिट करके भी दे सकते, जिसमें एडीआर होने के चांसेस बहुत ज्यादा कम हो सकते हैं और पेशेंट का एड्रेस मार्किंग बहुत इंप्रूव हो सकता है। स्टिल इसमें फैमिली एंगेजमेंट और मेंटल हेल्थ सपोर्ट भी अभी मिसिंग है, जिसमें एक पेशेंट के साथ साथ उनके फैमिली मेंबर की काउंसलिंग होनी चाहिए, जिसके पेशेंट को एड्रेस पूरा करने में मदद हो सके और उसके मेंटल हेल्थ सपोर्ट भी उसे मिल सके। साथ ही में रिमाइंडर चार्ट, वॉइस मैसेज फैसिलिटी, वॉइस मैसेज रिमाइंडर, ऑन कॉल रिमाइंडर और ऐप नोटिफिकेशन के जरिए भी एड्रेस मार्क किया जा सकता है, जिसमें मिस कॉल एड्रेस मार्किंग फैसिलिटी भी अवेलेबल है। पर जो रीजन्स में नेटवर्क कनेक्टिविटी की प्रॉब्लम्स होती है, वहां पे ये फैसिलिटी उतनी ज्यादा इफेक्टिव नहीं प्रूव हो सकती है। साथ ही में एडीआर मैनेजमेंट टिप्स और ऑनगोइंग पेशेंट इंफॉर्मेशन और मोटिवेशन वीडियोस के द्वारा भी एड्रेस इंप्रूव हो सकता है। पेशेंट को सिर्फ ट्रीटमेंट की शुरुआत में ही नहीं, पर थ्रू आउट द ट्रीटमेंट अगर पेशेंट की रिपीटेड काउंसलिंग हो जाए, उसको इंफॉर्मेशन दी जाए कि उनको एडीआर कैसे करने, डाइट कौन सी लेनी है और सेल्फ मैनेजमेंट टिप्स, इसके बारे में अगर इंफॉर्मेशन दी जाए तो एड्रेस इंप्रूव होने में मदद हो सकती है। नाउ हम टेक्नोलॉजी का भी यूज कर सकते हैं, जिसमें ई मेडिसिन बॉक्स भी अवेलेबल है। पर बहुत सारे पेशेंट जहाँ पे हम छोटे इलाकों में रहते हैं, जिनके घर बहुत ज्यादा छोटे होते हैं, वहां पे दिक्कत होती है कि उनको वो मेडिसिन बॉक्स रखने की जगह नहीं होती। तो ये एक सबसे बड़ा चैलेंज है। सर्वाइवर्स के एक्सपीरियंस शेयरिंग वीडियोस, जिसमें वो अपने सेल्फ मैनेजमेंट टिप्स शेयर कर सकते हैं, एजुकेशनल वीडियोस ऑन डाइट, मेंटल हेल्थ और स्टिग्मा, ये सारी शेयर कर सकते हैं। वो आज भी चीजें सिस्टम में मिसिंग है। अगर ये चीजें वीडियो फॉर्म द्वारा पेशेंट को दी जाए तो उसमें डाइट, मेंटल हेल्थ सपोर्ट, इसमें पेशेंट को बहुत ज्यादा मदद मिल सकती है। Now let's go through some key learnings from my presentation. Number 1, people and technology must go hand in hand. Number 2, patient support for adherence is not one thing, it is many. Third is patient support is equal to adherence, but adherence support is not patient support. हालांकि पेशेंट एडरेंस ये एक पेशेंट सपोर्ट का हिस्सा है। पेशेंट सपोर्ट में बहुत सारी चीजें कवर होती है, मेंटल हेल्थ सपोर्ट, एडीआर मैनेजमेंट, डाइट से लेके हर एक चीज कवर होती है। बट एडरेंस में सिर्फ एडरेंस से रिलेटेड बात की जाती है। इसीलिए पेशेंट सपोर्ट इज इक्वल टू एडरेंस, एडरेंस सपोर्ट इज नॉट पेशेंट सपोर्ट। टेक्नोलॉजी डज नॉट चेंज द इंडिविजुअल्स कॉन्टेक्ट। फोर्थ, patient information and access will improve self management. And last but not the least, stigma, mental health, gender remain key address constraints. Thank you so much for inviting me to speak at India TB Summit.
Hello, my name is Mona Ankshal, and I'll be discussing how we can leverage novel tools to improve TB treatment adherence. It's first important to recognize that current recommendations and guidelines have now prioritized daily treatment 7 days a week for a minimum of 6 months. This long duration of TB treatment means that patient support is crucial for successful completion of therapy. Current guidelines therefore acknowledge the need for case management as well as health education and counseling that should be provided to all patients in order to optimize treatment adherence. When thinking about treatment adherence, I like to distinguish the concepts of treatment monitoring from treatment support. There are many reasons to monitor treatment, which includes documentation of adherence. There's no current biomarker for microbiological cure of tuberculosis. Successful treatment is therefore defined in part based on microbiological, radiographic, and clinical endpoints, but also based on the completion of treatment, which includes ingestion of a pre-specified number of treatment doses over a 6-month treatment duration. Real-time monitoring and documentation of adherence has the benefit of not only allowing clinicians to know how much treatment has been taken, but also allows the delivery of adherence interventions which might support individuals' treatment adherence. There are many different interventions that can be considered to improve patients' treatment adherence. These are quite difficult to study in traditional randomized or controlled trial format, and this is because the optimal interventions that achieve maximal benefit are likely to require tailoring to individual circumstances. The data for treatment adherence interventions is relatively mixed, but current guidelines acknowledge and support the usage of tracers, material support, digital medication monitoring, psychological support, as well as education as means of actually improving treatment adherence by overcoming various barriers that patients may be experiencing. It can sometimes be challenging to identify issues that are coming up related to treatment adherence. And that is where approaches to treatment monitoring can be used to allow for real-time determination of a patient's treatment adherence. Traditionally, we use directly observed therapy, often in the home or in the healthcare facility. But increasingly, new approaches that are more patient-centered have become available. Video observed therapy, for example, is now incorporated into current guidelines as a replacement for in-person DOT when it is available. Overall, the usage of observation is still preferred to self-administration, in part because it allows for real-time monitoring of treatment adherence and the ability to intervene with individualized treatment adherence interventions when adherence becomes worse. Here you see a schematic of video observed therapy, which typically includes a mobile smartphone component that allows patients to record themselves ingesting medications. The smartphone application, as shown here, can also have ancillary interventions such as daily reminders, as well as the ability to capture clinical symptoms and side effects, which can help the patient care team to support the patient in their treatment course. The different pieces of information collected by the mobile application are typically transmitted to a secure portal, which can be viewed by the healthcare professional. Video observed therapy can be implemented either in a live streaming format where patients are in direct communication during a live communication event with the healthcare provider, or asynchronously, in which case the patient records themselves, but then the healthcare worker observes and verifies treatment at a later date or time based on the recording. Several lines of evidence are now available that support the idea of electronic DOT or video-based therapy. In 2 randomized trials, electronic DOT was found to be very similar to in-person DOT in terms of being able to verify Monday to Friday treatment doses. In one study, video observed therapy was superior to in-person DOT. We have found similar circumstances in our local setting, and we have also conducted feasibility studies in a variety of settings, including in Pune, India. One of the benefits of video observed therapy with the advent of daily treatment is that it allows for monitoring 7 days a week. In a small pilot study in India, we found that we could document adherence for 86% of doses in 25 individuals when using video observed therapy. During the COVID era, we have found locally here in the United States that there has been an increased transition away from in-person DOT towards the usage of video observed therapy. Both before and after COVID, one of the transitions that we have noticed is that we are able to document adherence to a greater proportion of doses than was possible with in-person DOT, which typically was only Monday to Friday. By contrast, with video observed therapy, we are able to document treatment 7 days a week, and in some cases are able to verify adherence in more than 98% of doses. Overall, we have found that video observed therapy is more acceptable than in-person DOT, in part because video DOT is more private than in-person DOT and more flexible and takes into account patients' schedules and allows for treatment ingestion according to their own circumstances. When one cannot implement observation as a means of treatment monitoring, other less intensive forms of treatment monitoring are also possible using new digital health interventions. SMS or telephone call-based systems such as 99 Dots are now available, as are digital pill boxes, which can document each time the treatment is taken from the pill container. Also emerging are ingestible sensors, which allow for documentation of treatment after ingestion of medication, which has sensors that are built in. Overall, however, all of these are simply methods of monitoring treatment, and the act of monitoring is not inherently going to improve adherence. In sum, what I would like to suggest is that these new tools for treatment monitoring can and should be incorporated and connected to individualized plans for treatment support, which are now acknowledged and recommended in current guidelines. In-person DOT, video DOT, or digital medication monitors can be used to document treatment and identify situations in which adherence is falling to subpar levels. In such situations, individualized case management plans, which can include incentives and enablers, as well as other forms of support, should be considered to optimize treatment adherence. Thank you very much.
Hello everyone, I'm Devashri Lokhande, an XDR TB survivor and a fellow with SATB India, and I'm here to conclude this panel on TB treatment, access and strategies, voices from researchers and the field, where we had excellent presentations from speakers all over the globe covering this essential topic, which is a key issue to ensure equitable access to TB treatment and patient support. Dr. Monank highlighted the need for patient-centered approaches for the management of TB, prioritizing of patient support tools to ensure treatment access, and the need for novel adherence tools to enhance treatment monitoring. Dr. Kelly throwing light upon the prevalent TB treatment pathways being followed globally and highlighting areas where an innovation and an overlay of supplementary patient support is required, and how it can be ensured to make the patient experience more comfortable. We had Himanshu, an MDR-TB survivor and patient advocate from India, sharing his journey of overcoming TB, particularly how he was able to access treatment from the private sector in India. We also had Yashwant, an MDR-TB survivor and patient mentor from India, sharing his learnings from his own TB treatment and from stories of patients whom he has interacted with, revolving around the need for patient support tools, what these tools are, and adherence tools, which are presently being followed in the public sector treatment cascade in India. Thank you all for your valuable inputs to make this meaningful discussion, to highlight just how important it is to put patient support at the center of the TB treatment plan at every step, and how it directly and positively impacts TB treatment access and quality, helping us to defeat TB. Thank you. I hope I join you all at the live Q&A.
Good evening. Okay, well, welcome to the India TB Summit 2022, and I think you've heard a great setup of important conversation and some really great insights from our panelists. As you can see here, we have Dr. Manang Shah, and we would love to start with some Q&A. And we have Yashwant and Ashna also on our panel. Welcome, welcome. So I think my first question will go to Ashna, and love to hear your perspective. There's a lot of focus on adherence, but is that possible without patient support and literacy in treatment? How can we bring these issues into the dialogue?
Thank you so much for that. So before I get to the questions of patient education or literacy, what I really want to talk about is the important element of also choice, which is that there are various ways to sort of comply with your TB medication. And TB, typically, you tend to take more than just a couple of pills. So making sure that you're taking all of those on time and at the same time each day, all of this is, of course, a task. That said, having this one-size-fits-all approach in terms of adherence is problematic because different patients may have different needs. So first, getting a sense of what patient needs are, what helps them sort of comply with their medication, that is critical. And two, of course, then empowering them to understand why this is important. Why do they need to be taking this medication? And how it can help them in the long run, what the trade-offs are despite the side effects. And then giving them that choice. I'll give you an example personally. When I was initiated on treatment by Dr. Datta here, who was a part of the summit, and my treatment was continued by a different doctor, Dr. Sharma. Both of them told me that these are my options. I can either opt for DOTS, or I could continue to take my medication on my own. And this is how, if I was taking it on my own, this is how I could schedule it and make sure I don't miss things. And I was comfortable with a sort of self-regulatory approach. So that's what I went with. But that's also because my doctors took the time to really explain that to me, to assess my needs, to assess my health literacy levels, and then recommend something in line with that. So allowing for that, the choice and then options in adherence is very important. And then educating patients about what each choice means and how each choice can help. And then letting them choose what works for them. Because at the end of the day, it's the patient that has to take the medication, and it has to be through a technology that really does work for them and is easier to do for them. And it's not just an add-on or more of a burden along with everything else that they're already dealing with while they have TB.
Yeah, incredibly important, Ashna, and thank you for really emphasizing the importance of a patient-centered approach where you have choice and can be empowered to make important decisions about how best to take your medicines and to really understand the why and how. And so we'll sort of talking about adherence. Manang, could you say more about the adherence tools and how do we economically support these tools? It seems that a lot of times that aspect does not get supported in programs. And of course, there is a cost to these. And so I'd love to hear your thoughts on that front.
Yeah, thanks, Amita. I'll start by just echoing what Ashna said, which I think is the center of all of this, which is that it's important to consider the patient perspective and what does the patient actually need and what will actually be helpful, because and it ties into the economics as well, because the one-size-fits-all approach often means employing resources in ways that that are not actually effective, and sometimes even stigmatizing or even creating barriers to care. And so trying to design things that are patient-centered, I think, can be much more economically viable. And we've seen that in our own setting, in that we've made usage of digital technologies in particular, which, while initially there may be some upfront cost to investment to purchase things like video observed therapy services or platforms, or even other digital technologies such as smart pill boxes, in the long run, these tend to be more cost saving and certainly cost effective when thinking about value for money. And the reason is because it's quite costly to employ traditional DOTS programs, particularly when you're focusing on in-home or in the community-based DOT. The costs related to the labor involved, but also just the coordination of such programs is relatively high, whereas technology costs increasingly have been coming down. The second piece is that, and it all ties back to having a patient-centered approach, is that if we can support patients up front with the most effective individualized strategies possible, it tends to lead to better patient outcomes, better patient satisfaction, and that, of course, has public health benefits because it leads to less treatment relapse, less treatment failure, less development of drug resistance. And so I think part of what policymakers need to be considering is the long-term costs in conjunction with the immediate budgetary impact. And I know that's challenging as a person that has to deal with these budgets myself. It's very hard to build in the future cost savings compared to what you have to pay right now upfront. But in our own setting, you know, we actually made the decision now more than 5-6 years ago to largely move over to a patient-centered approach so that we basically find out what does the patient actually need. And that reduced our in-person DOT costs, and we invested in video observed therapy. And certainly in the era of COVID, that actually led to in some cases, increased treatment adherence and treatment monitoring because we weren't as impacted by lockdowns because we were still able to monitor and support adherence. And ultimately, we've found a relative cost saving, even though we lost different human capacity because of changes in task shifting and things to the COVID response. So I think the key is to think broadly about those costs and to try to think strategically in the long term about what's going to be best for the patient.
Yeah, no, that's really, really important, and it, as basically you're saying, it can be done and should be done, and can be very very valuable on many fronts. So I'm going to pass over to my co-moderator Debashree, who will ask the next series of questions. Oh, she might be having connectivity issues. In which case, I'm going to ask Yashwant. So, Yashwant, can you speak more to your experience about what it was like to get TB treatment in the city of Mumbai and what kind of support you received, and sort of comment specifically on the mental health aspects of your treatment, support that you did or did not receive, and what can be done better if you feel that way about it.
Thanks for it. Am I audible? Okay. So basically मैं उन बातों पे बात करना चाहूँगा जो हमें नहीं मिली जब हम ट्रीटमेंट पे थे. बेसिकली एक पेशेंट जब इलाज ले रहा हो तो मेडिकल पॉइंट ऑफ व्यू से मेडिकल स्टाफ तो आपकी काउंसलिंग वगैरह कर ही रहा है. इसके अलावा कोई निजी जिंदगी में उनकी कोई तकलीफें होती उसके बारे में भी काउंसलिंग करने की बहुत जरूरत है. तो ये बातें सिर्फ एक टीबी सर्वाइवर ही समझ सकता है. इसीलिए सर्वाइवर लेड पेशेंट सपोर्ट ग्रुप, और उसमें एक अगर टीबी एक्सपर्ट हो उन पेशेंट सपोर्ट ग्रुप्स में, तो जो ट्रीटमेंट एडहेरेंस है वो इम्प्रूव करने में पेशेंट को और भी ज्यादा मदद होगी. साथ ही में न्यूट्रिशनल और इकोनॉमिक सपोर्ट जैसे सर ने बात की वो भी अगर मिले तो और एडहेरेंस इम्प्रूव करने में मदद हो. मेंटल हेल्थ एक टीबी डिपार्टमेंट में अनटैप सेगमेंट है जिसके बारे में ज्यादा बातें नहीं होती. जो भी साइकेट्रिक काउंसलिंग होती है पेशेंट्स की वो सिर्फ 10% है. इसके अलावा 90% हम ये चीजें कर सकते हैं. पेशेंट को उनकी जो निजी जिंदगी में चैलेंजेस आते हैं उनको अगर सिंप्लीफाई कर दिया जाए, साथ में उनको ये आर्ट ऑफ थिंकिंग बता दी जाए कौन सी सिचुएशन में कैसे डील करना है. साथ में काउंसलिंग के वक्त उनके सिर्फ बातें ही ना कही पर उनके प्रति एक अच्छे वाइब्स दिए जाए, एक पॉजिटिव वाइब्स उनको दिए जाए, तो उनका मेंटल हेल्थ कम होने में मदद हो सकती है. मुंबई नहीं, आज देश के तमाम शहरों में नेगेटिव एनवायरनमेंट है. सोशल मीडिया हो, चाहे घर में हो या उनकी निजी जिंदगी, हर जगह नेगेटिव एनवायरनमेंट है. इसमें उनको पॉजिटिविटी की थोड़ी सी झलक दिखानी. इसलिए जो काउंसलिंग करते हैं उनके तरफ पॉजिटिव वाइब से बात कर दी जाए तो उनको मेंटल हेल्थ काउंटर में मदद होगी। साथ ही में उनके फैमिली मेंबर्स को, केयर गिवर को भी बात बता दी जाए कि पेशेंट के साथ में कैसा व्यवहार करना है। साथ ही में सोसाइटी में भी एक अवेयरनेस कैंपेन्स की जाए कि एक पेशेंट के जब ट्रीटमेंट लेता है तो उसके क्या-क्या चैलेंजेस आते हैं, उसके साथ कैसा व्यवहार करना चाहिए। अगर उससे गलत व्यवहार किया जाए तो ट्रीटमेंट अपना बीच में भी छोड़ सकता है। इस तरह के अवेयरनेस कैंपेन्स की जाए तो ये मेंटल हेल्थ में भी पेशेंट को बहुत ज़्यादा मदद मिल सकती है। थैंक यू।
बहुत ही अच्छा, बहुत इम्पोर्टेंट बात आपने अभी भी बताया। तो now changing back to Manak, I don't see Dr. Dooley here, but interested in your thoughts about treatment shortening. So we've seen some very exciting new trials, even including one that just came out yesterday for children, looking at going from 6 months to 4 months, both for adults and children. And obviously, there are several studies also that have been recently published and or ongoing for really shortening MDR TB treatment with all oral regimens down to 6 months. Can you speak to how do we get these regimens adopted in India and get them more accessible so that we can have the benefits for a much larger population that really needs them?
Yeah, thanks, Anita. I think this is a question we're all wrestling with in India and in the global community. There are both logistical challenges, and then there are also a number of other downstream challenges, including physician and patient education. I was starting with the physician perspective. Many doctors are still hesitant to try something new when they've been using one strategy for a long time. And so being able to disseminate this information very effectively is going to be part of the process. Many experienced TB clinicians, they know how to react to side effects, for example, with the standard first line regimen. There's less experience with some of the newer drugs. And building that comfort at a provider level is going to be part of the equation. The second is that patients are going to have to be part of the discussion, of course, in part because there are trade-offs between the longer regimens and the shorter ones. And I think that the way to move forward is going to be allowing patient choice, as others have mentioned as well. The shorter regimens are in fact shorter, of course, but they do have much higher pill burden as one example of one potential trade-off. And so it may not be a one size fits all, but I think we do always have to keep that in mind. And the last is that there's going to have to be advocacy at the policy and governmental level to make sure that there's both availability and reduced costs. At least in our setting, the cost of rifapentine in one of the treatment shortening regimens is almost 100-fold higher than would be paying for rifampin. And so when trying to scale that to particularly in a setting such as India, where the number of patients perhaps that might be started on the therapy is quite high, this will lead to a fairly substantial cost increase unless there can be price negotiations up front. And so I think that work has to be started now to try to help with the supply chains. One of the real challenges and concerns has been that we may in fact start people on these new regimens, but then run out of drug in the middle, and that would actually be even more problematic. And so I think that it's really exciting to see these new options, but we probably need to do some work to lay the foundation to ensure that rollout and scale up is successful.
Great. Well, thank you. Very important points, and I think we could certainly spend a lot of time in trying to figure out how best to advocate and identify both the political will, the ability to change policy, the drug pricing and financing, and obviously ensuring that there is, the regimens that have been studied are readily available. And there seems to always be that challenge that from the research to actual practice, the amount of time that it takes, and especially if things are evolving quickly, In fact, I was just sitting on a WHO guideline committee the last few weeks, and the challenge of programs adapting their guidelines to evidence as it comes up is not trivial. So since Dr. Kelly Dooley has just joined us as well, and we were just having a conversation about adherence and treatment shortening. Kelly, I'd love to hear your thoughts about how, what do you think is the priority for, really taking some of the recent research findings and, which regimen should we be really focusing on to kind of get rolled out into practice, and how do we do that in countries such as India?
Yeah, I mean, I think, well, in terms of treatment shortening, at least for drug-sensitive TB, if we now have a 4-month regimen, really for me, that is just a step on the path towards having something that is 2 months or 1 month or eventually 2 weeks, or can be given by injectables without having to come to the clinic frequently. So it's maybe just a step on the way to something that is really much easier for programs and easier for patients to manage. But I would say that right now we do have prevention regimens for prevention of progression from latent TB to active TB that are very short and can be 12 doses or 1 month of therapy. And so if there are ways to roll out those things at prices that are acceptable, then to just get rid of that whole iceberg of latent TB that's sitting there waiting to become the active TB that makes people sick might be a place to put some priorities. I know there are a lot of activists working on pricing of things, and certainly we are far from having rifapentine containing regimens be easily affordable in most settings, but hopefully there'll be some movement towards that in the relatively near future.
Great. Yeah, thank you. I think the issue of drug pricing and it really does inform access, and of course you need political will and policy change and between sort of pharmaceutical companies, government, and TB advocates to really help in the equation. I'm interested to hear from Yashwant. What kind of access आपका किस तरह से access मिला, जैसे ये जो regimen है नई वाले, आपको मिले कुछ नई वाले regimen मुंबई में?
जी, मुझे MDR TB हुआ था, तो वो जो पुराने वाला रेजिमेन था मुझे वही मिले थे, कैनामाइसिन एंड ऑल। नए रेजिमेन, अब शॉर्टर रेजिमेन उस समय पे नए थे, एक्सपेरिमेंटल स्टेज पे थे, तो मुझे वो नहीं मिल पाए।
Okay, thank you for coming. And Ashna, आपके पास जैसे XDR TB था, so you can answer in English. You said you were an XDR TB survivor.
No,
so did you have
MDR
access?
TB.
MDR TB survivor, pardon me. But did you have access to any of the new regimens when you were getting treated?
My case was before I came for my MDR TB diagnosis. I just been initially it was just TB, so I started treatment in Bangalore, and they had messed up my first line treatment. So they couldn't consider me for a shorter regimen, even if that was a possibility. So both Dr. Datta and Dr. Sharma, who then continued my treatment, they had to put me on the longer regimen with, I had amikacin instead of kanamycin, but injectables for 6 months and treatment for 2 years.
Got it.
So, yeah. Which
How do you feel? No, go ahead.
Oh, sorry. Which also brings us to the point about provider knowledge, right? So I've had both experiences. Initially, my doctor did not know as much, and I had to insist that I'm getting worse. And I asked for a referral, and I from Bangalore, I then went to Delhi because I could see that I wasn't responding well to first-line treatment, and he was changing my medication very frequently. He put me on levoflox, injectables during my first line, so that made no sense. But a lot of people do not have that kind of literacy. And if I was somebody who did not have that health literacy, I would have listened to this man and waited for 2-3 more months, by which point, it would have been worse. So provider sensitization also in terms of prescribing treatment in keeping with international guidelines, so that patients who then may have the opportunity to be on shorter regimens can be put on shorter regimens is also something that's relevant, in addition to making these regimens accessible also universally.
So just to follow up on that, how did you manage to gain your TB literacy? What kinds of things did you access, and how did you find out what was sort of the best way to treat TB?
Although I'm a lawyer by training, my interest was in public health and policy right from law school. So I had been reading up and familiarizing myself with health research and literacy even before I got TB. So by the time I got it, I knew enough about. So I didn't know, for instance, that there's extrapulmonary TB. I was lucky actually to have two incredible doctors later on from my MDR TB diagnosis stage who really took the time to sit with me and almost treat me as a participant in my care, not as a recipient of care. So I went with this shorter regimen research that was being tried in Bangladesh, and I asked why I couldn't be put on that. And instead of dismissing me or patronizing me, he actually walked me through the science, and he's like, this is contraindicated for you, and this is why. And so my doctors really helped. I had the privilege of also knowing what to access and where to read up, and enough literacy to also read through academic journals and research studies. And of course, survivors against TB, when I spoke to other survivors and their experience, that's how I came to know about survivors against TB actually, through my own experience when I was looking for more avenues to learn more about TB. So all of these, peer support and peer education, provider counseling, and of course, individually having the privilege to sort of be able to access different modes of knowledge helped me. But I come from an incredibly privileged position, so we can't just assume that everybody will, self-educate. We have to make the information available and easily accessible to patients in different languages, in languages that they're comfortable with and familiar with, and in ways that they can understand, not in academies or legalese that may be dense for most.
Well, great. Thanks for sharing that perspective, and incredibly important to sort of be doing a much better job of both provider sensitization education, systems education around best practices, and making people with cough or people who are presenting to the healthcare system to be more informed about the possibilities of what their diagnosis could be. I think there's also additional interest in just sort of really addressing what are the factors that sort of define, and I'm going to put this question to Kelly and then to Manak to also give some perspective around how do we decide what a drug regimen costs? What are factors that go into that? And, is there a role for either compulsory licensing or, developing agreements for defining where cost should be so that programs can afford it more readily? It might not be necessarily in your immediate realm, because I know you're both researchers thinking of new regimens and actually figuring out new ways to provide adherence strategies, but just be interested in your perspectives on this, because I think this is really such an important reason as to why we don't have a lot of these things readily translating into practice once we show that they work. Kelly?
Yeah, I'm guessing Manak will have a better answer about how to make drugs cost effective. I know that there are some drug companies or drug developers that have, when they in-license drugs to further study them, to get them closer to market, that they require that that those drugs will eventually be affordable. Whereas there are other drug companies that are still trying to make a profit from TB drugs, and we know that that at least for drug-resistant TB, that the drugs are never going to be profitable, that rather they need to be developed with the end user in mind, with the recognition that this is being done for public health rather than eventually for profit. So I think that's part of it, is sort of the contracts and licenses that are happening along the way as a drug is developing towards the market. Other aspects, I think also, I was going to ask about access to the monitoring that needs to happen with some of these drugs. So, for the BPAL regimen of bedaquiline, pretomanid, linezolid, that works really well, and people can be cured in 6 months, but having EKG monitoring along the way and having checking CBCs to make sure people are not becoming anemic and thrombocytopenic, and then liver function tests all along the way with pretomanid. These things become extra costs on top of the drug costs. And I don't know a lot about how that's calculated in to program costs and if those things are affordable. Manan, you'll know more about the costing and cost effectiveness of these things.
And no, thanks, Kelly. Sorry, I'm getting an echo. I think you actually highlighted a lot of the key aspects here. So maybe I'll take the second part of that first, which is that I think you absolutely have to consider all the monitoring costs. And that is certainly one of the barriers to implementing some of these newer regimens, both for drug sensitive and drug resistant TB. So that, for the new drug sensitive TB regimen, that means not monitoring, but it means having provisions for additional diagnostic testing for fluoroquinolone resistance, as an example. But for the EKG monitoring is absolutely a barrier to rolling out the new short BPAL regimen to the extent that people believe it needs to occur. And that's globally, both in resource limited and resource rich settings, because in the public sector, often we don't have access to those things. And so a lot of this really comes down to health system strengthening more so than even just the cost of a TB program. It's the fact that TB programs very often operate in a silo away from the rest of the health system and disconnected makes it very challenging, because a lot of these services may be readily available in a routine clinic, but is not available in a TB clinic. And then being able to have all that care coordination becomes quite challenging and quite costly. But in terms of the costing of the actual new drugs, I think you really highlighted it. It really comes down to, in my mind, the pharmaceutical approach to putting this on the market. As a really simple example, like even with BPAL, bedaquiline, now, even though it's been around for so many years, is still cost prohibitive even in our setting. I was just dealing with this yesterday. There's a patient we cannot get bedaquiline for. The insurance companies won't pay for it. They can't pay for it. The health department cannot pay for it. It's almost $50,000 to $70,000 per course for us, which is a huge amount. On the other hand, pretominid is like $15 or something crazy like that, even though it's also a brand new drug. And a lot of that has to do with the route that each of the companies took to putting it on the market in terms of having negotiated prices either in the public sector or in the private sector with insurance companies and things. So again, pretominant, we can actually order it and even have it available within a day. Within less than 24 hours, whereas bedaquiline usually takes us weeks and months sometimes to procure. I will say that some of this also has to do with the unique way in which new drugs enter the market, with the idea that we want to quote unquote preserve them. And so this is not just on the pharmaceutical companies. It also has to do with the way guidelines are written and the way the public sector implements. So if we go back 5 or 10 years now for when bedaquiline was coming on, the public health sector also really restricted its access and said, oh, we're not sure people are going to be able to use it correctly. We don't want to blow this brand new drug. That actually played into this. So the distribution scheme that was introduced for bedaquiline was meant to purposely in some ways be limiting, so that it would go through multiple channels of approvals. And I think the company priced it out accordingly, because they knew that, hey, we have this brand new drug, but the implementers are already telling us up front they don't want to implement it because they don't want to lose the drug. So they want to use it very selectively. So I think, I'm not a pharmaceutical developer, but I could imagine they priced it knowing that they were going to have a limited uptake. Whereas now with like pretominid, they know it's part of this new regimen that people are going to want it and want to roll it out much more broadly, and they probably priced it accordingly. And so I think it's a very complex situation, but it's one where the implementers also have to be, at the table to help the pharmaceutical companies understand how it'll get used, because that's going to impact how they price it.
That's fascinating. So really major differences in strategy and costing for two, well, one not so new drug, bedaquiline, and two with pretonomid. It's interesting because in India, the government program was the one that sort of was really pulling together the regimen access for bedaquiline, for example, in the private sector, particularly some places which had a lot of experience treating could not readily access the drugs or the regimen. So it is sort of interesting where the fear of worrying about a drug rollout could, either develop resistance or make it no longer available, sort of as part of the tension of the discussion as well around access and delivery. Ashna, I'd be interested in hearing more about what are survivors against TB doing to help increase access and delivery in the Indian setting. What are the sort of key points or thoughts about what can be done?
So a couple of things. To begin with, creating awareness about what the challenges are out there and why these longer regimens are so difficult to comply with is critical, because only then would we understand why access becomes that important. So having that sort of awareness, engaging with survivors, we do this frequently where we get survivors to talk about their experiences with longer regimens and how a shorter regimen would have helped them in many ways. That's one. Two is looking at other forms of sort of, we talked about pricing, right? And we've been, we've in our work and also through our TIs, we have been asking this, that we do have this mechanism of compulsory licensing. And as someone who's a lawyer by training, I can also say this, that one of the ways to regulate pricing for drugs that are life-saving and that should be accessible is for generic companies to be able to manufacture them, right, to prevent this evergreening of patents. So both of those things, and I can see that we're short on time, so I'm going to wrap up. But yeah, bringing the survivor perspective to the fore and looking for ways, different ways through law, regulation, policy, innovation to make these regimens accessible to all.
Fantastic, Ashna. Well, that's an important point to end on. And I want to thank our incredible panelists, Dr. Manang Shah, Dr. Kelly Dooley, Yashwant and Ashna, and my co-moderator, Debashree, who could not join, but was there in spirit, and you heard her comments. Really wishing you the best for TB Summit. We all have to be in this together against the fight to really make drugs affordable, accessible, and support patients in a very patient-centered manner to ensure that they have the best outcome possible. So thank you again to all of our fantastic panelists and for all the work that you're doing. Much appreciated. Take care.